a truly enriching and meaningful program. విద్యకు అధిదాత్రి అయిన శారదా నవరాత్రుల్లో ఈ నాలెడ్జ్ షేరింగ్ CME కండక్ట్ చేయడం అనేది చాలా సంతోషంగా ఉంది. డాక్టర్ మల్లేశ్వరి will start.
Hello, very good afternoon all of you, respected seniors and my dear colleagues. And without delay we'll start the program, otherwise it will be get delayed. And each session will go around 20 minutes. In that talk will go up to 15 minutes and later the 5 minutes for discussion. Be very much punctual in the time, otherwise it will be get delayed. Okay, without delay we'll start the session. For the first session, the chairperson is Dr. Sunil Kumar. Please sir, come on to the dais.
The organizing committee, it gives me immense pleasure to welcome
ఇంకొక చైర్పర్సన్ రాలేదు. ఎవరిని Srinivas sir, for the second chairperson, please come on to the dais sir. Dr. Lalita will hand over the books to the chairpersons.
ఫస్ట్ ది స్టార్ట్ చేయాలి. ఫస్ట్ ది రవీన్ ఇది ఊరినే సెషన్ అయిపోతానే ఇది చేయాలి. వేస్ట్
The first session by Dr. Ravindranath Reddy K. is an consultant endocrinologist in Vasavi Endocrine Clinic, Kurnool. His topic is approach to resistant hypothyroidism. Please welcome sir.
Respected teachers, seniors and dear colleagues, a very good afternoon to all of you. Sorry for my sore throat. Today I am here to speak few words regarding refractory hypothyroidism. I am Dr. Ravindranath Reddy, DM endocrinologist from Kurnool. So coming to hypothyroidism, which is the most easiest aspect of endocrinology to be treated, coming to the refractory hypothyroidism, it is a very dicey part in the management and very difficult to treat part of endocrinology. First, I will be discussing in the following outline. Let us speak about definition of refractory hypothyroidism, what is the prevalence, and brief about a case scenario and causes of refractory hypothyroidism and how do we approach a case of refractory hypothyroidism. Clinically and biochemically, refractory hypothyroidism is defined as clinical evidence or biochemical evidence of hypothyroidism, that is serum TSH more than 4.5 milli-IU per ml following a 6-week interval after the last dosage increase, or despite increasing the dosage more than 2 microgram per kg body weight is also defined as refractory hypothyroidism. So what is the prevalence of this? The prevalence across various studies ranges from 15 to 30%. From USA to including China and one of the Indian studies, the prevalence is very high. So prompt diagnosis and management of this condition is very important. Coming to a case scenario, this is the last case which I have seen few weeks back. She's a 24-year-old female, primary hypothyroid for last 5 years, and she is on treatment with 150 microgram of levothyroxine. However, her weight is only 54 kilos. TSH was repeated twice, which is more than 50 milli-IU per liter. Total T4 is low normal, and T2 antibody was positive. Patient was claiming complete compliance to medication. So this is a pure case of refractory hypothyroidism. So how can we further diagnose and approach to this case of refractory hypothyroidism? Coming to the physiology of levothyroxine absorption, levothyroxine, it is diluted in the stomach and it is absorbed primarily in the jejunum part. Absorbed in the jejunum, and we require MCT 8 and 10 transporters for the absorption, and only 70 to 80% of this ingested dose is absorbed. This inter-individual variability in the GI absorption is a specific reason why different patients of same age and same weight require different doses of levothyroxine therapy, and these are various factors which will affect absorption process. These are like gastric juice pH, viscosity, type of the excipients which are used in the preparation of levothyroxine tablets, and also the ingredients. For example, this tablet form of excipients, they require lower gastric pH for dissolution, whereas the gelatin and glycerol containing tablets require less. However, these are not available in India. Coming to causes of refractory hypothyroidism. So why do patients develop refractory hypothyroidism? One, there is decreased bioavailability of levothyroxine, or second cause will be there is increased need for levothyroxine therapy. First, coming to decreased bioavailability, it is either because of poor adherence or non-compliance, or repeatedly changing levothyroxine preparations, or there can be GI malabsorption features, or any intramural factors or luminal factors like any interference with food and medications. Coming to the increased need for levothyroxine therapy, any rapid change in the body weight, drugs which increase the metabolism or excretion of levothyroxine, and also pregnancy. These are the few states which will increase the need for levothyroxine therapy. Other uncommon causes include genetic variations in type 2 dehydrogenase, antithyroxine antibodies, and also inappropriate tablet storage. So these levothyroxine tablets require storage at nearly 20 to 30 degree temperature, and they should not be in the moist places. Any storage in these places will damage the tablet and will hamper the absorption of levothyroxine. Coming to various drugs which will interfere with thyroxine, most commonly used medications like ferrous salts, calcium salts, and antacids like proton pump inhibitors, they cause physical interaction with thyroxine and decrease the absorption. And also multiple anti-epileptic drugs like phenytoin, carbamazepine, valproate, and also some estrogens, tamoxifen, when they are on hormone replacement therapy, these can also increase thyroxine metabolism, and they can lead to refractory hypothyroidism. And there are also some drugs which will act through TSH pathway. Drugs like phenothiazines, haloperidol, they increase antidepressants, they will increase TSH, and they will cause decrease in the tablet dosage, whereas corticosteroids and metformin, they can decrease the TSH acting at the central level. So these are the pictorial view where we can have multiple drugs which will interfere at the gastric part of levothyroxine absorption under the intestinal absorption of levothyroxine. Next, coming to the concomitant GI condition. So as I already mentioned, patients suffering from any GI malabsorption syndromes can also present with refractory hypothyroidism. So this is a study where they have seen prevalence of concomitant GI conditions in hypothyroid patients, and the prevalence was nearly 52%. So what are the various diseases? Usually occult conditions like lactose maldigestion, celiac disease, or the H. pylori infection are usually the occult GI conditions which will be associated with hypothyroidism, and they can lead to refractory hypothyroidism. However, short bowel syndrome, biliopancreatic diversion, Roux bypass, cirrhosis of liver, these are clinically evident diseases, and these can also lead to refractory hypothyroidism. So coming to our case scenario, we have seen a patient of refractory hypothyroidism. Then how will we confirm our diagnosis? First, we need to confirm the diagnosis of refractory hypothyroidism. For this, markedly elevated TSH levels with low or low normal thyroid hormones. Then we have to rule out any antibody interference, assess. So coming to assay point of view, there is a very important heterophilic antibody interference which can increase or decrease the TSH measurements, and also TSH secreting tumors or thyroid hormone resistant syndromes. There will be peculiar pattern of thyroid hormone reports through which we can differentiate these conditions, and we can stick on to the diagnosis of refractory hypothyroidism. Once confirmed, then we have to see for the compliance, which is the most common reason for refractory hypothyroidism. After ruling out compliance, check for the patient's medication bottle and tablets for dosage and also brand. There have been multiple brands of levothyroxine available, and each brand has different bioavailability. So for example, the most commonly available Thyronorm, which is from Abbott, and also the Mankind Thyrox, and also the L-Troxin one, these are the thyroxine preparations which have the highest bioavailability when compared to other preparations. So checking patient's dosage and also brand of thyroxine is very important. And also check regarding the ingestion history. At what time does the patient take? What is the gap with food? So we suggest at least a gap of more than 45 minutes gap with the food and intake on the empty stomach. And also we'll advise the patient to take any medications with the gap of nearly 3 hours, like proton pump inhibitors or any metformin or ferrous or calcium salts. There should be sufficient time gap between the ingestion of thyroxine tablet and these medications. Later, we will check regarding any patient having any drugs which increase the thyroxine metabolism or excretion. And finally, we'll perform a levothyroxine absorption test. So what is this levothyroxine absorption test? It is a clinical test to estimate thyroxine absorption. So this has mainly utility in patients who have unexpectedly high T4 requirements. So what is this test? In a fasting state, we'll give 600 microgram or 10 microgram per kg body weight of levothyroxine, and free T4 levels are measured every hourly for 5 hours. After, if there is mean increment in free T4 levels from baseline to 3 hours by 0.8 nanogram per deciliter, then we can rule out compliance as we can say this patient is not compliant to therapy. So if we are suspecting refractory hypothyroidism and patient is claiming compliant, we can do levothyroxine absorption test. So in our patient, this young female, which I have discussed, who is on 3 microgram per kg body weight, was claiming compliance and gap of 1 to 2 hours, and using same brand for last 2 years, not on any interfering medications. I performed a levothyroxine absorption test. In this test, we can see the baseline free T4 is 0.8 nanogram per deciliter, but after 4 hours, it has increased to more than 1 nanogram per deciliter. So the report was 1.8 nanogram per deciliter. This indicates that patient is not having any GI malabsorption state regarding levothyroxine tablet, and non-compliance was the main reason in this patient. So if post levothyroxine absorption test, when the free T4 levels are very low, then we have to suspect GI malabsorption. In that case, with our help of our gastro colleagues, we can rule out individual causes of GI malabsorption like lactose maldigestion, H. pylori infection, and then we have to rule out the celiac disease, which is usually very occult type of disease, and also some patients with chronic pancreatitis also has to be ruled out. So through this approach, we can rule out any malabsorption syndromes. And to finally conclude, compliance is the most common issue when we interfere with this refractory hypothyroidism patients. Education regarding timing of ingestion and interfering medications is very essential. Levothyroxine absorption test is helpful in ruling out the GI malabsorption. Levothyroxine malabsorption can be only manifestation of some GI diseases. Even after extensive workup, cause cannot be identified in 10 to 15% of cases, and they may require very high doses of levothyroxine therapy to normalize TSH. Supraphysiological replacement of levothyroxine is majorly detrimental to bone health and also the aging cardiac issues. So with this background, if any patient of thyroxine therapy, if they miss a pill on one day, they can take 2 pills on next day. Thank you. That is daycare test, ma'am. Normally, patient will come to OPD early in the morning, fasting state. We will give 600 microgram or 10 microgram per kg body weight of levothyroxine, and every hourly we'll be taking sample for free T4 testing. So then after 4 hours, we'll be measuring for all the samples. We need to measure free T4 levels. It's available. Matlab, we can do it on a daycare basis. Sir. No, sir. Minimum 3 hours, sir.
Hello.
Sir, we can take only with the preparation is gelatin based.
Sir.
Gelatin based, if the pH is low also or high also, doesn't make much difference. The
Yes, sir.
conventional, the conventional tablet,
Tablet
form, we
will
have
be-
a problem.
Yes, sir.
With
Yes.
the gel.
It is gelatin based, no issue.
no issues.
Can you mention the brands with low bioavailability of thyroid?
Low bioavailability, multiple brands
so
has
that
been there, sir.
we cannot prescribe them.
Usually they have good absorption, but majority of the brands they have issue with absorption.
Which should be avoided.
Avoided, we cannot say exactly, sir, but the ones which have best absorption is the one we can mention, but we need to do individual study for that with various brands, so that won't be good to mention directly.
Hi, this is a general question. How
Sir.
frequently you have to test for thyroid?
Yes, sir.
Not
So-
in resistant cases, general.
Yes. Sir, if any patient with hypothyroidism, the patient is on full dosage, based on his weight. He has reached the 1.6 microgram per kg body weight of the dosage, and age is more than 50 years, postmenopausal females, then we can increase the frequency of measurement to every 6 monthly. Whereas young reproductive age females planning pregnancy, we prefer measuring every 3 months or immediately after conception. And also young males also till 40 to 50 years of age, we prefer measuring up to every 3 monthly TSH measurement, at least only the TSH.
I'm a urologist. In infertile cases,
Sir.
I'll check whenever there is semen count less than 10 millions.
Yes, sir.
I'll order only TSH. Is it sufficient?
No, sir. We need to see T4 and T3 also. At least total T4 is essential to rule out secondary hypothyroidism.
Thank you.
In subclinical hypothyroidism,
Sir.
Is it must to send TPO antibodies? TPO antibodies?
Yes, sir. Not must, sir. So the first thing, while diagnosing subclinical hypothyroidism, we have to see the clinical context. Why did we test for hypothyroidism? So if patient is having any disease, suspicious of hypothyroidism or any other, sir mentioned infertility issues or any other issues which have association with thyroid, so then we prefer measuring TPO antibodies. And also in young individuals, we prefer measuring TPO antibodies because we need to follow up those cases, and whenever TSH crosses more than 10, they need to be treated. And also infertile females, especially, or males, if TSH is in the range of 4 to 10, to rule out to exclude thyroid as a cause of infertility, we will treat them with thyroxine and we will do TPO antibodies, because presence of TPO antibodies will also give us a clue that there is autoimmune etiology in that patient, and we need to look at other autoimmune diseases also, like pernicious anemia or autoimmune oophoreitis, which can also be there and which can lead to premature ovarian failure, especially in females.
Thank
Yes, ma'am. Yes. The weight loss will reduce the dose of thyroxine therapy. It helps. It helps.
Sir, how do you treat refractory hypothyroidism once it is established, like all malabsorptions are all, there is no evidence? I have seen 2 cases, young female, adults and girl, presenting with refractory hypothyroidism. She was using 200. Okay. For that age, I cannot extend more than that. So, how I have referred her to endocrinologist, but what are the other modalities? If the pituitary I have seen, I will look out for pituitary also. It was not, there was no adenoma. So, malabsorption I have not seen, but clinically she was having gross hypothyroid features even on treatment. So, what are the other things which we can think of
Usually non-compliance will be the issue, ma'am, because patients might be missing or will not be mentioning. So simply to rule out malabsorption, we can do levothyroxine absorption test for that girls. After levothyroxine absorption test, if free T4 is coming to normal, then that will clear-cut mention that patient is not having any GI malabsorption. Then we have to only think about compliance. If that is an issue, we can give her weekly dosage of levothyroxine therapy. For example, if she is on 100 microgram per day, we can give her 7 tablets of 100 microgram every week. We will call that patient to our clinic. In front of us, we will ask her to ingest 7 tablets at a time, and they have to stay for at least 1.5 hours with us, and then we will let them go. Actually, the regarding combining T3 with T4 therapy is still under research, and there are some studies which have clearly mentioned there is a benefit, and also some studies which have shown detrimental effect both on the bone and also cardiac activity. So which has to be so combining T3 therapy, there have been some peculiar patients. When we measure the thyroid profile, those patients will be having low T3 values. Despite normal TSH and T4, they will be having low T3, and they will be symptomatically hypothyroid. Constipation or generalized malaise, fatigue, those patients, if we add T3 therapy, clinically they have improved. But routinely well-controlled hypothyroid patients, asymptomatic, there is no role of adding T3, ma'am.
Okay. Thank you.
Sir, is fasting always mandatory for testing thyroid?
No, ma'am, no.
We can test without fasting.
Without fasting, if we need to measure total T4, patient should not take thyroxine on that day. If we want to measure total T4, but for TSH not necessary. Fasting is not necessary, but preferentially we'll ask to give sample at same point of day at every visit. For example, 8 to 10 o'clock or 8 to 12 in the morning, every visit we'll measure at the same time. If in the evenings also, every visit we'll measure at the same time. That would be suggest no problem will be there in the time point also.
Thank you.
Thank you very much. So questionnaire is done, so we'll move on to the next session.
Sure. Thank you everyone.
Congratulations, Ravindra, you completed within time. Congratulations.
And we request all the speakers to stay back for the inauguration program so that we can present the mementos during the inauguration session. Meanwhile, we would like to hand over the Dr. N. Apparao Family Security Scheme check of 19 lakhs to the Srimati Yashoda Magaru, wife of Dr. R. Chandrasekhar Reddy Garu, member of IMA Nandyal. So, I request Dr. Madhavi to bring her to the stage. I request Dr. Masudan Rao sir, Panil, State IMA Joint Secretary, to come onto the dais, and Dr. Vasudha. Dr. R. Chandrasekhar Reddy garu Nandyal IMA branch సభ్యులుగా ఉండి FSS స్కీమ్లో సభ్యులుగా ఉన్నారు. వారికి last year వారు he passed away last year. So IMA FSS memberగా FSS scheme నుండి 19 lakhs చెక్ని we are supposed to hand over the checks in the usual if any program is being conducted in the branch, we are supposed to give it in the branch so that other members, after seeing this presentation of the checks, they will become members of the scheme. So we have asked her to come over to Nandyal, and thank you, madam. She came all the way from Tirupati to receive the check. Once again, we thank you for coming and accepting our check. Thank you, madam. I request the AMS and Women Doctors Wing organizers to continue the CMA program.
Thank you, Ravindranath sir, for an elaborate presentation about causes of refractory hypothyroidism. Now I warmly welcome the next speaker, Dr. Varadaraj sir. who is the first senior neurologist in Nandyal, senior consultant at Vardarajan Neuro Care Center. And sir's topic is a rare but treatable acute encephalopathy in a person with diabetes and alcoholism. I request Dr. Sunita and Dr. Kirti to chair the session.
Good evening, everyone. Respected seniors, my dear colleagues. Thanks to IMA Nandyal for giving me this opportunity to present a rare case, but a routine case, and it's a treatable emergency. Every general practitioners must know about this type of cases. I am Dr. Vardharaj, neurophysician, Nandyal. A 35-year-old man who is a known diabetic and alcoholic. He presented with dullness, decreased activity, and not taking food properly since a week duration. Just one day prior to admission, he had altered sensorium with breathlessness. He presented to emergency room. He was found to have very high blood glucose levels with urine ketone bodies and metabolic acidosis in ABG. So naturally a diagnosis of DKA, diabetic ketoacidosis, was established. He was intubated in view of poor GCS, that is 7, and his sugars were controlled, corrected gradually, and acidosis was corrected. But still, his unconscious state was not improved. Then they referred to neurologist. When I examined, patient had GCS of E3, M4 and VT. And there is one important neurological finding on examination, that is ophthalmoplegia and Alzheimer's. This is the brief clinical summary of this patient. With this background history and examination findings, the differentials I considered clinically were whether this patient had developed any DKA related cerebral edema, maybe because of rapid correction of hyperglycemia or persistent hyponatremia or administration of sodium bicarbonate. So any DKA related cerebral edema or Wernicke's encephalopathy or hepatic encephalopathy, or he is in alcohol withdrawal syndrome, that is delirium tremens, or is it a stroke? With this, I subjected the patient to, among these, most likely possible diagnosis is clinically Wernicke's encephalopathies. There is triad to diagnose Wernicke's encephalopathy we read when we were in undergraduate days. That is, we remember this triad as GOA, G-O-A, GOA, that is global confusion, ophthalmoplegia and ataxia. If this triad is there, we can diagnose Wernicke's encephalopathy. Among these, patient had altered sensorium, ophthalmoplegia, but ataxia is not there because he is in altered sensorium state. With background history of alcoholism and poor food intake and elevated blood sugar levels, so likely possible diagnosis is Wernicke's encephalopathy among all these. It is added diagnosis to DKA. there is this patient fits into Keynes criteria, which is established in 1997 to diagnose Wernicke's encephalopathy. If 2 among 4 features are there, we can diagnose Wernicke's encephalopathy clinically also. One is evidence of dietary deficiency or malnutrition, as evidenced by BMI less than 18, chronic alcoholism, persistent vomiting, or any risk factors like pregnancy or post-bariatric surgery. And second one is oculomotor abnormalities like nystagmus, gaze palsy, complete ophthalmoplegia, and cerebellar dysfunction in the form of ataxia. Altered mentation in the form of confusion or unconscious state or mild memory impairment. So among these, patient had dietary deficiency, oculomotor abnormalities, and altered mentation is there. So this patient fits into Keynes criteria. So a clinical diagnosis of Wernicke's encephalopathy was established. The sensitivity of this Keynes criteria is 85 to 100%, but with just classic triad it is only 23%. This patient was subjected to MRI. These are the MRI findings. See, this is a flare sequence. There is altered signal intensity in the brainstem tectal plate. This is pons. See the pons in the tectal plate. In the periventricular region, there is altered signal intensity, hyperintense signal in the tectal plate, and even in the midbrain periaqueductal region. In the periaqueductal region, then including mammillary bodies also, and thalamus also, mammillary bodies and medial thalamus especially. This is classical for Wernicke's encephalopathy in alcoholics. So MRI findings are classical for Wernicke's encephalopathy. Other differentials were ruled out because in decay-related cerebral edema, there will be diffuse cerebral edema where gray matter and white matter differentiation will not be there. In hepatic encephalopathy, there will be symmetrical T1 hyperintensity in globus pallidus with the T2 flare hyperintense signals in insular cortex and cingulate gyrus. Strokes, especially artery of Percheron infarct and deep cerebral venous sinus thrombosis, mammillary bodies are not involved in these cases. And other differentials to be considered based on MRI findings are metronidazole toxicity and leak disease. Metronidazole toxicity, dentate nuclei and other cranial nerve nuclei are get involved, and splenium also involved. In leak disease, mammillary bodies are not involved. These are the decay-related cerebral edema where there is no differentiation between gray matter and white matter. And in hepatic encephalopathy, typical T1 hyperintensity involving globus pallidus and insular involvement. In artery of Percheron infarct, where both thalami get only single arterial trunk from one of the posterior cerebral arteries, thalami gets involved, but mammillary bodies are not involved. In deep cerebral venous sinus thrombosis, associated superficial sagittal sinus thrombosis and absence of flow signals in the deep cerebral veins, and basal ganglia involvement also there. And metronidazole toxicity, dentate nuclei involvement, classical and splenium. And leak disease, this is a pediatric mirror to adult Wernicke's encephalopathy. So both they will have same clinical features, same radiological features, only age is different. But in this, how to differentiate leak disease from Wernicke's encephalopathy apart from age? Here, basal ganglia are more involved and mammillary bodies are not involved. The MRI brain sensitivity for Wernicke's encephalopathy is 53%. Specificity is 93%. That means nearly half of Wernicke encephalopathy patient have normal MRI a negative scan cannot rule out Wernicke's encephalopathy. Sometimes Wernicke's encephalopathy patients have atypical presentations also, like cortex involvement, especially motor and sensory strips, and sparing mammillary bodies, and basal ganglia involvement, 6th and 8th cranial nuclei involvement, splenium involvement. But remember, symmetry is the rule in Wernicke's encephalopathy. So he was treated with simple thiamine supplementation parenterally. His unconscious level was improved. He was extubated. This is after extubation. After extubation, observe this patient has still having some attacks. I see he is swaying. Before that, GCS was only 7. So thiamine, the recommended thiamine dose for Wernicke's encephalopathy as per European Federation of Neurological Society is any suspected Wernicke's encephalopathy or manifest Wernicke's encephalopathy, give 500 milligrams of thiamine intravenously 3 times a day, 3 to 5 days, followed by in post-acute phase 250 milligrams either IV or IM for 3 to 5 days until symptoms stop improving. Then it was supplemented long-term on basis with 100 milligrams orally 3 times a day till nutritional recovery is there. Suppose if there is another clinical scenario like this, a chronic alcoholic patient is a diabetic, he is presented to emergency department with hypoglycemia. So what to do? Initially thiamine is mandate. This is the rule. We have to give thiamine. But dextrose also essential for this patient to avoid hypoglycemic injury. So how much time interval should be there between thiamine and dextrose? Usually it should not be more than 60 to 120 seconds. That is 1 to 2 minutes gap only. Otherwise, that type of patients may get damage, brain damage due to hypoglycemia. So give rapid IV thiamine bolus followed by a flush and then 25% dextrose. So Wernicke's encephalopathy classical triad is not present in all patients. The pathophysiology behind Wernicke's encephalopathy is mainly energy crisis. How thiamine deficiency causes Wernicke's encephalopathy? Because thiamine is a cofactor for the enzymes in the Krebs cycle and pentose phosphate pathways, especially this pyruvate dehydrogenase and alpha ketoglutarate dehydrogenase and branched side alpha keto acid dehydrogenase, and also in pentose phosphate pathway transketolase. For all these enzymes, thiamine is a cofactor. Without thiamine, they won't work. So in the absence of thiamine, there will be energy failure. In the absence of energy, cells automatically enter into anaerobic metabolism, results in lactic acidosis and swelling, excitotoxicity and oxidative stress. Why damage is remarkably specific around the periventricular region in Wernicke's encephalopathy? Because there is high metabolic demand where high rate of glucose utilization is there and oxidative metabolism is there, and simultaneously and indirectly need for thiamine. And one more thing, the blood-brain barrier is fragile around periventricular region, so more susceptible to vasogenic edema and petechial hemorrhages. How to confirm the diagnosis? The diagnosis confirmed by red blood cell transketolase activity, which is increased. But this is not routinely done because this is laborious process. Technical difficulties will be there, and all centers will not have these facilities. So if you suspect Wernicke's encephalopathy, don't go for MRI, don't go for RBC transketolase enzyme estimation. Just go for IV thiamine. Is Wernicke's encephalopathy risk is high in diabetics? If there is association of diabetes in alcoholics, it further enhances the risk of Wernicke's encephalopathy, because alcohol itself is a thiamine deficiency state because of poor intake of food and decreased intestinal absorption of thiamine. Ethanol metabolism itself required thiamine for its own metabolism, and alcohol triggers efflux transporters. And diabetes is also thiamine deficiency state. Diabetes increases renal clearance, and there is higher demand for thiamine in the presence of high glucose levels. So diabetic patients are at higher risk of Wernicke's encephalopathy. So the reasons for presentation is, it is a medical emergency. Wernicke's encephalopathy is, it is a treatable. If you not treat it, it results in 20% mortality, and 80% of survivors will have course of psychosis. So take home points. Often this diagnosis is missed clinically because majority of patients, they won't have classic triad. Majority of patients, the most common presentation of Wernicke's encephalopathy is just confusion. So that may be attributed to alcohol intoxication or in diabetes metabolic derangements. So majority times this is a missed diagnosis. So high index of suspicion is required for Wernicke's encephalopathy, and use Kane's criteria and give thiamine first as early as possible. One more important point is, if you suspect Wernicke's encephalopathy and clinically is there, radiological there, but patient is not responding to thiamine, then suspect magnesium deficiency, because magnesium is another cofactor required for pyruvate dehydrogenase complex enzyme. So give magnesium additionally to thiamine. And remember that all patients will not have radiological findings. Only 50% of times they will have radiological findings. And aggressive dosing, as I explained, is required. So if the patient is at risk and has any unexplained neurological symptoms, just give immediate IV thiamine treatment at risk patients. Thank you.
Thank you, sir, for the enlightening talk. Now it is open for the audience if you have any queries.
If you don't have questions, I have questions. Can I? A patient with history of chronic alcoholism and poorly controlled diabetes, it brought to ER with acute confusion and unsteady gait. Before administering intravenous glucose for suspected hypoglycemia, which of the following must be administered? This is thiamine. Everybody knows it. And a diabetic patient with chronic alcohol use disorder presents with nystagmus and inability to walk straight. Which area of the brain is most classically affected by hemorrhagic and necrotic lesions in the condition? Mammillary bodies. This is typical for Wernicke's encephalopathy, mammillary body involvement. A patient with chronic alcoholism is treated for diabetic ketoacidosis. If the medical team aggressively replaces glucose without checking thiamine levels, which clinical finding would most strongly suggest the onset of Wernicke's encephalopathy? As in this case, gaze palsy, ophthalmoplegia. Which of the following diagnostic test is most appropriate to confirm a suspected case of Wernicke's encephalopathy? A. MRI brain, C. Serum thiamine, lumbar puncture. Just is a clinical diagnosis based on history and physical examination. It is a clinical diagnosis. You are very attentive. Which of these population is at high risk for thiamine deficiency besides those with chronic alcohol use disorder? Type 1 diabetes on keto diet, athletes consuming high protein diets, individuals with vitamin D deficiency, patients with hyperemesis gravidarum. Hyperemesis gravidarum. Thank you.
One question, please. You have used many times the word chronic alcoholism. Can you define the chronic alcoholism?
Rather than me, a psychiatrist can answer better for this chronic alcoholism, because there are various terms: addiction, addictive, dependency. It is there. It is better to ask psychiatrist rather than neurologist. This patient was taking almost 2 to 3 quarters of whiskey every day. For almost 10 years he was taking. Right, thank you.
Sir, 1 minute. Sir, your talk has precisely translated complex neurological condition, giving its early recognition signs, practical bedside learning points for timely management, sir. Thank you for reinforcing take-home points, sir. Thank you. Now I request our young dynamic urologist Dr. D. Srikanth Reddy for sharing his insights in advancements of urology. I request Dr. Sharat Chandra sir and Siddhartha sir to chair the session. Dr. Krishnaveni and Dr. Madhuvani to complement the chairpersons. Dr. Madhuvani. Dr. Shailaja.
ఇదే కదా కనెక్షన్ ఆడియో ఏం లేదు ఇది ఎందుకు మళ్ళీ మేడం వీడియో ఉన్నాయి మేడం ఇది బాబు థ్యాంక్ యూ మ్యామ్ Good afternoon, everyone. So I thank IMA and Urology Association of Nandyal for giving me this opportunity to present this PPT. When I told Bhargav sir that I will present advances in urology, I thought it will be a smaller topic. But when I went through the subject, no, it was a very huge topic. So I will constrain myself to some topics of advances, like in prostate, stones, and in, if time permits, for stress incontinence. So what are the advancements in the benign prostatic hyperplasia management? As we all know, previously we used to give medications. The first line of medicine was the alpha blockers, which used to reduce the symptoms by 30 to 40%, mainly including tadalafil and sildenafil. Then came the 5-alpha reductase inhibitors, which will shrink the prostate gland and help to reduce the symptoms. In larger prostate, they used to have combined therapy, combining both alpha blockers and 5-alpha reductase inhibitors. Then newer drug modalities which have come into place is the PDE5 inhibitors, like tadalafil, sildenafil. In lower doses, they have good effect on improving the LUTs along with the erectile dysfunction. So this is the main advantage if you use PDE5 inhibitors. Then came like beta-3 antagonists for urgencies, which included mirabegron, which will have lesser side effects when compared to anticholinergics. Then came the GnRH antagonists, which will reduce the prostate size, and COX-2 inhibitors, which will reduce the inflammatory signs, which may lead to nocturia in some patients. So as I'm a surgeon, I'm more interested in surgery than the medical aspects. So coming to surgical improvements in prostatic management, as we all know, we have evolved from open surgeries to endoscopic surgeries in urology. Previously, we used to do open prostatectomies. Then came the era of endoscopic procedures. We used to do TURP, transurethral resection of the prostate. So initially, we used to do with monopolar, but there were many side effects with the glycine which was used in monopolar, like TURP syndrome and all those things. Then came the next bipolar, which was very good for medium-sized glands, and TURP syndrome was very much reduced. But what about the larger prostates which are more than 80 cc? Then came the laser. When the laser came, we used to do lobectomies. That means we used to remove the whole lobes of the prostate, like both lateral lobes, median lobe, and then we used to push them into the bladder, then do morcellation to remove the gland. But these all required higher doses of anesthesia, longer hospital stay, and irrigation. So now we have evolved into another good modalities which are like daycare based modalities. They are minimally invasive surgical therapies like prostatic urethral lift. Here we use tiny implants which will be passed through the urethra into the prostatic urethra. Then we use these implants and hold the prostatic lobes tightly so that the prostatic urethra will get widened and the patient will have immediate relief, and it is a daycare procedure. And transprostatic stents can be used in some patients, selective patients, where surgical treatment will be problematic for them, and in cases of malignancies, they give excellent symptomatic relief. Now the advancement came with this one, water vapor therapy, that is RISM. So it's a daycare procedure where we inject high thermal energy, that is the water vapor, into the prostatic tissue directly, and it has lesser side effects, good outcomes, and now many urologists are interested in doing this RISM therapy, and I expect maybe Bhargav sir may bring within 1 to 2 years this one to our Nandyal. So then comes the prostatic artery embolization. So here it's a non-surgical thing, more of a radiological procedure, where image guided block of the prostatic artery will be done. So it's a minimally invasive procedure. It's an outpatient based procedure where local anesthesia can be used, and it has a good outcomes also. 75% of the patients report significant LUTs improvement, and it has shown that it has a good improvement in the sexual dysfunction also. So now another latest modality is the aqua ablation. We have seen in some videos where high water jets can cut even the stones, then why not the prostate? So they have used it in the prostate, where they combined a real-time ultrasound imaging with the robotic controlled water jet injection. Here the water jet, here you can see in the video where the water jet will be injected into the prostate directly, and it will cut the tissues. If you could have noticed in the lower small box where the actual video was presenting, this here real-time ultrasound they are seeing, and this is the water jet which will be injected into the prostate through the urethra. This is the actual real image showing that the prostate has been cut with the laser jets. So then came the Optilium BPH catheter system, where it's a dual mechanism. Here we use the pharmacology and surgery. Here we use mechanical bulbs to inflate the prostate so that it can mechanically spread the prostate. Simultaneously, these balloons will have paclitaxel delivery mechanism, which will deliver this directly into the prostate, which will prevent the tissue regrowth so that the prostate remains in the same state. So this is about the BPH. Then coming to the advancements in the prostatic carcinoma management. So the main important factor here is the diagnosis. In diagnosing the prostatic malignancies, we have come a long way, where you use now PSMA, that is prostate specific membrane antigen based PET scans, where we can definitely diagnostically diagnose the prostatic malignancies with accuracy. It has earlier detection rates, targeted interventions can be done by these things, and it has a personalized treatment strategies for each and every patient. Next is the MRI guided biopsy, which is very important in patients who have higher PSA but not palpable tumors, which may be lying inside the prostate, where ultrasound truss guided biopsies is not possible and we will not have accurate biopsies. In those patients, MRI guided biopsy is an excellent choice for diagnosing. So coming to treatment modalities, some medical aspects. The first line of medicine used to be androgen deprivation therapy. Then some patients used to develop resistance for these, and they used to develop castrate resistant prostatic cancer. So next generation agents used to be like abiraterone and enzalutamide. Even they are fading away. Now comes the PARP inhibitors, which are the breakthrough in treating the prostatic cancers. So another medical management used is a radioligand therapy, where a molecule of targeted ligand is added with a radioisotope like Pluvicto, which will be introduced into the body. They will go into the bloodstream, they will identify the PSMA representing cancer cells, and they will specifically target those cancer cells, preserving the healthy tissues. So the clinical benefits are like improved survival in metastatic diseases, delayed disease progression, well tolerated with manageable side effects. So then comes the immunotherapy, where our body immunity will be targeted against the cancer. Then comes the combined therapies, where we can blend all these three modalities like PARP inhibitors, radioligand and immunotherapies. So coming to surgical aspects, robotics has played a great role in prostatic surgeries, because previously pelvic surgeries used to be very difficult to manage the bleeding, to have a suturing part to be done with difficulty with lap. Now the robotics have come in a larger way. They have very specific programming, and all the surgeries can be done with precisely, even preserving the nerves, sparing the like erection defects which will be occurring post-operatively. So advanced robotic systems enhances the surgical precision, minimize the invasiveness and reduce the complications. Then comes the SBRT technology, that is the stereotactic body radiation therapy, where radiotherapy agents will be directly introduced into the prostatic cancer. They will give a local radiation. So now comes the advancements in the renal calculi management in urology. So as you all know, there are many modalities of removing the stones. Latest is the RIRS, that is the retrograde intrarenal surgery, where a flexible scope is used and even the intrarenal stones will be targeted. So there is advancements in the flexible ureteroscopy every year. More thinner and thinner scopes are being produced with the high accuracies, and digital tips have been introduced so that we can have excellent vision. And so the removing of the stones has become very easy for the urologist nowadays. So it eliminates the need for external incisions. That is the main thing, because if a patient undergoes a PCNL, there may be chances of injuring the renal arteries, which may lead to bleeding and in sometimes nephrectomies also, which can be prevented with RIRS. So what are the advancements in RIRS? Now they have come up with negative pressure suction methods, that is fans, where we use a sheath, access sheath, for the flexible scope to enter, but this sheath has been equipped with the suction mechanism, so that when the stones are being fragmented with the laser, actually they will not be removed directly. They have to be passed over a period of time, but now it can be suctioned directly under vision. But the defect is, every time when the suction has to be done, the scope has to be removed, and the sheath which we use now, they will get damaged easily. That is the disadvantage of this. Then comes thulium laser fibers. Previously we used to have holmium lasers, which used to fragment stones up to 2 centimeters. We used to tell up to 2 centimeters go for RIRS, then after, if the stone size is high, go for PCNL. But now the thulium has come into very large scale, where it has a high energy levels, so the stones will be fragmented at a faster rate, and even at a large volume of the stones can be encountered simultaneously. I think thulium fibers are there in Nandyal. First was introduced by Bhargav sir in Nandyal, then we all have the thulium fibers now. Then coming to the main defects of RIRS is the raised intrarenal pressure, which will lead to calcial ruptures and infections. So previously we used to have optical scopes, which we have to use for every patient. Now they have come up with digital scopes, which are disposable ones, so we use for one patient and remove it and throw it out, so that the infection rates have come down. So now the latest thing is this combined intravesical stone fragmentation and aspiration mechanism, where, so this is a flexible scope, it has an incorporated laser into it, it can be flexed in all the directions, and it will be introduced from the urethra into the kidney. This is the flexible ureteroscope, which can be introduced into the kidney under guidance through by using a stent. Then when it is introduced into the kidney, it directly hits the stone under vision. There will be a high jet of water will be sprayed, so that vision will be clear. At the simultaneously, the stone fragments will be sucked out. So this mechanism has all the three features: lasing, irrigating and suctioning the stone, so that image quality will be good and all the stones will be removed. It has 97% stone clearance, 60% reduced procedure time and 85% lower re-treatment times. So another thing is the real-time pressure monitoring during erythroscopy. As I told, intrarenal pressure is the main culprit for RIRS. So we will check the pressures in the intrarenal system when we are operating, so that we will have good effects. Then comes the mini PCNL. PCNL is, as I have already told, it will puncture the kidney. So we have come up with many micro mini PCNL, so that tissue damage will be less. So next is the microbubble acoustic cavitation. Previously ESWL used to be there, where stone fragments used to happen with ultrasound beams. It was not a targeted therapy and it faded out its importance. Now they have come up again, where they combined RIRS with stone. So they will introduce a catheter near the stone, they will inject microbubbles and then use the ultrasound beams to break it, so that there will be accurate stone clearance, and it is a day care procedure they are claiming. Thank you. Restraining the time, I can't tell of urinary incontinence. Next time.
Sir,
Any questions, sir?
So what is the criteria for BPH for the medical and surgical management? So it's the size or
No, sir. Never the size. Never the size. It's always the symptoms. How the patient is having frequency, how much nocturia is there, how symptomatic is the patient. We have the prostate scoring mechanism. Based on that mechanism, we have to analyze whether the patient is fit for medical or surgical. And we will do uroflowmetry, where we will see the flow rate, then we will see how much post-void residue is there. We have seen patients with 20 cc gland having more symptoms, and 80 cc gland also patient is not having any symptoms. It's never the size, it's always the obstruction which will be causing their symptoms. And initially we will always try the medical management, and if there is no improvement with the medical management, and some patients with smaller glands will have fibrotic tissue more. So in those patients they may need for surgical management.
Then how long you have to wait till they take the decision for the surgery? So how long the patient has
Sir,
to be
when
on
you
the
start a
medical
medical management, I literally take 15 to 20 days and ask the patient to come back to check and reassess the LUT score. Okay. So if there is an improvement and patient is feeling symptomatically better, we can wait. And in some patients there is a specific criteria when we have to go for surgery, like if they are associated with another side effects, like if there is a vesical calculi associated with BPH, then definitely they have to go for surgical excision.
Thank you, sir. Any questions from the floor?
Srikanth,
Sir.
if you have more information to share with the medical people, today we have started this medical update IMA Nandyal YouTube channel with this same CME program. The entire CME program is being given live streaming in YouTube, and next time onwards we will inform how to record your speeches. We will arrange here. Anytime you can come and record the CME programs, present CME programs, we will record and upload into the YouTube channel exclusively from the IMA Nandyal.
Thank you, sir. We will definitely do it, sir.
That was an excellent presentation. Your points were very informative and insightful. Thank you for sharing, Dr. Srikanth Garu.
Thank you, ma'am.
I'm requesting Dr. Madhusudan Rao sir and Dr. Bhargavardhan Reddy sir to present memento to Srikanth. Requesting Siddhartha sir and Sharachandra sir to join. Then going to the next session. I'm requesting Dr. Nagamani madam and Dr. Narmada madam to chair the session. I'm requesting Dr. Hindumati Garu, Professor and HOD, OBG Department, Shantiram Medical College, and she is the Senior Consultant in Kedam Prasad Hospital. Topic is Caesarean scar ectopic, a precursor of placenta accreta. Dr. Anusha and Dr. Seshkiran will complement the chairpersons.
Good evening, everyone. Today's topic is cesarean scar ectopic. It's a precursor for placenta accreta. This is a case report that we have done this case in Shantiram Medical College. So the case is, she's a 24-year-old, second gravida para 1 L1 with prior cesarean section and came for routine ANC. She was booked somewhere else and she came at the end to our hospital. And she conceived 2 years after last childbirth and the pregnancy confirmed by UPT. And her first antenatal visit was at 2 months of amenorrhea at a local hospital. In the first visit itself, she was confirmed with a gestational sac in the lower segment of the uterus at the cervicoisthmic junction, that is cesarean scar ectopic. And patient was advised termination of pregnancy in the first visit itself, but the patient denied and she did not obey the orders of the gynecologist. As she was completely asymptomatic, she continued her pregnancy. And she took, the first trimester was uneventful. This is the scan report showing the scar ectopic. And second trimester was also uneventful. And even in the TIFA scan, it was diagnosed as the placenta accreta in the second trimester and confirmed placenta previa also. And second trimester was also uneventful. The same thing, that is the TIFA report showing the placenta accreta and the placenta previa. Third trimester was also uneventful. In the third trimester, she was diagnosed with IUGR and also oligohydramnios. And patient maintained her hemoglobin at 10 grams per deciliter. And even in the last trimester, that is in the 37 weeks also, we did a scan. She came at 37 weeks, 3 days to our hospital. And again in the third trimester, the same findings have been confirmed. And she came late at 37 weeks and 3 days. We don't have any time to confirm again with the MRI, because almost always we can confirm the placenta accreta with the routine ultrasound itself. So we have counseled the patient all the high risk factors possible because of obstacle hemorrhage resulting in cesarean hysterectomy. All the counseling has been done and all the complications have been explained and we have proceeded. And the past obstetric history, she had a cesarean section in GGH and it was an uneventful delivery in the first pregnancy. And past history, personal history, family and marital history and menstrual history, everything was normal. And general examination was also normal except for mild pallor on clinical examination, and her vital data was also normal. In obstetric examination, the Liker was little bit less and it was confirmed IUGR. And elective cesarean section was done at 37 weeks and blood and blood products were kept ready and all the counseling has been given for peripartum hysterectomy. Intraoperatively, SUMI incision has been given and classical cesarean section was done and a female baby was delivered with 2.3 kg with a vertex presentation, and complete placenta previa was noted, which was densely adherent and invading into the myometrium. Bladder was not involved intraoperatively and there was a massive hemorrhage. We did uterine artery ligation in the beginning, but the bleeding was not under control. So the urologist was called and we did internal iliac artery ligation and later we have proceeded for cesarean hysterectomy. And the total blood was around 2500 ml and she received 3 units of PRBC, 3 units of FFPs and 4 units of RDP intraoperatively. And she was admitted in ICU because of the hemorrhage. And she had an uneventful recovery and was discharged on the 12th post-operative day. And the HPE report was confirming placenta accreta. So these were the intraoperative pictures and the classical cesarean section that we have done, and adherence of placenta in the lower segment. So the topic is, this patient was diagnosed cesarean scar ectopic in the beginning itself. She has continued her pregnancy in spite of telling the termination in the beginning itself. So this has resulted in the peripartum hysterectomy, in the terminating her future conception also, at the permanent loss of fertility has resulted, and also the major morbidity that she has to face during the surgery and post-operative recovery. So cesarean scar ectopic, it's a variant of uterine ectopic where there is full or partial implantation of the gestational sac over the scar in a previous cesarean section. So the incidence of cesarean deliveries are increasing, and at the same time the complications due to cesarean deliveries are also increasing. So one of the complication is CSP, and there is high morbidity also, and CSP is considered as a precursor for placenta accreta syndrome. And then incidence of CSP is 1 in 1800 to 1 in 2500 of all cesarean deliveries performed. And the types of cesarean scar pregnancy are divided based upon the location of the gestational sac and the minimum thickness of the myometrium available. So type 1 is partially located on the scar of, and myometrial thickness is more than 3 mm, that is more towards the cavity. And type 2 is partially located in the scar itself with myometrial thickness less than 3 mm. And type 3 is where the sac is completely located in the area of the scar and myometrial thickness will be less than or equal to 3 mm. And based on ultrasound also it is the same, exogenic and endogenic. Endogenic more towards the cavity and exogenic over the scar and more towards the bladder in the niche of the CSP. Pathogenesis is similar. There will be microtubular dehiscent tract, and there is direct invasion of the trophoblast and loss of myometrial barrier and loss of decidual tissue as well as Nitabut's membrane. That is why extravillous trophoblastic invasion will be there and resulting in the placenta accreta spectrum. So clinical presentation, it is highly variable. Mostly 25% of the cases it might be asymptomatic, and some patients might present with vaginal bleeding and abdominal pain, with or without any pain. So ultrasonography is confirmatory or primary imaging modality for confirmation of the diagnosis of CSP. So in ultrasound there will be empty uterine cavity as well as the endocervix. Placenta, gestational sac, both might be embedded in the hysterotomy scar, and the triangular or round or oval gestational sac might fill the scar or niche, and the myometrium thickness will vary depending upon the sac location. If it is nearer to the endometrial cavity, might be more than 3 mm. If it is more towards the bladder, it will be, the myometrial thickness will be less than 3 mm. And prominent vascular pattern will be observed. So this is the ultrasound picture of the cesarean scar ectopic with prominent vascularity that you can observe. MRI also provides the degree of invasion, and if there is evidence of placenta accreta syndrome, that also you can diagnose, and any bladder invasion also you can confirm with MRI. And even in laparoscopic examination, you will observe as a ecchymotic bulge with Solman red appearance beneath the bladder with a normal uterus. So in the laparoscopy you can observe. And the management mainly, if the patient is stable and early CSP, you can go for medical management, methotrexate systemic or local injection of methotrexate intragestational into the sac with or without KCL based upon the cardiac activity. Rather than medical management, surgical management provides more success rate. So surgical management indications failed medical therapy, or if there is high bleeding risk or any advanced gestation, or you can go with ultrasound guided suction evacuation with cervical balloon tamponade, or hysteroscopic resection, or laparoscopy or laparotomy excision, and scar repair can be done. Interventional radiology, uterine artery embolization can be done with adjunct to medical and surgical management. This will reduce the hemorrhage risk to the maximum extent. So uterine artery embolization can be tried based upon the patient factors. And emergency management, if there is any massive hemorrhage or uterine rupture, you may need to go for laparotomy with or without hysterectomy. And in patients who opt for expectant management, we can recommend repeat cesarean delivery between 35 to 36 weeks of gestation. Complications with CSP, so fetal death, prematurity, placenta accreta syndromes, uterine rupture, severe hemorrhage, and need for hysterectomy, and also maternal death. So this is the largest review article that has been published recently, where they have studied 194 cases. If you see the data here, most of the cases are preterm deliveries in patients. So 81 cases were preterm delivery, that is 41%, and only 50 cases out of 194 have reached the term, that is only 25% of the cases. And if you observe the need for hysterectomy, it has been more than 50%. So 52% of the cases have landed in hysterectomy. And maternal hemorrhage and morbidity is also there in these patients. So take home message, reduce unnecessary primary as well as repeat cesarean sections to reduce the rate of CSPs. Ensure good suturing practices of the uterine incision excluding the decidia. Adequate interpregnancy interval has to be followed at least for 18 to 24 months. And perform early transvaginal ultrasonography in patients with repeat cesarean section so as to identify the cases of CSP and advise termination of the pregnancy as soon as possible. Counsel all the possible risks and complications that we can anticipate in continuing CSP, that we have to counsel to the patient as well as the attenders. And multidisciplinary care of approach has to be done in patients who continue the pregnancy with CSP at tertiary care center. Thank you. At Shantiram, we saw only 3 cases of CSP, ma'am. But we did placenta accreta syndromes, around 6 cases we did. But only 3 cases of CSP we have seen. And we have terminated 2 cases of CSP. This is the only case because she has come late at our hospital, where she has been advised termination, but she did not undergo termination in the first trimester. This is the only case where CSP has progressed to pass.
Does the technique of doing cesarean section plays a major role in preventing CSP?
Yes, ma'am. There are many factors that can lead to CSP. A technique of suturing is also important. In comparison to interlocking, we are going these days with continuous without locking, and also excluding the decidia into the suturing will definitely reduce the incidence of CSP.
Did you find any difference in the suture material using?
Yes, ma'am. Vicryl is more beneficial.
But after using Vicryl, we are seeing more number of CSPs, and
because more number of repeated cesarean sections can also impair the healing of the wound. That also a predisposing factor for CSP.
Can we can we advise routine scan after 9 months of C-section to know isthmosil? Isthmosil is the main thing for CSVs. Shall we start practicing that?
Isthmosil, ma'am. In primary,
anemia also plays major role. In
repeat cesarean section. Yes.
Anemia is also plays major role in healing.
Yes, ma'am.
Sutures.
How will you terminate in first trimester scarectopics in your practice?
We did laparotomy only, ma'am.
For 2 cases.
Yes, ma'am. We did laparotomy, not laparoscopy.
Even I did
not
one
even
case.
uterine artery embolization we didn't try. We just went for laparotomy.
Even I did laparotomy for one of my patient.
Yes. Maybe we can try uterine artery embolization because nowadays we have interventional radiologists available, because we didn't had interventional radiologist. Might be that would be a better approach rather than going for a laparotomy.
Is there any questions from audience?
Yeah, ma'am, but still we have that option. We can reduce the morbidity to a more extent.
In cases of primary?
Yes, primary, ma'am. Yes.
Any questions from audience?
Thank you, ma'am. Thank you.
Thank you, Indumati madam, for presenting a case that is a nightmare for every gynecologist, and also appreciate the bold management of the case at Shantiram Medical College. Now I request the next speaker, Dr. Pavan Kumar Reddy, for the next topic. The topic is when pain signals an emergency and not just another headache.
Vijay?
And I request Dr. Somshekar Reddy sir and Shailja ma'am to chair the session. And I request Dr. Ashok Kumar sir and Sindhu radiologist to complement the chairpersons.
Good evening, everyone. I'm Dr. Pavan Kumar Reddy, consultant neurologist in Shantiram Hospitals. I'm just presenting in a case of headache, which is rare. And also you can see a lot of cases recently now. There is exponential growth of these cases in recent OPDs. I would like to tell lot of neurologists, ophthalmologists and general physicians, they see lot of headache cases day in and day out in OPDs. But it is very important to classify the headache on the OPD itself. Why it is very, very important to classify the headache and the OPD settings, I'll tell in next few minutes. I'm jumping into the clinical details. She is a 18-year-old female engineer student presented with complaints of headache since 1 week, and she developed some double vision since 3 days. To detailedly explain about headache, Day 1, she woke up in the morning on 15th July 2025. She has severe headache in the early morning, initially presented to a physician where symptomatic treatment with analgesics given. There is no improvement. 3 days after the onset of headache, the patient developed double vision. Because of double vision, the patient was referred to me. And to in detail explaining, the headache is holocranial, throbbing, severe but fluctuating course, worse in the morning, and there is no photophobia, there is no phonophobia, and there is no nausea or vomiting, and there is no redness of the eye or lacrimation. And to in detail explaining the double vision, patient has binocular double vision, and the images separated horizontally, which is more pronounced with the lateral gaze on the both eyes, and pronounced on distant vision, and the near vision is relatively less affected. And there is no history suggestive of any other cranial nerve involvement. There is no history suggestive of any weakness of limbs or sensory involvement. There is no bowel and bladder involvement. And there is no history of trauma, and the patient doesn't have any other comobs. The past history, it's not significant. And coming to the menstrual history, she attained menarche at the age of 13 years. She had irregular cycles from past 1 year, but she is not on any treatment. And general examination, the patient is very obese patient. Even though she is 18-year-old, her BMI is around 35 kg, 35.5. You can see the patients, the ocular movements of the patient. When you focus on the right eye, there is an abduction restriction in the right eye, and also the abduction restriction in the left eye. The right eye abduction restriction, which is more compared to the left eye. So clinically, the patient has headache. You can see again the video. Patient has headache with bilateral lateral rectus palsy. So right more than left. So the clinical diagnosis is headache with a bilateral 6th cranial nerve palsy. So apart from this abduction restriction, the pupils were normal, the visual acuity is also normal. So to conclude what can be the diagnosis, I have proceeded to check the fundus. You can see the fundus. The fundus of bilateral eyes, the right eye and left eye, both have significant papilloedema around grade 3 to grade 4 papilloedema. You can see there is obscuration of vessels around the disc. So she has headache, then clinically patient has 6th cranial nerve palsy bilaterally, then the patient has papilloedema. So this is a case of raised ICT headache. So to summarize, this 18-year-old female patient without comobs presented with 10 days history of headache that is which progressive followed by the double vision, which is horizontal double vision, and without any other cranial nerve involvement and without any other systemic involvement. What can be the differential diagnosis for this patient? So even though patient doesn't have any significant history of fever, we can have the patient present with acute meningitis and the CSPT, intracranial space occupying lesions, bilateral pontine infarcts, and can be idiopathic intracranial hypertension. These are the DDs which patients can present with these symptoms. So next, move to the imaging. You can see this is a T2 imaging, the axial section of the T2 imaging. You can see the kinking of both sides optic nerves. You can see the optic nerve kinking. And also the T1 sagittal section, you can see there is a partial empty cella. These are typical signs for the raised ICT features. So the patients with the clinical and also radiologically confirmed there is raised ICT headache without any space occupying lesions. And MR venogram was normal. So, and then I proceeded for the lumbar puncture. Lumbar puncture, the many things while doing lumbar puncture, we have to see the opening pressure in any case with headaches or with any altered sensor. We have to measure the CSF opening pressure. The opening pressure is very, very high. It is around 55 centimeters of water. All the routine investigations to rule out the meningitis were normal. Protein, sugars, ADA, and CB is also not detected. So other CSF routine analysis was also normal. So this is a classical case of idiopathic intracranial hypertension. This is the diagnostic criteria for idiopathic intracranial hypertension, which suggests the signs and symptoms of increased intracranial pressure. Example, the headache, transient visual obscurations, papillary edema, and pulsatile tinnitus, and the visual loss. And there is no altered level of consciousness or nor localizing neurological signs except unilateral or bilateral sixth cranial nerve palsy. Increased intracranial pressure should be present with normal CSF composition, and also while doing the neuroimaging, we should not only do the MRI brain. We also have to do MR venogram to rule out the CVT to label the patient as idiopathic intracranial hypertension. There is no other etiology explaining the intracranial hypertension. So usually what are the common mistakes while labeling the idiopathic intracranial hypertension is, we'll do an MRI, we'll keep the patient on drugs for the idiopathic intracranial. That is not right. We have to open the CSF. CSF is both diagnostic and also therapeutic for the IIH. And also we have to rule out the CVT, we have to rule out any infection before labeling. If we miss any of these steps, patient may land in trouble. What next? So in neurology, actually the diagnosing the case is a little difficult, but for this patient the story starts now. After removing 30 ml of CSF, I also started on acetazolamide for 1 gram BD for the patient. Day 1, patient headache is significantly subsided. And the patient is very happy and hoping for all the symptoms to resolve within 3 to 4 days. But I advised for CSF diversion procedure. Patient is not happy. Because even though the patient's symptoms are improving, why are you advising me to go for an interventional procedure? But they asked for the discharge when I told to get some surgery. But is it right to discharge this patient? No. Why? Why I will tell. And the first follow-up, I convinced the patient to come within 2 days after the discharge. They came, patient is symptomatically better, headache is gone, almost 100%. Double vision also improving for near vision and still persistent for the distant vision. Then fundus examination done. I am not expecting the fundus, the papillary edema to resolve within 2 to 3 days. Still there is grade 3 to grade 4 papillary edema present. So what next? I still insisted for surgery. Patient is surprised. Patient headache is gone and the other symptoms are improving. I am insisting for surgery. What surgery? I am insisted for the thecoperitoneal shunt or a VP shunt for this patient. Why? Because you can see this is the visual field testing for a patient on day 1 of the LP, at almost 5 to 6 days after the onset of headache. You can see there is enlargement of blind spot on both the eyes. Some visual field defect, enlargement of both the blind spot we can expect in a idiopathic intracranial hypertension patient. This is on the day of LP. Just before the LP, I did this visual field testing. Day 3, I told them to come after 2 days. On day 3, after LP, the patient, you can see the visual field of the right eye and also left eye. You can see the patient is losing the peripheral vision, which is patient is not able to tell to me, or patient usually when there is loss of peripheral vision, patient doesn't have any symptoms usually unless the patient develops the central vision symptoms. So patient is losing her vision in spite of symptomatic improvement, in spite of after removing 30 ml of CSF, patient is losing her vision. But after showing this patient, they are convinced to go for the surgery. So, okay. So why it is very important, this is not just IIH, this is fulminant IIH. Fulminant IIH means this is rare aggressive variant of IIH, which is characterized by rapid rise in intracranial pressure. She has some 1 week to 10 days history, that's all. And severe bilateral papillary edema, grade 3 to grade 4 papillary edema within 1 week of onset of headache. And acute or subacute vision loss within days to 4 weeks. She is losing her vision within 10th day after the presentation of headache. So she is fitting quietly into fulminant IIH. That's the reason I am asked to go for a surgery. What kind of surgeries we can do for the idiopathic intracranial hypertension? That's usually a surgeon's choice. If the patient losing vision within 12 hours, they'll go for the optic nerve fenestration surgeries. If the patient has sometime days, they'll opt for the thecoperitoneal shunting or a VP shunting. And I told when they go for the surgery, patient, they have done the thecoperitoneal shunting. There are two types of shunts. There are programmable shunts and the non-programmable shunts. Programmable shunts, the surgeon can adjust the pressure. So we can even after the surgery, if you want to adjust the pressure, we can adjust. Non-programmable shunts we are using regularly, but programmable shunt is preferable. Why? Means she is very young. How many days or how many months we have to keep this, we don't know. So there is a chance of getting slit ventricle syndrome. Because of over drainage, there can be chance of slit ventricle syndrome with the non-programmable shunt. I told them specifically to go for a programmable shunt. They did the programmable shunt and they kept the pressure for the 16 centimeters of water. And after 1 or 2 days, they have adjusted it to 15 centimeters of water. And after procedure, some 10 to 15 days after, they came to me again. And after the thecoperitoneal shunting, patient is symptomatically better. And the fundus examination, still there is grade 3 papilloedema. What we can do? Don't expect papilloedema to resolve within days of surgery. It takes at least 2 to 6 months to resolve. What we have to see is this visual field. You can see the right and left visual field. When compared to the previous visual field, the patient's peripheral vision is improving. This is the criteria to go further for what to do, what not to do for the procedure, whether the procedure is adequate or not. So the procedure is adequate. This is after the surgery, 10 days after the surgery, you can see the ocular movements completely normal. The patient doesn't have headache, diplopia is gone, and movements became to normal. So, this is an emergency. Patients with fulminant IH, this is an emergency. So, high doses of acetazolamide we can keep up to 4 grams per day. Even though the role of methylprednisolone is controversial, but fulminant IIH patient, it will delay the visual prognosis and the bad visual prognosis. Repeated therapeutic lumbar punctures we can do if they are not willing for initial days surgeries. Medical therapies alone is usually not sufficient in cases of fulminant IIH cases. Definite surgical management is optic nerve sheath penetration surgery, CSF diversion procedure like LP shunt or ventriculoperitoneal shunts, and also the venous sinus shunting. So coming to the next case, a 18-year-old boy with history of holocranial headache since 2 months. There are no other symptoms apart from the headache. Headache is holocranial, episodic, throbbing, relieved with the analgesics. BP and fundus are normal for this patient. This is an unclassified headache. I kept the DDs like tension type headache or a migraine. I kept on analgesics for a week. This guy came after a week. After a week, he was fine. Again, 10 days later, similar complaints he presented along with some nausea. And I advised for MRI. He was not willing for an MRI. Okay, I put in a migraine with propranolol and flunarizine combination for a month. A month later, he is fine and I tapered drugs within 15 days. And again, after a month, patient came with the similar complaints with the headache. Then repeat fundus I did. The repeat fundus is normal. So I ordered for the MRI brain. MRI brain showed, again, there is optic nerve kinking and a partial empty cella. Fundus is completely normal. Whether even in the OPD, if I see lot of papilloedema cases, the fundus is normal. MRV showed transverse sinus stenosis. Visual acuity is normal and visual fields also normal. But I told the patient to get a lumbar pressure. I did CSF opening pressure is 30 centimeters of water. It is fairly elevated. And the CSF I removed 25 ml and the analysis is normal. I kept an acetazolamide. Patient is completely fine. This is idiopathic intracranial hypertension without papilloedema. Even though if there is patient doesn't have any papilloedema, in refractory patients, you have to ask the patient, if the patient is repeatedly coming to your OPD, ask the patient to get a CSF pressure. Friedman's criteria is the criteria which he modified the Dandy criteria. Actually, IAH without papilla edema is the criteria without papilla edema in Friedman's. Along with that, the patient may have unilateral or bilateral sixth cranial nerve palsy with MRI findings. Also, even without MRI findings, if the patient CSF opening pressure is elevated, even we can attribute this to the IAH without papilloedema. So take home message is, don't send a headache patient without examining fundus and also a BP. Don't consider just MRI features before labeling the patient as IAH. Symptomatic improvement is not always the parameter. So acetazolamide cannot stop the patients developing blindness even with maximum doses of fulminant in cases of fulminant IAH. So it is very, very, very important to identify what is IAH and then to differentiate it from fulminant IAH. Because if we miss that fulminant IAH, if we kept the patient on drugs, what will result is the permanent blindness. Thank you. Yes, madam. All cases it is mandatory. Because lot of cases, if you see MRI brain, it looks normal. CVT, some cases, in cases of transverse sinus thrombosis or small thrombosis in CVT cases, we tend to miss an MRI. So better to do MR venogram or a CT venogram. Anything is fine.
In uncontrolled systemic hypertension patients also we get papilledema sometimes.
Yes, sir.
When the patient is having
Yes,
accelerated hypertension or hypertensive emergency, and some visual disturbance also we get. And how many days it will take for the papilledema and visual disturbances to come down after controlling systemic hypertension?
Sir, any systemic disorder which is causing papilloedema, any local disorder which is causing papilloedema, it will take at least 1 to 2 months. Sir. We can't expect the papilloedema as a prognostic sign. The prognostic sign in a lot of cases is the visual field testing rather than just papilloid. Papilloedema will help for the diagnosis rather than a prognostic sign.
Thank you. Thank you. We'll close the session. Any questions? Thank you.
Thank you.
Thank you, Dr. Prashant, for your valuable Dr. Pawan Kumar, for your valuable insights. I humbly welcome all of you for first physical CME by AMS Nandyal in association with WBW under the guidance of IMA and Urology Society of Nandyal. Thank you. Now we will proceed to the inauguration session. Now we respectfully invite our chief guest Dr. K. Srinivas Rao, Sir, President IMA Nandyal, to kindly take their place on the dais. We request now our Dr. Ravi Krishna sir, our constant force and encouragement for today's session, former IMA AP State President, Central Working Committee member, to grace the dais with his esteemed presence. I invite our esteemed young dynamic Dr. Bhargav Vardhan Reddy, first urologist of Nandyal, President, first super specialist of Nandyal, also known as Laser Bhargav, President Urology Society. Now we request Dr. Panil Kumar, Joint Secretary, IMA AP State, to please take his seat on the dais. I invite our distinguished speaker, academician, all-rounder, Dr. Madhusudan Rao Sir Garu, immediate past president, to grace the dais. We request senior most surgeon of Nandyala, Dr. Sahadevudu Sir, our mentor and guide for many people. Sir, on the way, sir. I invite our young and dynamic Dr. Madhusudan Reddy Sir Garu, Superintendent, Shantiram Medical College and Hospital, to take his place in dais. We request our APMC observer for today's session, Dr. Vijay Bhaskar Reddy Sir, to please come forward to the dais. I invite Dr. Muhammad Rafi, Secretary IMA Nandyal, to the dais. I request Dr. Lakshmi Saujanya Ma'am, Secretary WDW IMA AP State, whose contributions inspire us all, to kindly come to the dais. I invite Dr. Mallishwari, President AMS Nandyal, our respected senior friend, to join the dignitaries on dais. We request Dr. Anil Sir. I invite our silent force behind every program from the start of Women's Wing, Dr. Madhavi Madam, President, IMA, President Nandyal, to please take to the seat on dais. We request our dynamic mentor, Dr. Vasudha Rani Ma'am, a strong supporter of all women doctors initiative works, to kindly join the dais. I invite State Working Committee member. I request Dr. Susuma Ma'am, AMS Coordinator, representing the younger leadership, to grace the dais. I request Dr. Shailaja, Organizing Secretary, Women's Wing, to kindly take the place in dais. I request Dr. Harita Ma'am, SWC member, Treasurer of IMA Nandyal and Women's Wing, immediate past President of AMS Nandyal, to grace the dais. I request our senior most gynecologist, Dr. Nagamani Ma'am, the force behind Dr. Madhumani Nursing Home and Madhusudan Rao Sir. I request Dr. Narmada Ma'am, Honorary Chairperson, WBW, to take the place in dais. Now we invite all the dignitaries on the dais to come forward and participate in the ceremonial lighting of lamp, symbolizing knowledge and enlightenment. I request prayer from Dr. Sahadevadu sir.
We will honor our president with the medallion. నిలబడాల్సిన అవసరం లేదు కదా సార్, కూర్చోవచ్చు. అదే మనం కూర్చొనే కదా వ్రతాలు నోములన్నీ చేసి.
ఈరోజు రథసప్తమి కనుక ఆదివారం రథసప్తమి, సూర్యుడి ప్రార్థనతోనే చేద్దాం. సప్తాశ్వరథమారూఢం ప్రచండం కశ్యపాత్మజం శ్వేతపద్మధరం దేవం తం సూర్యం ప్రణమామ్యహం. చిన్నది చేయమన్నారు, చిన్నది చేసి.
IMA prayer by Dr. Vijay Bhaskar Reddy sir.
Kindly stand up and repeat along with me. May everybody be happy. May every one of us see to it that nobody suffers from any pain or sorrow. I do not ask for crown, nor I wish to be in heaven or reborn. I only want to alleviate the suffering of those people who are burning in fire of sorrow. Long live IMA, Jai Hind.
Flag salutation by Dr. Panel Kumar. We did not repeat, but we have to stand. It is a flag salutation, a national flag salutation.
We, the members of Indian Medical Association, stand here to salute our national flag. In honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it, and realizing our responsibility is the accredited members of this national organization, swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind, long live IMA. Thank you.
President IMA Nandyal branch opening remarks.
సభకు నమస్కారం. Dignitaries on the dais and off the dais. Good afternoon, good evening all. స్వాగతం సుస్వాగతం. ఈ న్యూ ఇయర్ ఆరంభంలో 2 years క్రెడిట్ అవర్స్తో ఒక CME కండక్ట్ చేయటం నిజంగా నంద్యాలలో ఇది ఆనందదాయకం. నంద్యాల IMA is very active branch in all social activities, conducting regular CMEs. Mainly our women doctors wing doing amazing participation in all social activities, school health programs and motivational programs to girl childs, and recently conducted cancer cervical screening program very successfully. First 1 week anukunnamu kani it extended up to 3 weeks. I appreciate and congratulate all women doctors who actively participate in this program. Thank you. And we are also doing social activities, motivational speeches by our legend Dr. Madhusudan Rao garu, and we also participate in Swargadhamam activity recently. నిజంగా స్వర్గధామం అంటే అది హిందూ శ్మశాన వాటిక. శ్మశానం అంటే తెలుసు కదండి, కానీ ఈ స్వర్గధామం అలా లేదు. 6000 మొక్కలతో ఒక ఉద్యానవనంలా నిర్మించారు. నిజంగా మధుసూదన్ గారికి హ్యాట్స్ ఆఫ్. అంత బ్యూటిఫుల్ శ్మశాన వాటికని స్వర్గధామంగా మలిచారు. I proudly say Nandyal IMA have good scientific team both in specialties and super specialty wings, because ఈ CME గురించి అనౌన్స్ చేయగానే హ్యూజ్ రెస్పాన్స్ వచ్చింది. రెస్పాన్స్ రావడంతోనే మనకి స్పీకర్స్ లోకల్గానే మనకి టోటల్ స్పీకర్స్ వచ్చేసారు. ఇంకా స్పీకర్స్ వెయిటింగ్లో ఉన్నారు. సో థింక్ అబౌట్ ద నంద్యాల కెపాసిటీ. I think this is the first time CME conducting with local speakers with 2 CME credit hours. It is honor to Nandyal, I think. CME strengthens our clinical decision making, improves treatment outcome and helps to reduce medical errors. CME గురించి చెప్దామనుకుంటే భగవద్గీతలో ఒక శ్లోకం స్ఫురించింది. గీతలో శ్రీకృష్ణ భగవానుడు ఇలా అన్నారు: అభ్యాసేన తు కౌంతేయ వైరాగ్యేణ చ గృహ్యతే. అభ్యాసేన తు కౌంతేయ వైరాగ్యేణ చ గృహ్యతే అంటే నిరంతర అభ్యాసం, ఓర్పుతో ఏదైనా సాధించగలం. ఒక్కరోజులో ఏ సాధన పూర్తి కాదు. వాల్మీకి రామాయణంలో వానరసేనతో ఒక సముద్రం మీద వంతెన నిర్మించాలనుకున్నప్పుడు ఒక పెద్ద రాయితో ఆ వంతెన పూర్తి కాలేదు. కొన్ని వేల చిన్న రాళ్లతో రామసేతు నిర్మాణం జరిగింది. సో మై డియర్ ఫ్రెండ్స్, ప్లీజ్ షైన్ యువర్ నాలెడ్జ్ విత్ CMEs. థ్యాంక్ యూ వన్ అండ్ ఆల్. లాంగ్ లివ్ IMA, లాంగ్ లివ్.
Thank you, sir. Now I request Dr. Bhargavardhan Reddy, sir, President Urology Society of Nandyal, to share few words.
Respected dignitaries on the dais and off the dais, Nandyal is being witnessing many broad and Nandyal is being witnessing many IMA conferences and many broad and super specialty conferences nowadays. Recently, we as Urology Society of Nandyal conducted combined state urology conference. And Urology Society of Nandyal is fortunate to sponsor the first of its kind IMA AMS physical conference of Nandyal chapter. Nandyal IMA is unique among all organizations. All members will support unconditionally for any academic programs and for any social causes. All of you please stay till the end to get updated about cross-specialty knowledge, and you will be benefited at some point of your practice while treating your patients. Thank you for giving me this opportunity. Thank you.
Now I request Dr. Madhusudan Rao, sir, to share few thoughts.
హలో, అందమైన వైద్య విజ్ఞాన శుభ సాయంకాలం. నిజంగానే ఒక్కొక్కసారి విద్వాంసులు లేనప్పుడు నిలయ విద్వాంసులతో వాద్యగోష్ఠి నిర్వహిస్తూ ఉంటారు. కానీ మన నంద్యాలలో ఆ కొరత ఏమీ లేదు. నిలయ వైద్యుల నిరంతర వైద్య విజ్ఞాన సదస్సుకు ఇంత అనూహ్యమైనటువంటి స్పందన వస్తూ ఉందంటే ఒక్కటి ఖచ్చితంగా చెప్పవచ్చు, నంద్యాల వైద్యులు బాగా చదువుకుంటున్నారు. అది మోస్ట్ ఇంపార్టెంట్. అంటే గంటకు ఒకసారి ఒక సిరీసో టీవీ ఛానళ్ళు చూస్తూ కూడా అంతో ఇంతో విజ్ఞానాన్ని సంపాదించుకుంటున్నారు. ఆ విజ్ఞానం సంపాదించుకున్నది ఇంకొకరితో షేర్ చేసుకుంటున్నారు. దానికోసమే మళ్ళీ మే నెలలో ఇప్పుడున్న 15 మంది నిలయ విద్వాంసులు కాకుండా మళ్ళీ 2 మనకు క్రెడిట్ అవర్స్ వచ్చే విధంగా ఏర్పాటు చేసి చివరగా నంద్యాల జిల్లాలో ఎక్కడైనా ఏ సదస్సుకు పోకపోయినా సంవత్సరానికి కావాల్సిన 6 క్రెడిట్ అవర్సు మన నంద్యాల IMAనే అందరి వైద్యులకు ఇస్తుంది. ఇటువంటి వినూత్నమైనటువంటి ఐడియా రావడం మొట్టమొదట రవికృష్ణను మనం అభినందించాలి. ఎందుకంటే 5 సంవత్సరాలకు 30 కావాలి. ఇప్పుడే అంటున్నాను భార్గవ్లో, మాలాంటి సీనియర్ సర్జన్స్ అలా ఎగ్జంప్షన్ ఇస్తే ఏదో 10 గంటలకే మాకు అనుమతిస్తే సరిపోతుందని. అది ఇచ్చినా ఇంకా బాగానే ఉంటుంది. ఏది ఏమైనా ఇది ఎక్కువసేపు మాట్లాడే సమయం కాదు. కానీ నాకే అనిపిస్తుంది, వన్ థింగ్ ఐ కెన్ సే, ఇఫ్ యూ do not get updated, you will be outdated. అది మాత్రం ఎంతైనా కూడా మనము చనిపోయే చివరి క్షణం వరకు నిరంతర విద్యార్థిగా ఉంటూ ప్రతి సంవత్సరం 6 క్రెడిట్ అవర్స్ని మన నంద్యాల IMA నుంచి తీసుకుంటూ ఇంకొక మంచి యూట్యూబ్ ఛానల్ మనం ఓపెన్ చేస్తున్నాం నంద్యాల IMA. కాబట్టి మీకు సంబంధించిన ఏదైనా సరే మీరు దగ్గర కూర్చొని మీ మొబైల్లో మీరు రికార్డ్ చేసి పంపించినా కూడా మన IMA వైద్య విజ్ఞాన సదస్సుగా ఒక యూట్యూబ్ ఛానల్ కూడా రాబోతోంది. ఈ అవకాశం ఇచ్చినందుకు మరొక్కసారి ధన్యవాదాలు చెబుతూ నమస్కారం.
Thank you, sir. Now I request Dr. Madhusudan Reddy, sir, to share few words.
Dignitaries on the dais, of the dais, members Nandyal IMA and other members of IMA from Bananganapalli, Atmakur and different places of outside Nandyal. Very good evening. First I would like to congratulate IMA Nandyal branch, IMS branch for conducting this type of programs with the 2 credit hours. I would like to thank for sponsoring by Urology Society, and I think it continues from Bhargav. Eppudu Bhargav adigina kuda is ready for to sponsor every year. So actually this type of things, when I was secretary, I am a secretary Nandyal, we used to give credit hours. Appude ichchavallam manam that time. Yeah, 1 credit hours or 2 credit hours, whenever it is possible. We used to get sponsor from the companies only. సో మిడిల్లో చాలా మటుకు మర్చిపోయినట్టున్నారు. ఇప్పుడు అగైన్ మళ్ళీ ఇప్పుడు స్టార్ట్ చేసినందుకు ఇట్ ఈస్ గుడ్ థింగ్ ఫర్ నంద్యాల IMA డాక్టర్స్. నో నీడ్ టు గో ఫర్ ఎనీ కాన్ఫరెన్సెస్ బై వేస్టింగ్ యువర్ మనీ అండ్ దిస్ థింగ్ ట్రావెల్. సో యూ కెన్ అవైల్ యువర్ క్రెడిట్ అవర్స్ ఇన్ నంద్యాల ఓన్లీ. సో ఐ రిక్వెస్ట్ IMA president to conduct at least quarterly this type of program. At least 6 credit hours is must, and you should get to the Nandyal IMA doctors and surrounding doctors. Thank you for giving this opportunity. Thank you very much.
Thank you, sir. Now I request Dr. Sahadevudu, sir, to share few of his words.
సభకు నమస్కారం. ప్రతిదినము పెంచుకున్న తెలివి, పదుగురితో పంచుకున్న కలిమే కలిమి అంటారు. అంటే ప్రతిదినము సమయం వృధా చేయకుండా మన జ్ఞానాన్ని పెంపొందించుకోండి. మీరు కష్టపడి సంపాదించిన ఐశ్వర్యాన్ని సమాజ సేవలో 10 మందితో పంచుకోండి. దాన్నే సంస్కృతంలో క్షణసస్ కనసశ్చైవ విద్యామర్థంచ సాధయేత్ క్షణత్యాగో కుతో విద్య కణత్యాగో కుతో ధనః అంటారు. క్షణక్షణము క్షణసస్య అంటే ప్రతి క్షణము మీరు విద్య నేర్చుకోవాలి. కనకన అంటే కనకనం అంటే ₹1 అలాగ అనుకోండి. ₹1 సేకరించి ధనాన్ని తీసుకోవాలి. క్షణాన్ని త్యాగం చేస్తే విద్య రాదు, కణాన్ని త్యాగం చేస్తే ధనం రాదు. నమస్తే.
Thank you, sir. Now I request Dr. Madhavi ma'am to share a few words.
A warm good evening to all my senior and leaders, IMA leaders on this stage, and also to all my friends who have come to attend the CME. After Ravi, Sadavudu sir, Madhu sir మాట్లాడాక ఇంకా మాటలు రావట్లేదు. మీరు అంత ధారాళంగా మాట్లాడుతుంటే మాటలు ఎత్తుకోవాల్సి వస్తుంది సార్ మాకు. Okay, I want to convey my sincere, heartfelt thanks to all the women doctors who really have participated in mass campaign of cervical cancer awareness programs, and also posting their messages and videos on their status, WhatsApp, Facebook, all social media platforms they have used to reach the public, and also giving awareness programs in schools and communities. Without them, this program would not have gone to such a level, and we got such a good success. Getting 300 people in the first week screening is really a big thing, because whole day, even if we keep a camp and ask, not even 5 members will be turning up to the camp, it seems. So how to take this to the public, and we have a really all the obstetrician, gynecologists, non-gynec doctors also have helped it. ఒక్కరితో కాదు సార్, ఇది హోల్ టీమ్ వర్క్ అని చెప్పాలి, అందరికీ ఆ క్రెడిట్ ఇవ్వాలి. ఒక కాల్తో కమ్యూనిటీ రెస్పాన్సిబిలిటీగా ఫీల్ అయ్యి విత్ ఫుల్ ఆఫ్ స్పిరిట్, సర్వీస్, కంపాషన్తో వాళ్ళంతా వచ్చి దే హ్యావ్ పార్టిసిపేటెడ్ ఇట్. అండ్ రియల్లీ మోర్ దెన్ 350 వీ హ్యావ్ డన్. అండ్ మనస్ఫూర్తిగా అందరికీ కృతజ్ఞతలు చెప్పుకుంటున్నాను. దీనికి ఈవెన్ IMA లీడర్స్ హ్యావ్ రియల్లీ సపోర్టెడ్ అస్. థ్యాంక్ యూ సార్. ఇంకొక విషయం వచ్చేసి AMS లేడీ డాక్టర్స్ కూడా చాలా డైనమిక్గా బాగా అరేంజ్ చేశారు. ఆల్మోస్ట్ 1 month నుంచి దీని ప్లానింగ్, ఎగ్జిక్యూషన్ కోసం చేస్తూ వచ్చారు. అండ్ ఈరోజు చాలా బ్రహ్మాండంగా చాలా బాగా చేస్తున్నారు. ఐ రియల్లీ అప్రిషియేట్ డాక్టర్ మల్లీశ్వరి మేడం, డాక్టర్ లలిత, Seshi Kiran, and all the team of AMS team who are really doing a marvelous job. Thank you.
Thank you, ma'am. Now I request Dr. Mallishwari to share few words.
Respected dignities on the dais and off the dais, and respected seniors and my dear colleagues, a warm welcome to all of you for this first physical cross-speciality CME organizing by IMA AMS with support from Women Doctors Wing and IMA body Nandyal. As IMA AMS President, it's an honor to host this CME today. I'm very happy to say that we have received good number of registrations than expected. I'm sure you will all enjoy the talks and have fruitful interactions with the speakers and update ourselves. As Masudan Rao sir told, if you are not updated, you are outdated. In future, we will try to do more and more CMEs like this. Thank you, support from all of you. Thank you.
Thank you, ma'am. Now I request Dr. Ravi Krishna sir, the constant force behind us, to share few words.
On the occasion of IMA Nandyal one-day CME program, the presiding officer for the inauguration ceremony, Dr. K. Srinivas Rao, President of IMA Nandyal branch, and State IMA Joint Secretary Dr. B. Panil Kumar, and today's CMA Program Observer Dr. A. Vijayabhaskar Reddy, immediate IMA Nandyal Branch President Dr. C. Madhusudan Rao sir, and State Working Committee members Dr. K. Madhusudan Reddy, Dr. Vasudha Rani, Dr. Harita, and State IMA Doctors, Women Doctors Wing Secretary Dr. Lakshmi Saujanya, IMA Nandyal Women Doctors President Dr. Madhavi, Secretary Dr. Sailaja, and AMS President Dr. Mallishwari, and Secretary Dr. Lalita, and Treasurer Shashikiran, and Coordinator Dr. Sushma, and Honorary Chairpersons of Women Doctors Wing Dr. Narmada, Mission Pink Health Chairperson Dr. Nagamani, and my dear, and Dr. Sahajavud sir, Senior Surgeon and past IMA Nandyal Branch President, and my dear friends and senior colleagues and friends. IMA Nandyal is very well known throughout the state for organizing a lot of activities, both academic activities and service activities. Especially Women Doctors Wing is very popular in the entire state. And recently, Kakinada organized a Sankranti program, and there Dr. G.S. Murthy was past state president. He messaged me, we are inspired by IMA Nandyal and organizing Sankranti celebrations like you are doing in Nandyal. And recently, after seeing some postings in our IMA Nandyal branch, lot of specialty work is being executed by the specialists and super specialists in Nandyal. So I thought of starting a one-day CME program with all speakers from Nandyal only. So today it has been released, and the observer also from Nandyal only, and all the chairpersons Nandyal. And we will organize another CME in the month of May. Probably it will be sponsored by ISA Nandyal or Ophthalmological Society of Nandyal. And today's CME is sponsored by Nandyal Urological Society. We thank Dr. Bhargavardhan Reddy, Dr. Srikant Reddy, Dr. Ramesh, and Dr. Vijay Jay Babu for accepting to sponsor this program. And today we have started a medical update IMA Nandyal YouTube channel. So today the CME program is also given YouTube live streaming, and it will be uploaded into the YouTube after the CME program. You can share the YouTube link to your friends, and it will be there permanently in the YouTube. Even after that also, those who are interested to present scientific programs, presentations, or their personal experiences in their day-to-day practice, they can record their speeches, they can present their multimedia presentations, and if they give it, we will upload into the Medical Update IMA Nandyal YouTube channel. And shortly, next month, we are going to start another IMA Nandyal channel, YouTube channel, that is for the public health awareness program. So IMA Nandyal, doctors, so many doctors are there, they can share their knowledge to the public to educate them regarding the health awareness programs. And already Women Doctors Wing is organizing a lot of health awareness programs in the schools and colleges. Yesterday only they have done an excellent program in association with the Inadu newspaper on the occasion of National Girl Child Day in Government Girls School. In fact, they have approached us. Inadu approached us. We want to organize the National Girl Child Day, and please inform Women Doctors Wing to participate. And all the women doctors, 6 doctors went there and educated the girls on different aspects. So public health awareness YouTube channel also we will start. Through that we will enlighten the public regarding health awareness, and also we will propagate proper methods of following health care. And instead of going to RMPs, we will advise them to approach the qualified practitioners. And as Dr. Madhusudan Reddy told, when I was president and Dr. Madhusudan Reddy was secretary, and I did as president of IMA Nandyal for 3 years, with Dr. Masudan Reddy for 1 year and with Dr. Vijay Bhaskar Reddy 2 years. Even at that time also, for every CME program, we used to get CME credit hours from Hyderabad in the combined state. 1 CME credit hour for each CME. So many credit hours we have received during that time, and now we are planning to organize CME credit hours, CME programs. And another program I have proposed to the women doctors wing is, when I was president of IMA AP state, I have organized IMA UCon in association with women doctors wing, and also AMS of IMA AP state and Mission Pink Health of IMA AP state. One day CME, all the speakers, women doctors, different specialties, all the chairpersons and including observer, women doctors. And we have given it a virtual program, Zoom link. With Zoom link we have given that with 4 CME credit hours, we have done that IMA UCon. Nearly 3,000 people registered and attended on the virtual program. That was organized by Dr. Vasudharani, Dr. Lakshmi Saujanya from Nandyal, and different women doctor leaders from the different places. So I proposed IMA Nandyal Women Doctors Wing. Shortly, in the month of March, I think, I proposed to organize a virtual CME for the 1 day from morning 10 a.m. to evening 5 p.m. with all speakers from Nandyal, that too women doctors. Women doctors belonging to different specialties will present IMA Nandyal CME virtual program. We will circulate it in the entire country so that we can showcase the academic talent or academic interest and academic excellence of IMA Nandyal doctors. So we are going to organize another CME, virtual CME with CME credit hours with all women doctor speakers with different specialities. So ఈ రకంగా ఈరోజు సిఎంఈ క్రెడిట్ అవర్స్తో మనం ప్రోగ్రామ్ చేసుకున్నాం. ఐ థింక్ ఇందాక మన డాక్టర్ ఐఎంఏ ప్రెసిడెంట్ చెప్పినట్టుగా perhaps this is the first time a branch organizing a one-day CME with CME credit hours with all their speakers from their own branch, local speaker, only belonging to one branch, entire speakers with CME credit hours. Probably this is the first time a branch is organizing such a program. And I should appreciate Dr. Lalita and Dr. Mallishwari, AMS wing President Secretary and Coordinator Susma and Treasurer Sheshikiran. For the last 1 month, they did lot of homework for organizing this program. I used to give advices only, but they have executed everything. They have contacted the speakers and collected everything. And Dr. Panila also helped a lot. And I think we will organize similar programs in the future also. Along with these academic activities, we are proudly announced that IMA Women Doctors Wing is doing excellent work. Almost every day, every alternate day, cervical cancer programs చేశారు వీళ్ళు. న్యూస్ పేపర్స్ కూడా 2-3 సార్లు పంపించారు. సిమిలర్ ప్రోగ్రామ్స్ ఆల్టర్నేట్ డేస్ రోజు వస్తున్నాయి సార్, ఇదే ప్రోగ్రామ్స్ అంటే డిఫరెంట్ ప్లేసెస్లో జరుగుతున్నాయని చెప్పాం. నిన్న ఆర్గనైజ్ చేశారు. అండ్ డే బిఫోర్ ఎస్టర్డే వీ హ్యావ్ ప్రజెంటెడ్ ఎ స్పోర్ట్స్ కిట్ టు ది డిజేబుల్డ్ డెఫ్ అండ్ డమ్ స్కూల్ ఆల్సో. సో ఉమెన్ డాక్టర్స్ వింగ్ ఈజ్ డూయింగ్ లాట్ ఆఫ్ యాక్టివిటీ. And Dr. Masudan Rao sir also doing lot of activity in colleges and schools, are conducting personality development courses, motivational classes he is organizing. And already we all know that what he is doing in Swargadamam. So with all your cooperation, we will continue our academic activities, social service activities and health awareness activities. And this update, I request all the members to utilize to present your topics in the medical update IMA Nandyal YouTube channel, and also contribute to the shortly going to be started YouTube channel for the health awareness of the public. And ultimately we organize CME programs not only to update our knowledge, the updated knowledge of the doctors will indirectly or directly help the patients because they will get better treatment when they come to hospitals. So with these words, I congratulate all the organizers for organizing this program, and I thank all the speakers also for coming forward to present these topics. Thank you, one and all.
Thank you, sir, for your kind and encouraging words. With your constant guidance and support, we hope we will reach to our expectations, sir. Now, it's the time for memento presentations to the speakers. Now I request yes, sir. Now I request Dr. Prashant, Dr. Ravindranath Reddy. Yes, sir. I request Dr. Hindumati Madam. I request Dr. Hindumati Madam. Now I request Dr. Pavan Kumar Reddy Garu. Now I request Dr. Madhusudan Rao sir. We request Dr. Bhargavardhan Reddy Garu. Aruna Madam. Dr. Aruna Kumari ma'am.
వస్తున్నారు సార్. పోట్ డాక్టర్ లక్ష్మీ సౌజన్య మ్యామ్. డాక్టర్ శ్రీహర్ష. డాక్టర్ రవీందర్. భాస్కర్ సార్ Dr. Vijay Reddy, sir. APMC observer for the CME.
అబ్జర్వర్ మన లోకల్ బ్రాంచ్ అని మనం ఇగ్నోర్ చేయడానికి లేదు. అబ్జర్వర్ ఏపీఎంసీ అబ్జర్వర్. థ్యాంక్ యూ డాక్టర్ ఏ విజయభాస్కర్ రెడ్డి ఫర్ కమింగ్ యాజ్ అబ్జర్వర్.
Request Dr. G. Ravakrishna sir to please receive the memento. Dr. Shiva.
Dr. Munir sir from IMA Nandyal branch, he passed away last year, and we have received 3 checks for his sir's wife and daughter-in-law. We request them to come to receive the checks. Dr. Enna Parao Family Security Scheme lo member Dr. Munir sir. Nandyal IMA branch నుండి ఉన్నారు. ఆయన ఐఎంఏ ఎఫ్ఎస్ఎస్ స్కీమ్ నుండి 9.5 lakhs సార్ మిసెస్కి టోటల్ 19 lakhs. టోటల్ 19 lakhs. అది ఎఫ్ఎస్ఎస్లో వీ కెన్ డివైడ్ సార్ 50% సార్ మిసెస్ పేరు మీద, 25% డాటర్కి, 25% డాటర్ ఇన్ లాక్. నమస్తే అమ్మా.
I request all the speakers to come near to the dais for a group photo. Sir, kindly bring your mementos if possible.
వద్దులేండి మా, వదిలే మొమెంటోలు పట్టుకొని ఎందుకులేండి, స్పోర్ట్స్లో గెలిచినట్టు ఎందుకు. మామూలు మా ఆఫీస్లో స్పోర్ట్స్లో గెలిచిన వాళ్ళందరికీ మొమెంటోస్ ఇచ్చి గ్రూప్ ఫోటో తీసుకుంటా అంట మా స్పోర్ట్స్ ఇట్లా వచ్చినప్పుడు. ఎందుకు పైన నిలబడచ్చు. అదే మనం వద్దా, రండి రండి. మోసన్ సార్ స్పీకర్, ఏఎంఎస్ వింగ్ వాళ్ళు రండి. మధు సార్ రండి సార్, స్పీకర్స్ ఫోటో ఇది. మధుసూదన్ రెడ్డి రండి. స్పీకర్స్తో పాటు ఆర్గనైజర్స్ ఏం లేదులే. వినోద్ ఫోటో తీస్తున్నాడు అంటే నెక్స్ట్ మినిట్లో అది స్ప్రెడ్ అయిపోతుంది, వైరల్ అయిపోతుంది. అది కాదు, సగం తీసావా ఏంటి? తీసినారు కదా. అబ్జర్వర్ రెడీ ఉన్నా.
లాస్ట్ స్టేషన్ ఒక హాఫ్ క్రెడిట్ పాయింట్ కట్.
ఓకే. Thank you. We request the AMS wing to continue the sessions.
Vote of thanks by Dr. Shashikiran.
A warm good evening to all. On behalf of the organizing committee, it is my proud privilege to propose the vote of thanks on the occasion of this cross-specialty CME. First and foremost, we express our sincere gratitude to the Almighty for blessing us to successfully conduct this CME. And we extend our heartfelt thanks to our IMA Nandyal President, Dr. K. Srinivasrao Sir, Secretary and its members, and IMA Women Doctors Wing President, Dr. Madhavi Ma'am, Secretary Dr. Shailja Ma'am, and members for guidance and encouragement. We gratefully acknowledge Urology Society of Nandyal and its President, Dr. R.K.GURRALA Reddy Sir, for his support. And we offer our sincere thanks to Dr. Ravikrishna Sir, former IMA President AP and Central Working Committee member of IMA, for his time, constant guidance, and valuable insights. We respectfully thank Dr. Madhusudan Rao Sir for the venue, Madhumani Conference Hall, which is a great venue for smooth conduction of the CME. And we sincerely thank Dr. Vijay Bhaskar Reddy Sir, who is today's APMC observer. It is our privilege to thank today's speakers for enriching the CME with their academic excellence and making the session highly informative. Our sincere appreciation goes to all the delegates who have registered for the CME and are actively participating in the CME. And we thank the print and digital media for the support. We thank the efforts of all the supporting staff, paramedics, volunteers who have made the CME happen smoothly. Our sincere apologies if we inadvertently missed to acknowledge anybody. And we humbly thank all our senior colleagues, madams and sirs, who have been constant source of inspiration and mentorship and guidance. Thank you all for making this physical Thank you all for making this first physical CME conducted by IMA AMS a grand success, and we look forward to conduct more CMEs in future. Thank you all.
Hello.
We'll move on to our next session. The topic is snoring from Puranas to present notable points for every doctor. We present our internationally acclaimed senior ENT surgeon of Nandyal, Dr. C. Madhusudan Rao Sir, who is a sleep surgeon specialist. He did his MS from PGI Chandigarh. Senior ENT surgeon, Madhumani Nursing Home, and past president of AOI IP. Thank you, sir. I request Dr. Vinod sir and Dr. Maheshwari sir to please chair the session. Sir, kindly stick on to time. There will be a bell at 13 minutes. Alert at 13 minutes, sir.
Ade bhayanga undamma.
Sir. I request Dr. Shravani and Dr. Tanuja to compliment the chairpersons.
Very friendly chairpersons, my colleagues Dr. Vinod, Dr. Maheshwari Reddy and others. It's just an evening chit-chat. Madhusudan Rao in front of you. Notable points to every doctor. I am not going to speak any serious topic, but certainly an interesting one. He lights, Vijay. Kumbhakarna, who is the father of snoring. Madhumani is the killer of snoring. That much I can say. The first point to be noted down. I already told, if you do not get updated, you will be outdated. I'm not going to speak volumes of knowledge of academic interest in ENT, but I'm going to give you a very take-home points, very useful for snoring. After Lalita calling me, doing snoring surgery, especially it takes 3 to 4 hours for us. Manideep is also doing. It is very difficult to cut short such a big problem in 15 minutes. Easy for me to do 4 hours surgery than to cut down to 15 minutes of this. Snoring, number 1, is considered as a deep ecstatic sleep. Bah! ఎంత బాగా నిద్రపోతున్నాడు రాయుడు, ఎంత బాగా గురక పెడుతున్నాడు అని అనుకుంటున్నారు. ది ఫస్ట్ ఈజ్ మోస్ట్ ఇంపార్టెంట్, దట్ పర్సన్ ఈజ్ నాట్ ఇన్ డీప్ స్లీప్. He is not in deep sleep. His mind is always awake. Oxygen levels are making him, carbon dioxide is accumulating, and total air passage is getting compromised. Why this happening? Snoring is not a sound sleep. There is only sound and there is no sleep. రైల్లో పడుతుంటాం, వాడేమో శబ్దం చేస్తూ నిద్రపోతుంటాడు, మనకు శబ్దం ఉంటుంది, వానికి నిద్ర ఉంటుంది అనుకుంటున్నాము. Snoring has become a third point. Second is global epidemic syndrome. Just type in Google what is the percentage of people who are snorers. What will be the percentage for you to imagine? 40 to 50% of above 60 people do snore, but they are not that to be taken into a very serious consideration. But most important is pediatric snoring has become global syndrome. Old people above 65 like us snoring, no problem. But a child from first year or second year, his snoring means how much amount of mechanical airway obstruction. If a child is taking a breathing like this, how do parents sleep? But you have to read this sentence. Snoring has become a global epidemic syndrome in children, affecting right from 1 year of age to 12 years. Surgery gives best results after maximum medical treatment by pediatricians for 3 to 4 cycles. Take enough amount of time. Don't think that a pediatric snoring child certainly needs surgery. But certainly if the patient is not responding, next will come. మనకు కంకర రోడ్లు ఉంటాయి, మనము ఎద్దుల బండిలో రోడ్లో పోతూ ఉంటాం. బిఎండబ్ల్యూలో 120 కిలోమీటర్ల స్పీడ్లో పోతాం నంద్యాల టు హైదరాబాద్. ఎలా ఉంటుంది? స్మూత్గా ఉంటుంది. మన ఎయిర్వే కూడా అట్లా ఉండాలి. అందుకే ఐ హ్యావ్ టేకెన్ దిస్ పిక్చర్. ఇఫ్ ది బుల్లకాట్లో మనం ఈ గతుకుల రోడ్లో పోతుంటే డబా 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 అని ఎట్లా శబ్దం చేస్తుందో మన ఎయిర్వే కూడా అట్లే శబ్దం చేస్తుంది. Suppose if you are going in a BMW in highway, it is so smooth. Now the snoring surgeons are making your rough road into a National Highway Authority of India roads. How that is done, you will come to know. First of all of you take this point. If any of your friend, relative, somebody tells that my child is snoring, my husband is snoring, my wife is snoring, take and ask them to get a 1-minute video, and you will see this 1-minute video how this child snores. And that boy is lying in left lateral position with both lips are open, upper incisors are visible, and he is sleeping. This is not a healthy child. This boy will always have troubles. And see this child, how much amount of effort that boy is making. He is just 1.5-year-old child, retrosternal and also jiffy sternum, and you can see, and we are doing an endoscopy. I am doing an, I think that video is not actually playing to be played. We are doing a pediatric endoscopy for this child with sevoflurane and we could see huge amount of adenoids blocking. That child, same child, the other child, snoring with froth. Froth is nothing like, don't think it's serious because he's snoring, that's all. The biggest myth, tonsils and are police for our body. It's a big myth. పోలీసు మనకు ప్రొటెక్షన్ ఇవ్వాలి, అల్లర్లు దొంగతనాలు చేయకుండా. పోలీసే దొంగతనం చేస్తున్నాడు, పోలీసే అల్లర్లు, పోలీసే గలబా చేస్తున్నాడు. ఆ పోలీసుతో ఉంటేనేమి లేకపోతేనేమి. Tonsils and adenoids have stopped working for the defense system. So remove. If many people will ask our question, సార్ టాన్సిల్స్ తీసేస్తుంటే పెరగరంట కదా సార్, ఇమ్యూనిటీ పోతుందంట సార్, మా వాడికి వస్తుంటే ఇప్పుడు ఆల్రెడీ అవి ఇంకా ఎక్కువ డ్యామేజ్ ఉంటాయని. పోలీస్ హార్మింగ్ is nothing. Tonsils and adenoids are no more a defense and protecting immunity organs in children who suffer from recurrent respiratory tract infections. These two doesn't have any role. We have millions of lymphatic system in the body. ఈ మాత్రం దారిలో పోతూ ఉంటే ఒక చెట్టు పడిపోతే తీసి పెట్టేయచ్చు, ఓకే, ఒక 10 మంది. Suppose this block like this, how can you remove this? You have to take a big machine, cut off and take the highway. That's what snoring surgeons we are doing for adenoids. Adenoids are very small issue thing that, but it gives wonderful results. And see, if you don't do, these are all our Madhumani data. How much amount of high arched palate, prominent incisor teeth. This boy is 13 years old. The amount of therapies he is going with dentists and malocclusion. We have done surgery for him for adenoids. If this child would undergone at the age of 3 or 4 years, all these things would not happen. We have now seen a Pyrie-Robinson syndrome with retrognathia. This brother and sister, mother is also same. These two children we have operated last month and we had terrible difficulty to intubate. I think Madhavi is there. I also tried to intubate, Madhavi also tried to intubate. With last effort, we could get an airway for this child. And both her mother also there. But now, before surgery, see amount of opening and how they are now happy. And even a 2-year children can have adenoid surgery with modern coblation. Now Madhumani is going to get most werewolf Smith and Nephew advanced coblation machine, maybe in another 15 days we are purchasing. And it has a rapid coblation technique like advanced what urology people were showing. These people, and I'll just show a video. This is actually Jagan Mohan Reddy's son Vakul's video and how it works. And there are 3 electrodes are able to see. In between these 3 electrodes there is a suction channel. It cuts just like a ఆవాల గింజలను ఆ సైజులో కట్ చేస్తుంది, ఇరిగేట్ చేస్తుంది, లిక్విడ్ మీడియం సలైన్ మీడియం అండ్ సక్స్ అవుట్ అండ్ ఇన్స్టాంట్ హీమోస్టేసిస్. ఐఎమ్ టెలింగ్ యూ, there will not be sometimes even a few drops of blood, but time. It takes time. A good anesthetist, good airway, both are being shared by this thing. That we should be very careful. And finally you can go, the picture will be total opening of this. See the amount of mechanical block being removed. Such will be the dramatic result. And these are all children, a small 3 years old kid coming, doctor, I am very happy, ma papa baga nidrabotundi. Even both brothers at a time getting surgery. We are having at families, brother, sister, both brothers, sisters and brothers. Now, what is the difference between pediatric and adult snoring? Excellent, immediate. They get surgery, evening, sir, my child is sleeping, dramatic. Adults are not like that. Better and excellent, takes time, but depends on the case, how best. Contrary, one snoring patient of Srinivas Koti, cardiothoracic surgeon, and we posted and prepared everything for surgery and went for cardiovascular clearance. We came to know he is having blocks, and within few weeks he passed away. Not this thing. Such a cardiovascular you have to screen before surgery. This is with permission, Sindhu, gynecologist, Jagan's son Vakul. Morning surgery done, afternoon at 2 o'clock, Vakul is getting discharged, and I am operating. You can see the cobbletter machine and endoscope, and Jagan, Sindhu are observing, and the boy is hardly not even 2 years, legs like a captain. మా విఐపి రూమ్ ముందు నన్ను నడుచుకుంటూ తిరుగుతుంటూ అసలు వీడిని నిద్రపుచ్చడానికి ఇద్దరు ఆయాలను పెట్టుకున్నారు జగన్ సింధు with the permission, and that surgery has shown them. And these are all, Deepu is doing a lot of, she is an ENT surgeon, Divya Rana, 1 year, 9 months child Mihira from Tirupati. Husband is a Raghunath, he is a pediatrician, and she came from Tirupati. Last month only we have done. Just want to show the dramatic, instantaneous results of this awareness with pediatricians. Really, I had to salute all the pediatricians in Nandyal. They treating wonderfully well, not responding. Simple X-ray adenoids, mass identified, grade 3 to 4. If this thing, after giving good amount of medical therapy, steroid therapy, not responding, then only for surgery. Adult snoring, now coming pediatrics, obesity, lifestyle, comorbidities, and anatomical blocks. These are all to be taken care of. This recently coming from South Zone conference, I recorded this video. Vijayawada railway station, and both of them see they have put their chappals as pillows. ఎక్కడ ఎత్తుపోతారో మనం నిద్రపోయి గురక పెడుతూ ఉంటే అక్కడ ఎదురుగా వెయిటింగ్లో చూస్తున్నాడు, నేను దీపు ఇంకా దాని నుంచి వచ్చినాము, అంతే ఇతను బాగా నిద్రపోతున్నాడు, మనకు కట్టే సమస్య. అంటే స్నోరింగ్ డజంట్ నీడ్, నాలుకకు రుచి ఎరగదు, గురకకు కూడా స్థలంతో సంబంధం లేదు, ఎక్కడ పడుకున్నా, బెడ్రూమ్లో పడుకున్నా, ఎక్కడ పడుకున్నా కూడా వచ్చేస్తుంటారు. కౌన్సిలింగ్, రామాయణం మాదిరి గురకాయనం. We have made a very good pamphlet available. వస్తూనే గురకాయనం ఇచ్చేస్తాం, చదవమని చెప్తాం, దాంట్లో ప్రశ్నలు ఉంటాయి, మధుమణి నర్సింహంలో చేయాలి. ఇది రివర్స్ ఈ మధ్య ఎక్కువనే అవుతుంది, అట్లేం లేదు, అక్కడ దిండు కప్పుకున్నది ఏదో వైఫ్ అని కాదు, సర్జన్ కాదు. అండ్ 3 days back one husband has come, married 6 months back, wife is pregnant, and she is so pestering that if you don't get your snoring relieved, I will not come after delivery. Such a threatening situations are there. Levels of snoring. Level 1, ముక్కు లోపల ఉన్నదంతా level 1. నోరు తెరిచినప్పుడు కనపడేది level 2. బేస్ ఆఫ్ టంగ్ నుంచి ఎపిగ్లాటిస్ అని కిందికి level 3. Level 3 surgery is dangerous because very, very complicated base of tongue, epiglottis. Level 1, level 2. Minimum we do 6 to 8 procedures at a time. Septoplasty, turbinectomy, anidoidectomy, valopharyngeal incompetence, tonsillectomy, bubulectomy, modified jetaplasty, remove both tonsils, suture both pillars, stretch out, and do everything in one sitting. And just after a few days they will have wonderful healing. And you just see the amount of snoring. This person is closed his lips, still he is struggling this thing. And this is, you can see this Nagarjun Reddy, and his message is also there.
డాక్టర్ నరసింహారావు సార్ని ఖర్చుమని చెప్పడం జరిగింది. నేను జనవరి 30వ తారీఖు 7 సర్జరీలు చేసి సార్ మాకు ఈ స్నోరింగ్ ప్లస్ ఈ ముక్కులో అంతా నీట్గా చేశాడు. ఇప్పుడు నాకు
Madhumani Nursing Home is a snoring center recognized now. We are doing multi-level snoring surgeries for level 2 and level 2. Now we are extending to tongue-based reduction also. So we want to establish as snoring referral center, and you know there are 3 now. Sureka is also there. Multi-level snoring surgery really challenging, and we can't just jump into the snoring field because years of seeing the cases, and but rewarding both to the patients and doctors, but enormous preparation. Last, come to the diagnosis, whole thing, polysomnography dies. This is a CBCT machine. You can see in 30 seconds, it takes 300 CT images and gives the total picture of axial, coronal as well as axial. Sleep study, we have 2 sleep labs in Madhumani, night 9:30, morning 6 o'clock, we give sedation, go to sleep, it assesses everything. Next we take to the theatre, give 15 cc of propofol, do drug-induced sleep endoscopy, where we pass a bronchoscope, I personally doing, and Manideep, Rohit, everybody does this dice, and we will actually see when he is in snoring with deep propofol, what is happening inside? Where is the block? Where is the obstruction? Then you can easily show him the video, but anesthesia workstation, and you should be ready with oxygen. Snoring is curable. Establishing a snoring center in peripheral and rural center of India, 21st and 22nd, 23rd, I am presenting in Marriott Hotel in Mumbai. How a peripheral rural place of India can have a good tertiary referral snoring center also. But only thing is, we have to get trained. Medical versus surgical. Many people will ask, what is the medical treatment? Is very good. Positional sleep, weight reduction, thyroid and exercise. And this is another feedback I don't want to take. And if they don't want surgery, when surgery is not done, CPAP is the best. Don't worry, 65 years, triple vessel block, thyroid, diabetes, CKD, pulmonologist, asthma, you can't do surgery to all these patients. Then give him a CPAP machine, they can sleep wonderfully well. No surgery, CPAP is best, 30 to 35,000. You can get even rental, 2,000 rupees per month. They'll keep in your house. Happily you can sleep, not disturbing your life partner. Madhumani family, thank you very much. I think I have 15 minutes to rush through, and presenting what is to be done in snoring is only this thing. Thank you for all your, because snoring itself, only surgical procedure one takes 1 hour, more than that.
మధుమని స్నోరింగ్ సర్జరీ ప్రారంభించిన తర్వాత లాయర్లు, కోర్టులు, జడ్జిలు కంప్లైంట్ చేస్తున్నారు, విడాకుల కేసులు తగ్గిపోయాయని.
Sir, wonderful presentation, sir.
Thank you, Mahen.
The images are wonderful.
Images, నేను కూర్చొని I struggled with ChatGPT and artificial intelligence to make these slides more interesting, but it takes time.
Any questions from the audience?
Harsha. Actually, Pyrie Robinson syndrome, retrognathia, tongue base, hypomaxilla, very coined face, everything. But we have done only to give her a good airway. But they have to go for mandibular advancements. The total, both mandibular condyles will be fractured and brought. Avanni Nandyal level kaadu. Yeah, for her adenotonsillectomy with sinus wash, both brother and sister. Mother is also having the same features, but got married, gave birth to 2 children. But she is not worried about this thing.
So they are giving consistent results with Pyrie
Syndrome.
That patient had adenotonsils also, sir, but she will need maxillary splitting, maxillary rapid advancement, then mandibular advancement. That all will be done after 10 years by an OMFS. In this case, it wasn't indicated, but it was a tough intubation because of the anterior larynx, protuberant teeth, and very short neck.
Challenging was anesthesia. Really, it was challenging. We could intubate luckily, otherwise we had to do tracheostomy.
Sir, what is the prevalence, sir, in adult population snoring? Because every now and then every relative will be asking, he snores and all like that.
Deepu, he's...
In US right now, because of obesity, it's around 20 to 25. there is no proper prevalence study in India. But in India, because of our culture, we think snoring is a healthy sign of a good sleep. That's what we tell our patients. That is a disadvantage in our culture, but now people are getting more awareness. Even many films are making it sure that there are no proper treatments for snoring. If you take like so many, I think one Good Night or Satya Prem Ki, some all films say snoring is it's an acceptable thing, partners should accept and sleep. So it's very underreported, sadly, but we are doing our best as an ENT. But pulmonology people are diagnosing it a lot. We are fighting on that note also, because they only suggest CPAP, they don't suggest surgery. That is an interdisciplinary understanding and diagnosing and referral, sir. But there is no proper prevalence study in India.
Thank you.
Thank you, sir, for taking us from Puranas to present on very common problem, snoring, and now which is curable at Madhumani Nursing Home. Next, I welcome next speaker, Dr. Bhargavardhan Reddy, sir. Sir is the first super specialist in Nandyal, and I request Dr. Sahadevdu sir and Dr. Madhavi ma'am to chair the sessions. I request Dr. Susuma ma'am and Dr. Krishnaveni to compliment the chairpersons.
ఎందుకు స్లీప్ మోడ్లోకి వెళ్తాం? ఏంటి? Thank you, IMA AMS Nandyal chapter, for giving me this opportunity to share my knowledge about evaluation of renal pain. But organization has given me a tough time. It is very difficult to speak after the ever youthful, legendary international speaker like Masuro sir. So I will try my level best. So flank pain. Here the difference comes from loin, and what is the difference between loin, flank and the groin? Loin means the area of between the area between the costal margin, iliac crest, and this is the paraspinal region, and this is a posterior axillary line. This is called as a loin. Flank means between anterior and posterior axillary lines. The groin means an area above and below the inguinal ligament is called as the groin. It is often immediately assumed that when a patient present with a flank pain or loin pain has a stone in the ureter or kidney. However, only 50% of the patients present with the flank or loin pain have ureteric stone confirmed on imaging studies. So the other 50% have non-stone related disease. The differential diagnosis is vast, and it depends on the age, sex of the patient and side of the pain side. There are multiple causes of the flank pain. An extent reflect the fact that the nerve root subserving the pain sensation from the kidney also subserve the pain sensation of other organs. So pain derived from T10 to T12 costal nerves can also be confused with the renal colic. The pain sensation from the kidney primarily transmitted via the preganglionic sympathetic nerves that reach spinal cord levels between T10 to L2. So every patient, any renal colic patient will have the other symptoms of like nausea and vomitings if it is carries to the stomach, and the patients will have the tennis mesh-like sensation, and the patient will have frequency and urgency and radiation towards the groin, and the few patients will have radiation to the gonads and the genitals because of the cross innervation. What is the pathophysiology of the pain mechanism? Renal colic happens when a stone gets obstructed in the ureter, not at all a stone, but other things like fungal balls, any papillary necrosis like that. If any obstruction occurs in the ureter, it will cause the distension of the renal epithelium, urothelium, and the stretching of the capsule. These two things will cause the pain, and there are also certain release of the inflammatory responses. So there is increased vascular permeability leading to the ureteral edema and the ureteral smooth muscle spasm, inflammatory response and the prostaglandins release, and pylolymphatic backflow and the capsular stress. These are the causes of the renal pain whenever there is obstruction in the ureter. So I will divide this colic into the three topics: renal colic, and those are the atypical presentations, and last one is the non-renal causes. The first and important things are in the evaluation of renal colic are history taking, examinations, and investigations. History taking, these are the classical history whenever patient presented with a renal colic: severe flank pain originating in the costovertebral angle, radiating anteriorly, inferiorly towards the groin. These are associated symptoms like nausea, frequency of urine, pseudo-retention like symptoms, dysuria, sometimes hematuria, and fever with chills. But the problem nowadays is most of the presentations are atypical. We are very sparsely seeing the classical presentations because of the multiple things like Google, availability of the painkillers on over the counter, and the manipulation or treatment by the primary physicians or RMPs at the local levels. We are now getting very atypical presentations. The history taking is an art అని మన బుక్స్లో చదువుకొని ఉంటాం, లైక్ ఇన్ మాన్యువల్స్, హచిసన్ మాన్యువల్ కానీ దాస్ మాన్యువల్ కానీ. అండ్ మన సీనియర్స్ లైక్ మధుసూదన్ సార్, సహదేవుడు సార్ సాఫ్ట్గా మాట్లాడాలి పేషెంట్స్తో వైల్ టేకింగ్ హిస్టరీ అని చెప్తుంటారు. బట్ ఇట్ ఇస్ వెరీ డిఫికల్ట్ నవ్ ఏ డేస్ టు టేక్ ది హిస్టరీ ఫ్రమ్ పేషెంట్. ఒక ఎగ్జాంపుల్ చెప్తాను. ఒక పేషెంట్ వస్తాడు, అయ్యా చెప్పండి అయ్యా మీ ప్రాబ్లం ఏంటి అంటే, సార్ నాకు స్టోన్ ఉంది సార్, కార్డు తెచ్చుకున్నాను సార్, ఆరోగ్యశ్రీ కార్డు ఆపరేషన్ చేశారంట. అట్లా కాదయ్యా, అసలు హాస్పిటల్కి ఎందుకు వచ్చావు, నీకు ఏం ప్రాబ్లం ఉండే? లేదు సార్ స్టోన్ ఉంది సార్, మా డాక్టర్ చెప్పాడు సార్, స్కానింగ్ సార్, స్కానింగ్ చూడండి సార్, స్కానింగ్ సార్. అట్లా కాదయ్యా, పెయిన్ ఉందా, వామిటింగ్స్ ఉన్నాయంటే, ఇప్పుడు ఏం లేవు సార్, ఎప్పుడో వారం ఉండండి సార్, ఇప్పుడు ఏం లేవు సార్, స్టోన్ ఉంది సార్, ఆపరేషన్ చేయండి, కార్డు ఉంది. సరే సరే ఇన్వెస్టిగేషన్ చూస్తే వీ ఫౌండ్ ద 3 mm నాన్ అబ్స్ట్రక్టివ్ క్యాలిక్యులస్ ఇన్ రైట్ కిడ్నీ. నీకు పెయిన్ ఎక్కడుంది అంటే లెఫ్ట్ కిడ్నీ అని. ఇది రైట్ కిడ్నీలో ఉందయ్యా, నువ్వేమో లెఫ్ట్ కిడ్నీలో. అట్లెట్ అవుతుంది సార్, తప్పు చేసింటారులే సార్, నువ్వు ఆపరేషన్ చేశారు, నాకు రాయి తీసేశారు. దిస్ ఈస్ ద టైప్ ఆఫ్ పేషెంట్స్ వీఆర్ గెటింగ్ నవ్ డేస్. సో ఇట్ ఈస్ వెరీ డిఫికల్ట్ టు ఎక్స్ట్రాక్ట్ ద హిస్టరీ. So the pain is characteristically very sudden in onset and increasing severity, followed by the reduction in severity. It radiates to the groin as the stone passes to the lower ureter. The pain may change in location from the flank to the groin, but it is not classical always. The location of the pain doesn't provide a good indication of the position of the stone, except in cases of we use a stone like this. If the patient is having frequency and urgency sensation and the pain radiating to the radiating the penis and testis, he may having the stone in the intramural position like a vesicular junction. And while examination also, there is some differentiating points. You can differentiate between the renal colic and the non-renal colic. The renal colic patient want to move around in an attempt to get a comfortable position. But on the other hand, in patients of peritonitis, such as appendicitis and ruptured ectopic pregnancy, twisted ovarian cyst, want to lie very still. So any movement is very painful. In particular, in peritonitis cases, they do not like palpation also. So pain may radiate to the tip of the shoulder. This means you are not dealing with the urological cases. In peritonitis cases only, pain radiates to the tip of the shoulder or scapula because of the irritation of the phrenic nerve. So thus when you approach patients, just spend a few seconds looking at them. If they are lying very still, you may be dealing with a non-renal case. So here also we are getting trouble. When patient is in casualty, when you are observing the patient and when you are asking multiple questions like left unda, right unda, mundu vastunda, vomiting vastunda, tumminappudu ekku avutunda, దగ్గినప్పుడు పక్కనోడు అనుకుంటుంటాడు ఏంది డాక్టరు పెయిన్ ఉంటే పెయిన్ తగ్గించకుండా ఈ నానా క్వశ్చన్లు అనేవి చంపుతున్నాడు అని పక్కన అటెండర్ అనుకుంటుంటాడు. సో దిస్ వెరీ డిఫికల్ట్ టు ట్రీట్ ఇమ్మీడియట్లీ బికాస్ who may be dealing with sometimes a myocardial infarction, because sometimes renal colic may radiate to the epigastric region, and all adult patients with whoever presented with the epigastric pain, he may be having myocardial infarction without seeing his vitals and without observing the patient, without at least without come to a conclusion, primary conclusion. It is very difficult to treat the patients. It is very difficult to give us at least analgesics also in this era. So pain on other sides may be renal and other causes also there. Examination, the basic examination like abdominal palpation and renal angle palpation is very important. Many times we miss, especially in females, many times we miss these ruptured ectopic pregnancies and twisted ovarian cyst. Come to the basic investigations. Ultrasound is the first and foremost investigation we will advise to the renal colic patient, and followed by the CT scan, maybe contrast or IVP, renal function test, uric acid, serum uric acid in few patients and recurrent renal colic patient, and the plain abdominal X-ray. This is the ultrasound showing, this is the kidney, this is the hydronephrosis, and here is the stone. See the stone here at the VUJ calculus. This is the VUJ calculus. Shadowing of the, you can clearly observe the shadow, post-acoustic shadowing. The problem with ultrasound is that it is a subjective area, subjective. Whenever there is a hydronephrosis, it is very easy to pick up the stone. See this case, this is a CT scan. The ultrasound showed normal, but patient has a classic renal colic, so we advised CT scan. See, this is no hydronephrosis, so it is very difficult to pick up the stone in ultrasound. So CT scan showing the distal aortic calculus. And nowadays very less role for the X-ray KUB. For the follow-up, we can use the with X-ray KUB and IVP. So how to manage this renal colics? If the size of the stone is, for ureteric calculi, if the size of the stone is less than 7 to 8 mm, which is who is having mild pain with no infection clinically or investigational wise, with the normal renal functions, when there is a medical facilities available in and around, we can treat medically. Why I stress this? Because we can't advise conservative management in sailors who is sailing in the sea for 6 months to 1 year, and we can't advise conservative treatment for pilots. We can treat with the alpha blocker. This is the first and foremost drug in renal colics. Alpha blocker means tamsulosin or silodosin, low dose diuretics, analgesics depending on the renal function, NSAIDs or tramadol or paracetamol 1000 mg IV, low dose steroids like deflazacort, alkanizing syrups, and dietary recommendations. So when you come to surgical, we can treat these patients with the various modalities depending on the indication. If the renal stone in the kidney like here less than 10 mm, we can treat with ESWL, stone in the ureter URSL, stone in the kidney PCNL and RIRS, stone in the bladder CLT. And this is recently we are doing, this is the advanced lasers. This is the old Holme-Mac laser. This is the new TFL laser. See the amount of energy with the TFL laser. This is the advanced TFL laser, more than 2.5 centimeter stone. We are doing laser with the TFL laser, which is most advanced in the world nowadays. So within 15 to 20 minutes, total 2.5 centimeter stone fragmented, became dust. This is up to the classic renal colic. Why I have taken this basic evaluation of renal colic whenever patient has non-atypical presentations. This is one of the presentation, a 60-year female patient with uncontrolled diabetic presented with the right loin pain since 2 days with mild fever. Ultrasound shows only mild hydronephrosis, mild rise in count, serum creatinine is 1.4, loss of taste is for 3 days, BP is decreasing trend 106, previous day it is 110, only 4 decreased, but pulse rate is 110. It's a very good indicator of the total entire body. Pulse rate is 110. So I advise CT scan, plain CT scan is also showed only mild hydronephrosis, no stone is there. Then I have suspected papillary necrosis because of the uncontrolled sugar, because of the rising pulse rate and rising trend of creatinine. But they didn't listen for degestenting because it is surgical thing. And next day they came with again fever. Then on that day I advise CT scan. So see the CT scan, there are multiple non-enhancing regions. See the poorly functioning kidney. Then we have done degestenting. With the difficulty, we have counseled the patient and done degestenting. See the amount of pus coming from this ureteric orifice. After passing a guide wire, video is not playing well. So see the pus is coming from the ureteric orifice. See the jets of pus coming. So this is one of the atypical case. With the difficulty we found one sign, pulse rate is 112. Again we poked history multiple times, then she is giving history of fever for 3 days duration. Then NCCT is also showing normal. With the suspicion of past history and the pulse rate, we have started IV antibiotics. So these are the atypical cases. And few patients present with only testis pain. Only testis pain. So all testis pain in teenage boys, it is very important to advise a Doppler test because you may be dealing with the torsion of the testis or epidermolysis. So you have to examine whenever there is nothing in the clinical examination. Sometimes you may be dealing with the VUJ calculus. VUJ calculus patients also present with the only testis pain. So you must order one ultrasound Doppler scrotum, and if you can call to radiologist for the screening of the VUJ region. And few patients will present with only vomitings. 1 week back, one patient presented, a 50-year patient presented with only vomiting, nothing else. We have tested the creatinine, it is 8. It is 8. So these are the most of the atypical presentations are there sometimes. Only patients will present with only hematuria. Sometimes patients with present with frequency of sensation of defecation, that is tenesmus. And few patients present with pseudo retention. They will say there is retention of the urine, but if you catheterize, nothing will be there. So whenever patients present with the classical ureteric colic with retention, you can do, or you can put a probe with the ultrasound. If there is any post-wire residue, then only catheterize. Don't do catheterize unnecessary. There are the non-renal causes. There are the multiple non-renal causes are there. Medical causes also there. We have to check for this is the pleurisy. Sometimes myocarditis is also present with the left ureteric colic. In those patients, you have to ask for the palpitations. So in gynecology cases, twisted ovarian tumors and the ruptured ectopic pregnancies. Biliary colic, this is the gallbladder edema with the gallbladder calculus. This is the appendicitis also will present like a ureteric colic. And left-sided patients, pancreatitis tip of, whenever there is a inflammation of tip of the pancreas, and diverticulitis, and the leaking abdominal aneurysms will also present like ureteric colic. And dermatological, this is my case only. Initially I missed this 3 days back. He presented with this one. He said only loin pain radiating to the groin. See this, loin radiating to the groin. Just I advised ultrasound, it is normal, I have written some painkillers. 3 days back again came, sir, itching is there. Then I lifted his shirt, see this, herpes zoster. So inspection and palpation are very important in our clinical examination. So to conclude, loin pain evaluation requires systematic clinical and radiological assessment. Imaging with NCCT is gold standard for accurate diagnosis for the renal calculi. Early recognition of life-threatening conditions are essential, especially for papillary necrosis patient in uncontrolled diabetics, especially in females. Individual management based on etiology ensures optimal outcomes. Thank you. Thank you for giving me this opportunity.
Any question from the audience? సిఎంఏస్లో ఆడియన్స్ రకరకాలుగా ఉంటారు. ముందు మాట్లాడిన స్పీకరు పక్కాలతో మాట్లాడుతుంటాడు, నేను బాగా చెప్పానా అని. తర్వాత మాట్లాడే పోయి స్పీకరు ఎప్పుడు ముగిస్తాడో అని అనుకుంటుంటారు. ఆర్గనైజర్స్ ఇది ఎప్పుడైపోతుందో టైం చూస్తూ ఉంటారు, ఈయన 15 నిమిషాలు అయిపోయిందా లేదా. కాబట్టి సిఎంఈలో ఎవ్వరూ విన్నా వినకపోయినా చైర్పర్సన్స్ వినాల్సి వస్తుంది, ఎందుకంటే గడియారం ఎప్పుడైపోతుందో. కాబట్టి మాకు ఈ అవకాశం ఇచ్చినందుకు కోర్స్ నిజానికి భార్గవ్, నేను ఎంఎస్ చేసిన తర్వాత డాక్టర్ విక్రమ్ సింహారెడ్డి గారి స్ఫూర్తితో యూరాలజీ చేయాలనుకున్నాను. అనుకోకుండా నేను తప్పిపోయినా, నువ్వు యూరాలజీ చేసావు. కంగ్రాచులేషన్స్.
థ్యాంక్ యూ.
Sir, if in ultrasound we give normal study or a microlith or very minimal hydronephrosis, how are you going to counsel the patient to undergo rest of the investigations?
No, I will see for clinical thing. Even CT scan gives normals many times. I will call to the CT scan technician and ask to search for ureter, entire ureter for the reconstructive study. If the clinical condition warrants, if it is the classical pain, at least classical radiating pain, at least with one of the symptom like nausea, dysuria, hematuria, one of the symptom associated with, so I will, even CT scan I don't trust. I will ask the technician to reconstruct the images once or twice. So clinical condition is the very important. If ultrasound is normal, clinical condition not warranting, then it's okay. Otherwise we will do CT scan.
Thank you, sir.
Work out. Forced dialysis has very less role, sir, because obstruction, if already patient is in obstructing system. So if you give forced dialysis, so where will we go this the entire urine secreted urine? So it will reflect back into the system, leading to the sepsis, or somewhere kidney will rupture and perinephric collection will come, urinoma will come, and leading to the sepsis, urosepsis. Yeah, yes sir, yes sir. Yes. Recently also many, local physicians will do, like they will write 3 RL, 3 NS with 2 ml of Lasix, 3 ml of Lasix. No role, sir, no role, sir. And that's why I have written as low dose diuretic. Low dose diuretic is advised. At least some push we need some push, not excessive force.
Sir, earlier days,
because the kidneys are soft structures.
To relieve the pain, antispasmodics were tried. Sir. But later on, the simple analgesics like diclofenac is giving better results. Earlier we were used to give some cyclopam or other
yes,
things.
Sir, yes, sir. Diclo is the analgesic of choice, sir.
Yes, sir.
But if renal function compromises, then that is the problem.
Serum
in
creatinine
casualty,
normal.
we will give diclo. Then creatinine comes 1.3, 1.4.
Yes.
He may question.
Yes, sir.
So if you want to give diclo, without notice you can give. Okay. Without written anything, you can give. Or paracetamol 1000 mg is the best choice. According to books, best analgesic is the morphine, but morphine is not available.
Thank you so much for your expert talk, sir. For the next session, I request Dr. Arna Kumari ma'am to deliver her talk. She is working as senior consultant at Naravati Multi-Speciality Hospital with her special interest in hysteroscopy and genital tuberculosis. To chair the session, I request Dr. Radhika Jyoti ma'am and Dr. Nagareka ma'am. To present books to them, I request Dr. Fatima and Dr. Shilpa ma'am to give books to the chairpersons.
Good evening to all. I am Dr. Aruna. I thank. Good evening all. I am Dr. Aruna. I thank IMA, IMA-MS, Dr. Malleshwari, Dr. Lalita for giving me this opportunity. Hope all of you have seen Kalki movie, Kalki 2898 AD, and enjoyed the movie. Declining fertility, is this a fiction or it is reflecting the fact? In this movie, hero lives in a society which is oppressed and the society is suffering with the misery. And there is a complex. It controls the life and death politics and segregates women based on their reproductive ability. Women who are able to conceive are treated as valuable, but are essentially confined and used as vessels for scientific experimentation with their wombs, artificially seeded in a program called Project K. Whereas the society, this dystopian reality, in this society, the women are infertile, even the animals are infertile, showed as animals also infertile. Globally, fertility rates have been falling rapidly for decades, a trend that is progressing across most nations. This real-world phenomena is a major topic of discussion among demographers and economists. Fertility rate has fallen significantly from 5 births per woman in 1950 to 2.2 in 2021. Many high-income nations and increasingly developing ones like India are already well below this rate. This has a very high socio-economic impact. A continued dramatic drop in population is predicted to result in significant economic and societal shifts, including potential labor shortages and increased strain on social welfare systems as the population ages. In the movie, they have shown it as controlled reproduction, which led to the infertility, controlled reproduction, and the society which led to the infertility. But in real scenario, the increased education of girls and women, greater access to the contraception, and individual choices to have smaller families and no children led to decreased ovarian reserve. What is meant by diminished ovarian reserve? Diminished ovarian reserve means fewer eggs. This impacts the fertility and overall health of the female. Coming to the causes, age is the most important cause for infertility. With increasing age, the ovarian reserve decreases. During intrauterine life, every female fetus has 7 million eggs, but at the time of birth, it's only 1 to 2 millions. Out of these, 400 oocytes will be released during reproductive period. Genetics also plays an important role. Most of the autoimmune disorders are associated with diminished ovarian reserve. Premature menopause and it runs in the families. Fragile X syndrome and premature menopause will run in families. Coming to the medical treatments, treatments like chemotherapy, radiotherapy will also cause diminished ovarian reserve. Surgeries, especially laparoscopic ovarian drilling and ovarian cystectomies where excessive cautery is used, all these lead to the damage of the ovary and in turn leads to the diminished ovarian reserve. Lifestyle factors like smoking, stress, diet, weight and toxins have impact on ovarian reserve. Stress messes up with the hormones, so it leads to the diminished ovarian reserve. Excessive weight or underweight also leads to ovarian reserve. Whenever female improves her diet and sleep patterns, then the ovarian reserve shows much better. This is the ovary of the female. It has no eggs at all. This is a case of diminished ovarian reserve. This picture also shows the ovary. This is the ovary and this is the uterus. No eggs at all. And this is the ovary. This is showing PCOD picture with multiple follicles. What are the symptoms of diminished ovarian reserve? Usually diminished ovarian reserve patients will be asymptomatic, but some may show anovulatory cycles or amenorrhea, may suffer from dry vagina, dry skin, may have osteoporosis, may have bone fractures, increased incidence of bone fractures is seen in these female patients. How to diagnose the diminished ovarian reserve? Diminished ovarian reserve can be diagnosed with the help of hormone tests like FSH, AMH and estradiol, and using ultrasound AFC count. Coming to the treatment options, changes in the diet and stress management may improve some amount of ovarian reserve. Fertility medications like ovulation induction may help if the patient's AMH is 1 to 2. If the AMH is less than 1, we can prefer IVF, or if fertility medications fails, then also we can prefer IVF. AMH less than 0.7, then patient may need donor eggs. From 0.7 to 2, we can suggest IVF treatment to the patients. The other option is freezing of eggs or embryos if the patient wants to delay her childbearing. Coming to the emerging techniques, ovarian tissue cryopreservation. If patient wants to postpone her fertility, then she can opt for freezing of eggs or embryo. If she is married, she can opt for freezing of embryos. If she is unmarried, she can opt for freezing of the eggs. This ovarian tissue cryopreservation, it is helpful in patients who are suffering with cancer or with endometriosis or with chocolate cysts. Then you can freeze the ovarian tissue, which we may implant in future, or you can culture the oocytes from these ovarian tissue in the IVF lab, and you can use those eggs for IVF. Another treatment modality is IVM, maturing oocytes in the lab. Ovarian organoids. We can create 3D ovarian structure for oocyte development and maturation. Stem cells. Stem cells from the bone can be used to generate ovarian tissue. Thank you.
మేడం ఒక్క నిమిషం మేడం షిఫ్ట్ పట్టది రిమూవ్ చేస్తాం. మేడం ఓకే మేడం నేను ఇస్తాను.
Ovarian cortex, primary oocytes are there in the ovarian cortex. In freezing the ovarian tissue, we will freeze the ovarian cortex. Very thin, 1 to 2 millimeters thickness of ovarian tissue is frozen in the media. Usually we will implant those either in the ovarian base or in the underneath the skin, in the arm. We can transfer the frozen tissue. It will develop its own blood supply. Then it will, after inducing with oral ovulations or gonadotropins, oocytes will develop in that ovarian tissue. Five years.
Mother is postponing her motherhood. We have to cryo-freeze the semen also at the same time.
If she is married, embryo cryopreservation is the better option than oocyte cryopreservation.
Okay.
Because oocyte is the largest cell in the body. It has so much of cytoplasm. Replacing that much cytoplasm with these medications is very difficult.
If the mother is opting for freezing of the eggs after marriage only, at the same time will you cryopreserve sperms also?
Instead of freezing egg and sperm separately, we can freeze the embryo.
Embryo, okay.
If she is not willing the embryo cryopreservation, then we can opt for oocyte cryopreservation.
That is also for 5 years, embryo also. Thank you.
Sorry, it may be out of the topic, but however, that I want to know just what is the role of cure cell therapy, cure cell in relation to stem cell therapy.
I don't know, sir. I never heard.
Thank you, Aruna ma'am, for very informative topic. Thank you, ma'am. Now I request Dr. Koti Srinivas sir to present high-risk cardiac surgeries in Nandyal and their experience. Sir is a consultant cardiothoracic surgeon in Indus Heart Institute. They have upgraded our Nandyal to a super specialty, not a town, a corporate setup. One stop for everything. Now I request chairpersons Dr. Venugopal Gupta sir and Dr. Jahangir sir to chair the session.
Hello. 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 Good evening, sir. Jahangir sir.
Dr. Jahangir sir. I request Dr. Madhupreeti and Dr. Sharmila to compliment the chairpersons. Dr. Sharmila.
Good evening, everyone. So we started doing cardiac surgery since last 3.5 years in Indus Heart Institute. So apart from doing regular coronary artery bypass surgery and valve replacement, we have done some high-risk cases and some interesting cases also. So I wanted to present our mix-up of cases in this brief presentation. So I'm going to discuss about these cases. One is free wall rupture of LV, left ventricle, coronary stent pseudoaneurysm, large mediastinal mass, left atrial myxoma. Couple of redo cardiac surgery cases we did, and recently we started doing minimal invasive cardiac surgery also. And the last slide about the statistics. So coming to the first case, it's free wall rupture of left ventricle is a dangerous complication of mechanical complication of myocardial infarction. So the other complications are papillary muscle rupture of mitral valve, which leads to severe mitral regurgitation. Okay, sure. So the first mechanical complication is papillary muscle rupture of mitral valve, which leads to severe mitral regurgitation. Patient presents with acute pulmonary edema, and the other is the ventricular septal rupture. They present with circulatory collapse.
and the another mechanical complication is a free wall rupture. So pseudoaneurysm is a sequel of free wall rupture of the left ventricle. So whenever patient ignores angina or dyspnea, usually after 4th or 5th day, they'll have a transmural infarct, and they'll have a transmural infarct, and the left ventricle muscle gets thinned out and it's fragile and it ruptures. So blood from the left ventricle seeps and enters the pericardial cavity. So then we'll have a left ventricle rupture, free wall rupture. So coming to our case is a 55-year-old male, came with severe dyspnea in severe hypotension. We have to start on higher inotropes. ECG showed massive anterior wall MI, and echo showed large pericardial effusion with clots surrounding the left ventricle. So usually in this type of cases, we have very less time. We have to try to convince the patient, do a emergency angiogram and try to shift the patient to OT. So emergency angiogram was done. We shifted to OT immediately, went on emergency bypass, on emergency heart-lung machine, arrested the heart. After opening, this is what we found. This is the tear in the anterolateral wall of the left ventricle. So this is the tear in. Thank you, sir. Thank you. So this is the tear in the anterolateral wall of the left ventricle. This is a free wall rupture of the left ventricle. So we repaired this entire tear with the Teflon patch using 4-0-proline, and we did a saphenous vein graft to left anterior descending artery. So CABG and free wall rupture repair was done. So shifted to ICU with very high dose of inotropes. Patient got discharged on 6th day and he is doing well on follow-up. Similar case, we have a second case, a 72-year-old female, again present with similar complaints with severe dyspnea and angina and severe hypotension in cardiogenic shock. ECG showed massive anterior wall MI, and echo showed large pericardial effusion. Because she is a 72-year-old female, it's very hard for us to convince the attenders and regarding the risk involved with the surgery. We did an emergency angiogram and shifted directly to OT from the cath lab. After opening, we went on the heart-lung machine, arrested the heart, and this is what we found. This is the tear in the anterolateral wall of the left ventricle with a large hematoma. So similar to the previous case, we did a Teflon patch repair with the 4-0-proline. I used 2 patches, but because she's 72-year-old female, the heart muscle is so fragile and thin, it's like I'm taking bites on the butter or cheese. So whenever I take a bite, it's cutting through. So the muscle is cutting through, so I have to use another patch to buttress and to support the ruptured myocardium. Later we did a saphenous vein graft to LAD. This is a saphenous vein graft to LAD. So again we did CABG plus free wall rupture repair. So this is after repair. This is the saphenous vein graft to LAD, and this is the ruptured myocardium. Sorry. Video
I request the audience, please make less less noise.
Video.
Whispering is okay, but not more than that.
So this is after repair. Once we come off bypass, we are checking whether the muscle is even after when the heart muscle contracts, the repair should be intact. It should not get cut through and they should not be bleeding. So we are checking for the bleeding, and the heart muscle is intact and there is no bleeding. So shifted to ICU with higher inotropes. Post-op, she went into pulmonary complications and AKA, and gradually she was improved and discharged on 7th day and doing well on follow-up. So these 2 cases, they are very challenging. Usually free wall rupture of left ventricle, they carry very high mortality. We will not have much time. Hardly they reach to operation theatre. Within 10 minutes, either they'll collapse, they have the cardiac arrest. Luckily, they survived till that time and were able to successfully manage these 2 cases. Coming to the next case, 22-year-old male came with severe dyspnea. He was evaluated outside hospital with X-ray and CT chest. There is a large anterior mediastinal mass indenting on the superior vena cava and ascending aorta. So this is a classical X-ray picture which shows typical superior mediastinal widening, and this is the CT image. If you can see, this is the mass which is compressing on the heart. So this is the heart. In the below picture, you can see this is the mass. You can see this is the ascending aorta with the arch vessel. So this entire mass is indenting on ascending aorta and the arch vessels. So we planned for sternotomy and anterior mediastinal mass excision. So after sternotomy, this is the head end, this is the leg end. We did sternotomy. We can't see any heart. It's completely covered with the mass. So this entire thing is the mass. Here we can see LV apex. Only apex of the heart is seen. So we did gentle and careful dissection around the heart, safeguarding all the superior major vascular structures, superior vena cava and ascending aorta and the arch vessels. So this is the picture after removing the mass. So this is the innominate vein. This is the SVC joining into the right atrium. This is the ascending aorta. This is the right ventricle. Here you can see 3 markings. These are the indentation markings because the mass is compressing on the RV. These are the indentation markings on the right ventricle. So we removed entire mass in situ and we sent for histopathology. This is the mass. It's around 15 centimeters length and 10 centimeters width. So patient got discharged on 5th day and was on regular follow-up. He is doing well. Histopathology showed it as a thymoma. So coming to another interesting case, is a 48-year-old male. He underwent coronary stenting to left anterior descending artery. After 1.5 years of stenting, he presented with dyspnea and angina. So on clinical evaluation, he had severe LV dysfunction. We did a coronary angiogram. I'll show you the angiogram also. Angiogram showed large pseudoaneurysm of the LAD at stent with minimal flow in the LAD. So it was very challenging case. We were thinking among ourselves whether we should do here or we should send somewhere. So after convincing the patient and we decided to operate here, we planned for CABG and LAD aneurysm repair. So this is the angiogram image. You can see this is the left main coronary artery. You can see this structure. This is the coronary stent pseudoaneurysm. This is a stent. You can see minimal flow in the LAD. There is no flow in, this is the minimal flow in the LAD. So there is no flow in the LAD. So our plan is to excise the aneurysm and try to repair the coronary artery. So I'll show you how far we are successful in it. So we planned for elective surgery, went on bypass, went on heart-lung machine and arrested the heart. And after arresting the heart, we tried to opening the aneurysm. It was so hard and dense adhesions that it was very difficult for us to open the aneurysm itself. So we opened the aneurysm. So there are a lot of clots in the aneurysm which are densely adherent to the aneurysmal wall. So we excised and removed all the aneurysmal clots. After removing the aneurysmal clots, then we identified the stent. So stent was densely adherent to the aneurysmal wall. So when we are trying to remove the stent, the entire coronary wall is also coming along with the stent. So then we try to remove the stent. You can see the metal structure on my left hand. So this is the stent. We are trying to pull out the stent right from the origin of the coronary artery to the mid left anterior descending artery. So this is the excised stent, it's a small metal piece. We excise the stent. So you can see this is the proximal opening of the left anterior descending artery. This is the distal opening of the left anterior descending artery. Initially we thought we can repair this coronary artery, but it's not possible because this entire 2 centimeters length of coronary artery is very badly and diffusely diseased. So we thought we'll close this opening and we'll put a distal graft to the LAD. So we put a distal saphenous vein graft to the LAD to maintain flow to the coronary artery, and we repaired this entire sac. To repair this damaged and diseased coronary artery is not an easy task. So we tried to close it with a, so I'll just, this is the aneurysm, this is the proximal opening, and this is the distal opening. So we took a small pericardial patch. We took a small pericardial patch and closed the proximal opening of the aneurysm. So pericardium is the best structure which we can use inside the heart with less minimal bleeding. So we close the entire proximal opening with the pericardium, and we close the entire opening with the distal opening with the pericardium. And we close the entire sac with the Teflon patch. So we sacrifice this part of the coronary and we put a distal saphenous vein to the distal LAD so that the flow is maintained. So patient came off bypass very well, and he got discharged on 6th day, and he's doing well on follow-up. Coronary stent pseudoaneurysms are very rare. Maybe out of 1,000 or 10,000, we hardly get 1 or 2 cases. There is very few cases, even in the literature also. So it's not possible without the team effort with our cardiologist and our cardiac anesthetist. So the next case, this is not a high-risk case, but one of the interesting cases we had. It's in a left atrial myxoma. 35-year-old female came with dyspnea and palpitations. On evaluation with the echo, there's a large LA myxoma in the left atrium. We planned for excision of the LA myxoma. This is the echo findings. So if you can see, this is a 3 to 4 centimeter mass. This is the left atrium. This is the left ventricle. It's indenting on the mitral valve. It's compressing on the mitral valve, and the patient is having a clinical scenario similar to mitral stenosis. So these are the gradients across the mitral valve. So you can see mass from the LA entering into the LV and obstructing the mitral valve. So we planned for excision of left atrial myxoma. So this is a small video showing the surgery. This is the mass. That is the entire mass which we removed. So the key to this surgery is to remove the entire mass in toto, remove the pedicle where it is attached to the left atrium, and prevent any small piece of embolism, and patient should not have any brain stroke postoperatively. So patient discharged on 4th day and is doing well, and histopathology confirmed the diagnosis of myxoma. It's a benign tumor. So another case, this case we did around 3 years ago. It's an infective endocarditis of the aortic valve. 65-year-old male with grade 3 to grade 4 dyspnea since 4 months. We received patient on ventilator in AKA and in sepsis. So initially we thought we'll manage with higher antibiotics, but patient general condition gradually worsened. We thought we'll give a last chance. We planned for an emergency high-risk aortic valve replacement. Post-operatively, he gradually recovered and discharged on 9th day, doing well on follow-up since 2 years. Redo cardiac surgeries, we did couple of redo cardiac surgeries. 23-year-old male, he underwent mitral valve repair when he's at 12 years of age. Now again came with dyspnea and palpitations after 10 years. Echo showed severe mitral restenosis and moderate MR. We planned for a redo mitral valve replacement. The challenge with the redo cardiac surgery, heart gets stuck to the sternum because of the primary cardiac surgery. So it's very difficult for us to separate the sternum from the heart. Successfully we separated the heart, and there are dense adhesions surrounding heart. We can't see the cardiac structures. So we have to carefully dissect all the cardiac structures, and there is a mitral valve ring here. If you can see, the mitral valve ring gets completely embedded in the left atrial wall. We have to carefully excise the old mitral valve ring. So this is the excised mitral valve ring, and we replaced with a new mitral valve. So patient got discharged on 5th day and stable on 3-year follow-up. So I want brief couple of slides on minimal invasive cardiac surgery cases. We started minimal invasive since 4 to 5 months. This is the left anterior thoracotomy, which is used for CABG. This is the harvesting of internal mammary artery. So patient will have this scar. This scar can be minimized, And this will require a double lumen endotracheal tube with left lung isolation and left anterior thoracotomy incision for CABG. This is another patient, female patient, which is having a large ostium secundum ASD, again double lumen endotracheal tube for right lung isolation. This is the cosmetic inframammary incision. This incision can be used for ASD closure, mitral valve replacement. So this is the inframammary incision. So I finished my cases, and these are the total number of cases which we did since last 3.5 years. So apart from routine CABGs and valve replacements, we did a large variety of cases, although they are small in number. But this is not possible. This is not a one-man show. Definitely, I should thank our cardiac anesthetist, Dr. Shravani, and our cardiologist, Dr. Jahangir sir, Murli sir, and Kranti sir. And thank you all. Thank you, IMA Nandyal, for giving me this opportunity. Thank you. Sir.
నాకు ఒక ఏదో హిస్టరీ గుర్తుకొచ్చింది. పాతకాలం ఒకసారి సతీ సావిత్రి ఆయన యమధర్మరాజుని వేడుకొని బతికించుకుంది వాళ్ళ పతిని. మీరు ఎలా ఉన్నారంటే మీరు ఆ యమధర్మరాజును ఛాలెంజ్ చేసి బతికించారు వీళ్ళందరినీ. సో ఇలాంటిది ఒక నంద్యాల లాంటి పెరిఫెరల్ సెంటర్లో 1996లో నేను వచ్చినప్పుడు యాంజైనా పెక్టోరిస్ అంటే తెలియదు ఎవరికి ఇక్కడ. అప్పుడు ఎంఐ కేసును వచ్చి నేను అడ్మిట్ చేసి ట్రీట్మెంట్ ఇస్తానయ్యా నాకున్న ఆ పరిమిత నాలెడ్జ్తో అంటే నమ్మేవాళ్ళు కాదు. ఏంటి సార్ హార్ట్ అటాక్ను అడ్మిట్ చేసుకుంటారా, చచ్చిపోతే మీ కథ ఏంటనేవాళ్ళు. డాక్టర్స్ కూడా భయపెట్టారు, ఒరే బాబు ఇది ఎమర్జెన్సీ రా, కర్నూలు పోయినా చచ్చిపోతాడు, ఇక్కడున్నా చచ్చిపోతాడు, ఎంఐ ఈజ్ ఎ మెడికల్ ఎమర్జెన్సీ, ఇప్పుడున్న పరిస్థితుల్లో ఎక్కడ వీలైతే అక్కడే ట్రీట్మెంట్ ఇవ్వాలా అని చెప్పి అప్పట్లో చేసేవాడిని. అట్లాంటిది ఇంత సర్జరీస్ ఇప్పుడు నంద్యాలకు వచ్చాయంటే రియల్లీ ఐఎమ్ వెరీ వెరీ హ్యాపీ.
థ్యాంక్ యూ సార్. థ్యాంక్ యూ.
ఇట్స్ వెరీ నైస్ అండ్ ఐఎమ్ కాన్ఫిడెంట్ నౌ. యూ నో వై ఐఎమ్ టెలింగ్ దిస్. ఇప్పుడు నాకేమన్నా అయితే నేను ఎక్కడికి వెళ్ళను, ఇంకా వచ్చేసి ఇక్కడే ఉంటా, ఎందుకంటే బిల్లు కూడా తగ్గిపోతుంది కాబట్టి.
థ్యాంక్ యూ సార్. థ్యాంక్ యూ.
ఒక 6 సంవత్సరాల అమ్మాయికి మరుసటి రోజు ఓపెన్ హార్ట్ సర్జరీ ఉందట. ఆ రోజు రాత్రి సిటీ సర్జన్ రౌండ్స్ వేస్తూ ఉంటే అమ్మాయి అడిగిందట, రేపు నాకు ఆపరేషన్ చేస్తారు కదా, నా గుండె తెరిచినప్పుడు అందులో దేవుడు ఎట్లా ఉన్నాడో చూపించండి అని. అంటే దేవుడు లోపల కాదమ్మా ఇక్కడే ఉన్నాడు.
థ్యాంక్ యూ సార్. థ్యాంక్ యూ.
ఎనీ క్వశ్చన్స్ ఫ్రమ్ ది ఆడియన్స్ ప్లీజ్?
That was an excellent presentation, sir. Your expertise and clarity are impressive, and your passion for CT surgery is clearly evident in your work. And Team India's is really a boon to Nandyal. Thank you for your work, sir. Yes.
Koti sir, in your census slide, you missed about mentioning also managing heart diseases in pregnant and postpartum women. Because of you and your cardiac anesthetist and the cardiologist, I'm able to manage pregnancies with heart diseases. Thank you for your support.
Thank you, sir. Next, I invite the next speaker, Dr. U. Lakshmi Saujanya ma'am, for her talk on menopause 360 degrees from hot flushes to heart health.
Small comment, madam. So first of all, I would like to congratulate Dr. Koti Srinivas sir for his services to the people of Nandyal and surroundings. And the more important thing I would like to tell about him is, I would like to call him a poor man's surgeon. So sir was telling that bill tagutundi and chepta unnaru. So all these complex surgeries doing under the R.K.GURRALA scheme, and you can expect what is going on inside Indus. So I would like to congratulate Srinivas sir and internal supporting system Dr. Shravani madam for their senses all these things. Yeah, thank you.
Thank you, sir.
Pushpa.
To present books to ma'am.
everyone. I thank IMA AMS Nandyal for giving me this opportunity to talk to you on menopause 360 degrees from hot flushes to heart health. We, on behalf of Life Hospital, representing my junior colleagues Pushpa, Sushma, Hema, Madhuvani, Geetanjali and Sravanti. Menopause is cessation of menses for 12 months or more. It marks the period from reproductive status to non-reproductive status. It is a natural process of aging which is marked by the declining ovarian function and falling estrogen levels that leads to various symptoms, many of which can be challenging. The most commonly distressing symptoms are vasomotor symptoms, genitourinary syndrome because of estrogen lack, cardiovascular risk like dyslipidemia, atherogenic risk, and osteoporosis. Is it really required to diagnose menopause? Not really in all the cases, but when a woman has symptoms, we need to confirm the diagnosis by the cessation of menses of more than 12 months and increased FSH more than 40 and estrogen less than 20. The mean age of menopause in India is 46 years. The life expectancy of women in India is 70 years. So 10% of population is in this menopause age, and non-communicable diseases like diabetes, cardiovascular diseases, stroke, which are increased because of estrogen lack after menopause, accounts for 60% of the deaths. So we need to address this problem in a great way. According to Modifies Anclasaria's Indian Menopause Society Consensus Group, the menopause is staged into 4 stages. During the first stage, that is 2 to 3 years before menopause to 1 year after the menopause, most often these women experience vasomotor symptoms like hot flushes, sweating, palpitations, sleep disorders and mood changes. From 1 year after menopause to 5 years, they may have urogenital atrophy and dyspareunia, vaginal dryness, and urinary tract symptoms like urgency and increased frequency of urine because of endothelial epithelium lining thinning. And 5 years after menopause, they may experience complications like osteoporosis, atherosclerosis, coronary artery disease, and cerebrovascular disease. All these are because of the estrogen deficiency that happens after menopause. So when a woman comes to menopause, it's an opportunity for us to examine her as a whole. We need to check her blood pressure, waist circumference because of increased tendency of weight gain after menopause, breast examination, and we need to advise mammography, and pap smear to rule out cervical cancer risk, and ultrasound to see the endometrial pathology and the ovarian pathology. And the lab parameters, we need to check her complete blood picture, sugar levels, lipid profile, thyroid hormone, and pap smear, TV, transvaginal scan and mammogram as already said. So the question is, does every menopausal woman need hormone therapy? There was earlier in 2001 and 2, it was advised to advise hormone replacement therapy for every woman. But there was a big threat that was shown by WHI study, Women Health Initiative study. This study was conducted for the women who were taking hormone replacement therapy, and they found that when the study was going on, many women were dying because of heart risk and stroke, and the study has to be abruptly stopped. The main drawback of this study was the age was not considered. It included every menopausal women right from 45 years to above 60 years. So later on, various studies were done, and they found that between 45 to 60 years, with caution, menopause hormone replacement therapy is safe. For premenopausal women, that is for below 50 years, when there is premature menopause or surgical menopause below 50 years, the woman has to be given menopause hormone replacement therapy till the age of menopause, natural age of menopause. And from 50 to 60 years, if she has any symptoms like vasomotor symptoms like hot flushes or urogenital atrophy, cardiovascular risk or osteoporosis risk, clear-cut osteoporosis risk, women has to be given menopause replacement therapy. And they clearly, the recent studies say after 60 years, MHT should not be given. The various estrogens that are available are 17-beta estradiol, estradiol valerate, and conjugate equine estrogen. Does the estrogen matter? Yes, definitely it matters, because earlier we used to use conjugated equine estrogen, but it has 2 to 3 times extra load on liver, and bioavailability of the drug is very less. Now we have drugs like micronized 17-beta estradiol, which is very close to the endogenous estrogen produced in the body, and with minimum liver load and much lesser risk of vascular thromboembolism. And coming to the progesterones has to be added to estrogen when the woman has uterus, because it to reduce the risk of endometrial hyperplasia and endometrial cancer. Earlier, medroxyprogesterone acetate was used a lot, but these days we have moved on to micronized progesterone and dydrogesterone because of the close proximity to natural endogenous progesterone in the body. And medroxyprogesterone acetate on long-term use in this age group is associated with increased risk of cancer. So coming to the management plan of menopause, any women without menopausal symptoms, usually replacement therapy is not advised. But if the woman undergoes premature menopause and surgical menopause, we have to give hormone replacement therapy, though there are no symptoms. Suppose if she has symptoms, we have to give based on the complaint. A 50-year-old female with complaints of hot flushes, sweating and palpitations and sleep disturbances. She has irregular periods since 1 year and vaginal dryness. So this is a case of vasomotor symptoms. We have to differentiate this from menopause-related hormone dysfunction, hyperthyroidism, and generalized anxiety disorder. Confirm it by FSH, and then menopause-related, this is a clear-cut case of menopause-related symptom, and hormone replacement therapy should be given. So coming to the hormone replacement therapy, now we have tablets available like Femostone. Suppose if the woman has uterus, we have to supplement with estrogen progesterone combination pill, and if the woman is hysterectomized, we can give estrogen only pills. This is available for us, 17-beta estradiol 1 milligram and 10 milligrams of dufestone. And this can be given either in the oral form, transdermal form. This is the patch, estrogen patch, but this is not widely available for us. Estrogen gel is available in India. A 60-year-old female, hypertensive for 10 years, complaining of burning and itching in vulva with increased urinary frequency and urgency. Many a times we see this kind of scenarios, but unfortunately many a times these women go to many of us with the diagnosis of urinary tract infection, and she must have gone through various courses of antibiotics. Sometimes we have to realize that it is a case of genitourinary syndrome of menopause, and the treatment is simple estrogen vaginal cream, which helps in recovering normal vaginal flora, improve division of vaginal epithelium, and induce proliferation of capillaries. And non-estrogen agents, wherever the estrogen creams are contraindicated, like in cases of breast cancer or patients with risk of breast cancer, the estrogen creams are contraindicated. We can go with non-estrogen agents like osmifene, dihydroepiandrosterone. Vaginal moisturizers and lubricants also go a long way in helping these patients. Hormone therapy in patients with cardiovascular disease risk factors is not preferable. Non-oral estrogens like transdermal estrogens and micronized progesterone dydrogesterone combination are safe. And age of starting therapy is very important. Above 60 years, it is advised not to start on hormone therapy, and if it can be started for women between 50 to 60 years or from within 10 years after starting of menopause. And hormone therapy in breast CA related issues, a patient with generalized risk can be prescribed. With benign breast disease, we can prescribe if the patient has symptoms. Breast cancer survivors should not be given hormonal contraceptive. They can go with non-hormonal therapies, and even vaginal creams are contraindicated for breast cancer survivors. The DVT risk and stroke risk is very minimal below the age of 60 years, but it is high after the age of 60 years. So what is important here for us to understand is the age is the major determinant of risk and benefit of menopause hormone replacement therapy. Below 50 years, the benefits far outweigh the risks. So for premature menopause and surgical menopause, we have to start if the patient is young, before the age of menopause, and should continue till the age of natural menopause. Between 50 to 60 years with menopausal symptoms, yes, we have to start. And after 60 years, risks outweigh the benefits, hence it should be avoided. So with hormone replacement therapy, the quality of life improves in terms of all the symptoms. A 51-year-old female presenting with hot flush, vaginal dryness, started on hormone therapy. She complains of irregular bleeding now, breast tenderness, and has high density breasts. What do we do? Now the hormone therapy, estrogen, progesterone is a relative contraindication. Now the drug of choice is tibolone. It is a synthetic steroid with estrogenic, progesterogenic and androgenic action. It is useful for vasomotor symptom, genitourinary syndrome and osteopenia. And the advantage of this drug is there is no endometrial hyperplasia, and it has can be used in patients with dense breasts because it has no effect on estrogen receptors present in the breast and the endometrium. And it should be started 1 year after the menopause. It is available in 2.5 milligram and 1.25 milligram dose. SERMs are the other drugs which can be used for menopause patients, but this is not contraindicated in hot flushes and urogenital symptoms. A 44-year-old woman has hot flushes, hypothyroid on treatment. Sister has history of hip fracture at 50. BMI is 18. Her main risk here is osteoporosis or osteopenia. DEXA scan done shows T-score of -2, which is suggestive of osteopenia. So osteopenia patients have twofold increased risk of fracture, osteoporosis 4 to 5-fold. So demineralization of bone is potentially the most serious long-term consequence of menopause. So menopause hormone replacement therapy and tibolone can be initiated in postmenopausal women at risk of fracture before 60 years or within 10 years of menopause. And this is the only indication where the menopause hormone replacement therapy is indicated as a prophylaxis. Even for the cardiovascular disease risk, prophylactic therapy is not advised these days. The first line of treatment is bisphosphonates, which is being given by our orthopedicians, alendronate and residronate, and the IV zoledronic acid. Commonly used other drugs are raloxifene, bajidoxifene, and teriparatide. We should not neglect the lifestyle modification like calcium, vitamin D, and exercise. Calcium intake should be 1000 milligram per day, and diet rich in calcium should be concentrated, and vitamin D should be checked, and if it is deficient, it should be corrected. And exercise is very important, and which is most neglected by our perimenopausal and menopausal women. How does resistance exercise protect bone? Mechanical loading from resistance and impact exercises like squats, deadlifts, heel drops generate strain and fluid shear in bone, activating osteocytes and mechanotransduction pathways that favor osteoblast activity and bone formation. Same way, the resistance training strengthens muscle by stimulating muscle protein synthesis, increasing cross-sectional area of fibers, and improves neuromuscular recruitment, thereby increasing muscle mass and strength in postmenopausal women. Therefore, diet and exercise plays a major role, and it should not be neglected. And weekly exercise schedule including aerobics, resistance, strength training, balance and flexibility training should be included in the daily routine. Bisphosphonates, as already discussed, alendronate and resedronate are given. They are oral forms. Zoledronate 4 milligrams IV annually is being used by orthopedicians. And SERMs like raloxifene 60 milligram per day is available for us. The additional benefit of raloxifene is breast cancer risk and cardiovascular risk is reduced. Many novel molecules of SERMs are available. For menopause, we are mostly using raloxifene. Calcitonin is no longer used widely. Parathormone is used for very severe osteoporosis by orthopedicians. And the present scenario about hormone replacement therapy is selective use for symptom relief within 10 years of menopause. It should not be used for more than 5 years. not to be used for primary or secondary prevention of cardiovascular disease. Natural estrogen, progesterone in low dose and minimal effective therapy should be preferable. Oral, transdermal and vaginal creams are available these days. Important points to consider are when to start the therapy, which route, and how do we tackle these side effects, how long to give, when to stop should be very clear. Contraindications have to be kept in mind, and follow-up of these women initially first 3 months, and then every annual follow-up is important. Choose your women well, start early and individualize the plan. Screening the risk benefit according to the age group. Compliance is very important. Choose which drug is suitable, hormone therapy, tibolone, relaxofone, and which route. And there is no role for prevention except for osteoporosis. If the woman has clear-cut risk of osteoporosis, we always have to give MHT depending upon the age. Lifestyle modification should never be neglected. Menopause is not end, it's a new beginning. Embrace the changes and you'll find the strength within. Thank you.
Very well presented, Saujanya. You have covered everything. Not many questions, but you have at least opened a discussion because HRT is not widely prescribed even today in Nandyal. Because women at that age, they just take it for granted that they have to suffer with all those problems. But now that we have to let people know that there is a solution. So that's very good. Thank you.
Estrogen, yes, estrogen has protective effects, sir. It releases increased nitric oxide release, which causes vasodilatation. And lipid profile also, it has positive effects like increased HDL and decreased LDL. And it has anti-inflammatory effect, which is protective to the coronary arteries. It reduces the risk of atherosclerosis. And all these protective effects are lost once she attains menopause and estrogen reduces. Yes, sir, yes.
Very comprehensive.
Sir, actually, even the Menopause Society says, for cardiovascular disease risk prevention, don't give hormone replacement therapy.
Thank you. A very comprehensive but on to the point presentation, Saujanya. But as we all know, we are not using HRT as of now. Yes. But can I ask, as any of us have a experience with HRT? Any of us started HRT to any of our patients? And even at least non-hormonal therapies?
HRT we are giving for premature menopause, surgical menopause.
Have you put them on your patients? No. Have you started your patients on them?
Very few patients for the last 6 months we have started using. Femostan we are giving.
Okay.
Femostan we are giving. For vaginal symptoms we are giving creams.
Creams, yes, we have been doing that.
Femostan we have started using.
Yeah, I've seen some of the prescriptions from cities with SSRIs, gabapentin. I don't know how they're working. I've seen patients coming with the prescriptions.
Yeah, for hot flashes, clonidine, gabapentin, and all
they're the non-hormonal management. Yeah.
If the lady presents with severe atrophic vaginitis and the topical estrogen alone is not enough, and if she hasn't got a uterus, we can give unopposed estrogens. If she has a uterus, you have to break it with the progesterone because the endometrium will be growing. So you have to give the break with the progesterone. If the symptoms are severe, we can give with the normal estrogen progesterone we have in our pharmacies.
And keep in mind the age of the patient.
Age and uterus.
Yes.
We have 2 recent non-hormonal drugs also coming up. They have been given sanction. They have been just sanctioned 2025 October. Maybe we'll have them also. They by the name of Fentolzin and something. Okay. They carry a long name. I don't remember exactly, but they are going to be on the board very soon.
And we should also talk about the natural things, the soya and etc.
Yes, diet.
So diet and things.
Isoflavones, yes.
Thank you, Surgeon.
Thank you, ma'am, for the update on HRT and various options available for the treatment in menopausal women.
We are doing a lot of hysterectomies. We should start giving hormonal therapy for them. I think we should get an idea. This is what I want.
Yes, ma'am. Next, I warmly welcome the next speaker, Dr. Shiva, who is a consultant urologist at Sri Sai Multi-Specialty Hospital. To chair the session, I welcome Dr. Jafrullah sir and Dr. Srinivas Rao sir. To complement the chairpersons, I invite Dr. K. Nagarjuna and Dr. Jahangir sir to give books to chairpersons. Dr. K. Nagarjuna. Dr. Murli.
Good evening, everyone. Today my topic of discussion is approach to hematuria. Coming to the basics of hematuria, normal urine should not contain any RBC, but RBCs of less than 3 RBCs per high power field is considered as hematuria. The chemical detection of blood in the urine is based on peroxidase-like activity of hemoglobin, which is detected by the dipstick test. The pathophysiology behind this dipstick test is heme will act as a pseudoperoxidase like enzyme, and it will catalyze the oxidase reaction for the chromosome, which is present on this dipstick test strip, and the chromogen here will be the orthotoluidine, which after getting oxidation, it gets converted to green in color, which indicates positive test. Coming to the classification and timing of hematuria, hematuria can be classified according to the visibility and its timing during the urinary stream. Broadly, it can be classified as gross hematuria, which can also be called as frank hematuria, visible hematuria, or macro hematuria. Other thing is microscopic hematuria, and it can also be classified as painless or painful hematuria. And pain in the hematuria, it is due to the clots, which will be blocking the urinary system, giving rise to the clot colic. Coming to the origin of hematuria, hematuria can be broadly be like nephrogenic causes and urological causes. Nephrogenic causes are in turn divided into glomerular versus non-glomerular causes. In the nephrogenic causes, presence of RBC along with the proteins in the urine, then it will be called as the nephrogenic hematuria. In the glomerular hematuria, there will be presence of dysmorphic RBC and RBC casts along with the proteinuria. The dysmorphic RBC, in this picture, there is this is normal RBC, which is biconcave in shape. Second picture, there is a dysmorphic RBC. This is due to the pliability of RBC while passing through the glomerular capillaries. And this picture indicates the RBC casts, which is due to the clumping of the RBCs. And in the non-glomerular causes, there will be hematuria RBCs along with the proteins, but the shape of RBCs will be preserved. Whereas in case of urological causes, there will be only presence of RBCs in the urine without any proteins. Coming to the surgical hematuria, it can be either microscopic hematuria or gross hematuria. Gross hematuria might be, the source of gross hematuria might be bladder. Most common cause of bladder source will be carcinoma of the bladder. Second will be tuberculosis, and other will be hemorrhagic cystitis. This picture depicts the hemorrhagic cystitis, where there is diffuse inflammation of the bladder mucosa with diffuse oozing of the blood from the bladder mucosa. Others will be the hematuria from the prostatic origin and hematuria from the urethral origin, hematuria from the upper urinary tract and vascular conditions. Microscopic hematuria, it is a sign rather than a symptom, because it is a laboratory diagnosis and is diagnosed by the presence of red blood cells on microscopic examination of urine, which is not evident on the visual inspection. The prevalence of microscopic hematuria among the healthy individuals in the screening studies has been proven to be 6.5%, and its prevalence is more in the males when compared to the females, and it increases with the age, and it is more in the smokers. In most of the studies, 1/3 to 2/3 of the patients will have a demonstrable cause in case of microscopic hematuria, and the most common cause will be the benign prostatic enlargement, which accounts for 12.9%. Second most cause will be the malignancy, ranging from 0.3 to 6.25% of cases. Third will be the calculus disease, and fourth will be the urethral stricture. Likelihood of identifying malignancy is greater in patients with higher levels of microscopic hematuria. That is, when the number of RBCs in the microscopic field increases, the level of detection will be increasing. Criteria for the diagnosis: as per the American Urological Association guidelines panel, microscopic hematuria can be defined as 3 or more RBCs for the high power field. And other criteria will be the sexual intercourse and exercise, and the cause of hematuria in the exercise will be diverting of the blood to the other vital organs during exercise, like heart and the muscles, and there will be decreased blood flow to the kidneys, which will be activating the tubulointerstitial feedback mechanism. So there will be increased dilatation of the glomerular capillaries, and there will be increased filtration of RBCs through the glomerular capillaries. Other cause will be the urinary tract malignancy, and the cause of microhematuria seen here will be intermittent. The most important thing is a single positive urinary analysis is sufficient for the prompt evaluation, and this should include urine cytology, cystoscopy, and PSA values, and radiological investigation, mostly like CT urogram. Coming to the risk factors for the urinary tract malignancy, this will be ranging from the male gender, age more than 40 years, past or the current smoking history, occupational or exposure to the chemicals or the dyes. Coming to the occupational history, it will be more commonly seen in the people working in the dye and the plastic industries, and the most commonly dyes involved here is the aniline dyes. And the other thing is analgesic abuse. More usage of analgesics causes the thickening of the basement membrane, which in turn causes the pre-malignant changes, and which will be giving rise to the upper tract urothelial malignancy. And history of the gross hematuria, history of urological disorders, history of the irritative LUTs. Presence of the irritative LUTs indicates that it is an advanced disease. History of the pelvic irradiation, history of the chronic urinary tract infection. Chronic urinary tract infection will give rise to the dysplastic changes in the urothelium, which in turn gives rise to the malignancy. History of chronic indwelling catheter, it increases the chance of squamous cell carcinoma in the bladder. Selecting the patients for the evaluation of the hematuria, the risk factors, as per the American Urological Association, the risk factors considered here are age and the sex, smoking, that is pack year index, degree of microhematuria, that is number of RBCs seen in the high power field, and history of the gross hematuria, prior episodes of the microscopic hematuria. These can be broadly classified into low risk category, intermediate risk category, and the high risk category based on these factors. As per the American Urological Association, there should among the low risk individuals, cystoscopy and any imaging modalities are not recommended, but there should be a shared discussion making between the doctor and the patient attendants, and we should give an option of 6 months urinary analysis versus cystoscopy with renal ultrasonography in the low risk individuals. But in the high risk individuals, all the 4 factors like urine analysis, cystoscopy, upper tract imaging in the form of CT urogram, and PSA should be definitely done in these patients. Coming to the anticoagulants, patients who develop hematuria, that is microscopic or gross hematuria, and are on anticoagulants or antiplatelet medication should undergo complete evaluation in the same manner as patients not taking any medications, because we will be thinking that the ongoing hematuria is due to the usage of the anticoagulants by the patients, and we will be postponing the evaluation of the hematuria. But this should not be done, because many studies suggest that the likelihood of finding genitourinary cancers in these patients will be the same as that of the patients not taking these drugs, and these drugs will mark the detection of the genitourinary cancers earlier. Coming to the cystoscopy in the diagnosis of the hematuria, as per the American Urological Association guidelines, cystoscopy should be performed in all the patients who are having the high risk factors, and AUA guidelines will cystoscopy should be omitted in persons younger than 35 years and not having any risk factors. Usually white light cystoscopy will be done. This will be missing the superficial malignancies and CIS, and we will be insisting for the blue light cystoscopy. In the blue light cystoscopy, this is the picture depicting, this is the white light cystoscopic picture. Here the detection of the urothelial malignancies will be less, and in the blue light cystoscopy, the malignancies will be seen as the dark red in color, which will be easily detected by the blue light cystoscopy. This is the video depicting the usage of the flexible cystoscopy, which is available in our institute. The advantage of this flexible cystoscopy is the wide freedom of this cystoscope with multiple deflection, so that we can see the entirety of the bladder, like bladder neck, dome, and posterior walls of the bladder easily without causing any trauma to the bladder, which is first introduced in entire Rayalaseema in our institute, in our hospital only. Upper tract imaging in the evaluation of hematuria, usually we will be doing CT urogram. In the CT urogram, there will be 4 phases, that is first unenhanced phase, second phase will be corticomedullary phase, which will be lasting for 1 minute after the injection of the contrast. Here we will be seeing only the enhancement of the cortex, and in the third phase it will be the nephrogenic phase, which will be lasting for after 2 minutes. Here we will be seeing both cortex and the medulla, and the detection of the renal malignancies will be more in this phase. And the third phase will be the excretory phase. It will be starting from 3 minutes after injecting the contrast. For seeing the calyces and the pelvis, we will be seeing at 3 minutes and 5 minutes. For seeing the ureters, we will be seeing after 15 minutes, and we will be using any like compression, and for seeing the bladder we will be doing after 30 minutes to see the bladder, and post-void films also we will be seeing. The only disadvantage of this is the allergy to the ironated contrast materials, and we cannot be using this in the pregnant females. There we will be using MR urogram or the ultrasound with contrast. Another thing is the urine cytology. The sensitivity of the urine cytology will be varying upon the grade of the tumor and the number of samples used. Usually we will be using 3 samples, and the sensitivity increases with the Barr-Bottage specimen, and the sensitivity will be more in the high grade urothelial cancers because of increased shedding of the cells. And recently the many biomarkers are available for the detection of the malignancy. Of this, FDA approved biomarkers are nuclear matrix protein, bladder tumor antigen, FISH for the abnormalities in the chromosomes, and immunocytology for CEA, and mucin glycoproteins. But AUA guidelines do not recommend the use of these biomarkers. And management of the microhematuria, it includes the history and the physical examination. If any cause is seen in the history and physical examination, we will be treating it. If no cause is found, then we will be doing cystoscopy and upper tract imaging. If anything is found, we will be treating it. If nothing is found, we will be doing yearly urine analysis for at least 2 years. And if nothing is found, we will be releasing the patient from the care. Gross hematuria, the degree of hematuria increases with the number of hemoglobin in the urine. It can be initial hematuria because of the urethral cause, that is distal to the external urinary sphincter. Terminal hematuria, it is due to the contraction of the smooth muscles. It can be from the bladder, trigone, neck and the prostate. And the total hematuria, it will be due to the bladder or above. This is the picture depicting the clots in the urine. These are the serpentine clots depicting the upper tract urothelial malignancy. Coming to the pseudohematuria, it can be due to the endogenous causes like the bilirubin and the food ingested like beets, and the drugs will be like pyridium and the rifampicin, and it can be also due to the dehydration. And the gross hematuria should be differentiated from the vaginal bleeding, and it can be done by the urine analysis and the microscopy only. Yes, sir. Coming to the bladder cancer is the most commonly identified urinary tract cancer among the patients investigated for the gross hematuria. This is the video showing 85-year male patient presented to us with the cauliflower-like growth at the left VUJ. It was treated with the thulium fiber laser. Here we will be seeing the 200 microns thulium fiber laser. Cauliflower-like growth will be seen on the left. This is the left ureteric orifice and this is the cauliflower-like growth. This is the thulium fiber. Here we can see that we are coagulating circumferentially to decrease the bleeding, and we are resecting the bladder tumor below its base. We can clearly see that there is no bleeding with the usage of this fiber, and the chances of perforation with this fiber are also less, and the chances of the postoperative hematuria with this also are less. And as the tumor was nearer to the left VUJ, here we have resected the left VUJ also, and then we have done DJ stenting in this case. After complete resection, the bed should be seen like a pale white in color, and we have done stenting in this case. Coming to the differential diagnosis for the bladder cancer, it can be hemorrhagic cystitis, and the causes will be like infectious causes, traumatic causes, malignancy, vascular causes and chemical exposure, and the radiation therapy is the most common cause for this, and other medications like bleomycin, other systemic manifestations. And the treatment of the hemorrhagic cystitis will be like initial management like hydration, bladder irrigation, cystoscopy with the clot evacuation and fulguration, intravesical therapy with the alum and treating of the coagulopathy causes, and then usage of hyperbaric oxygen therapy, formalin and urinary diversion. Hematuria from the prostatic origin. The most common cause for the hematuria from the prostatic origin is the BPH. It is due to the androgen-induced microvascular density overgrowth and the prostatic tissue overgrowth, which is due to the vascular endothelial growth factor. Other causes for this BPH is the prostatitis and the prostatic cancer. For the BPH, we will be initially giving medical management with the 5-alpha reductase inhibitors. If the patient improves, then we will be doing prostate related surgery. If hematuria is not resolving, then we will be doing cystoscopy with fulguration. If it is still not resolving, then we will be doing angioembolization, then prostatectomy. This is the video showing thulium fiber laser enucleation of the prostate in a 64 years male patient. Yes, sir. Here we are dissecting the two lobes of the prostate with the thulium fiber. Here we can see that there is a decreased risk of bleeding in this case. Here we are removing the prostate from the surgical capsule. This is the right lobe and this is the left lobe. Here we can see that there is no risk of bleeding in this case. And here we are resecting the prostate from the at the bladder neck. The advantage of this thulium fiber is decreased risk of bleeding, and we can resect larger sized glands. This is being done in our hospital with the thulium fiber. This is the most advanced surgery for the prostate. And hematuria from the urethral bleeding, it can be due to the urethritis or the trauma to the urethra. It can be detected by the retrograde urethrogram or cystoscopy. Advantage of the cystoscopy is it is both diagnostic and therapeutic. Hematuria from the upper tract, the most common cause will be the glomerular causes, and then followed by the stone disease, followed by the malignancy. Other cause will be the vascular condition, that is nutcracker syndrome. This is the left renal vein entrapment syndrome. Here the left renal vein is entrapped between the superior mesenteric artery anteriorly and the aorta posteriorly, and the nutcracker here will be the left renal vein. And the causes of this hematuria in this is the renal venous hypertension, causing the rupture of the capillaries in the collecting system, leading to the hematuria. Thank you. I would like to thank my mentor and chief, Dr. K. Bhargavardhan Reddy sir, for giving me this opportunity and his videos. Thank you.
Thank you, Dr. Siva. Any questions from audience? Then move to next topic.
Thank you, Dr. Shiva, for a very elaborate session. Now I request Dr. Prashant Garu. His topic of the day is sepsis and septic shock, evidence-based practice and major recommendations. Now I request Dr. Madhusudan Reddy sir and Dr. Shabnam madam to chair the session. I request Dr. Fanindra and Dr. Raviteja to compliment the chairpersons.
Hello. Hello. So, should I start? Yes. Okay. Good evening, one and all. Myself, Dr. Prashant. I'm a consultant intensivist and head working at Udayananda Hospitals. I'm looking after ICU of 22 beds. I did my DRMD from Fortis, New Delhi, and currently I'm doing my fellowship in ECMO from European Society of Intensive Care Medicine. So, topic of my presentation, it is sepsis and septic shock. It is equally important to all the departments who are present here. So, I think we'll pay this minimum attention. Thank you. So, the definition of sepsis, it comes from Greeks starting from 750 AC till today. So there were multiple changes in this definitions. So among this, one of my favorites is among the William Osler, who defined this as the patient dies as a result of the body's reaction to the infection rather than due to the infection itself. So after that, the modern medicine, 1992 was the landmark where the Sepsis 1 conference was held, which defined and streamlined the definition. There were upgradations followed in 2001 in Sepsis 2 and 2016. So we have this surviving sepsis campaign timeline. The most recent one is 2021 adult guidelines. So how do we define sepsis? Sepsis is a life-threatening organ dysfunction caused by the dysregulated host response. This is not the regulated host response, which happens in the normal. Resuscitation. And why do we need this separate definition for septic shock? It is because the mortality rises for more than 40% compared to the sepsis itself. So previously we used to tell SIRS and severe sepsis as the terminologies which are obsolete now. So the continuum of severity, it ranges from infection to bacteremia, followed by sepsis, septic shock, multi-organ dysfunction syndrome, and followed by that is death. So this is the 2005 guidelines where we had resuscitation bundles of 6 hours and 24 hours. That was again streamlined in 2013 where it said that 3-hour bundle and 6-hour bundles has to be followed, and which was cumbersome to follow. So now the 2018 guidelines which says 1-hour bundle, all the 5 components of this 1-hour bundle is of utmost importance.
like measuring of serum lactates, which is more than 2, will come in one of the definitions for septic shock. Obtaining blood cultures prior to the antibiotics. Administering broad spectrum antibiotics. Begin rapid crystalloid resuscitation with more than 30 ml per kg in first 3 hours. And followed by application of vasopressors if hypotension is present to maintain the MAP of more than 65 millimeters of mercury. So initially the screening tools right away from the emergency room, use of performance improvement programs are required to explain the mortality to the patient's relatives, and measurement of blood lactate in suspected sepsis patients, because we'll have to target, we'll have to chase these lactate levels to come to normal when we are doing the resuscitation. Initial resuscitation, start immediately more than 30 ml per kg crystalloids in 3 hours. Just be cautious in the cardiac patients where the patients will not go into failure. After this, targeting lactate normalization and use of capillary refilling time as adjunct, where when the hospitals we do not have when we don't have this hemodynamic monitoring systems, we can go for capillary refilling time. So this is the bedside adjunct which will be helpful. Relating to MAP and vasopressors, target MAP of more than 35, and norepinephrine will be the first line drug. Do not go for vasopressin or epinephrine in the first go. First start with the norepinephrine, and then you can add vasopressin. And do not escalate norepinephrine beyond 0.2 mics per kg per minute. And epinephrine, if needed, we can add it as a third adjunct. So this is already explained in the VANISH and VAST trials regarding the addition of vasopressin to the noradrenaline. Regarding the fluids and adjuncts, as already discussed, the balanced crystalloid solutions are preferred like plasmalite and plasmalite A over the NS. Albumin is indicated only if the large volume of crystalloids are required. Avoid starches and gelatins in view of AKI, and peripheral vasopressors are okay initially, and you can take the central line later. The, multiple studies regarding the goal-directed resuscitation for septic shock have been explained. Among them, these are very important, like process study and this. Antimicrobial timing, immediate empirical antibiotics should be started within the first 1 hour. If the sepsis is suspected, then we can start within the first 3 hours. Reassess daily, and daily de-escalation of antibiotics is necessary. And in patients with MRSA and MDR and fungal coverage, if high risk, then all these coverages are required, and better, instead of giving as bolus antibiotics, go for the prolonged infusions. This is the antibiotic timing again. Source control, rapid identification and removal, especially the indwelling catheters, and shorter duration of antibiotics should be encouraged with the procalcitonin. So many of the institutions, they follow this procalcitonin to start the antibiotics, but the literature says otherwise. The procalcitonin levels in the decreasing trend help us to reduce the duration of the antibiotics or to de-escalate the antibiotics. Ventilation strategies and ARDS management, low tidal volume 6 ml per kg on ventilator for ARDS patients, and high PEEP are encouraged in moderate to severe ARDS patients. Proning for more than 12 hours is also beneficial to improve the oxygenation. And intermittent neuromuscular blocking agent, boluses, the studies are conducted with atracurium, and atracurium infusions are very helpful in proning. If none of these works in ARDS patients, so ECMO can be tried. So this is a PROSEVA trial, which is a landmark trial where the proning in ARDS patients has been explained for more than 12 hours with the benefit. Corticosteroids, IV corticosteroids, if vasopressors are ongoing, it's a weak recommendation again, and restrictive transfusion, do not go for liberal transfusions. And DVT prophylaxis, Clexane is preferred over unfractionated heparin, but in cases of renal failure, you'll have to go for UFH. Nutrition and RRT, early enteral nutrition in sepsis and septic shock patients is encouraged, that is within the 3 days. If you are unable to start within the 3 days the enteral nutrition, then go for the total parenteral nutrition or the partial parenteral nutrition. And in the RRT, continuous and intermittent RRT, both are equal. None has the advantage over the other. So the goals of care will be early goal discussions, that is within the 72 hours, and integrate palliative principles also. Screen for post-sepsis impairments, peer support and rehabilitation referrals are also important. Thank you.
Your topic finished in 8 minutes.
That is well within the times.
Any questions from the audience? It is a very important topic which everyone should know.
What is the maximum dose of noradrenaline we can escalate before adding another inotrope?
Sir, the noradrenaline range, it raises from 0.04 mics to 0.4 mics per kg per minute. So it will approximately come, we do two strengths, one is the single strength and the double strength. If you are going for the single strength, if it is coming till 10 ml per hour dose, then you can go for vasopressin immediately after that.
We are not intentions. Please say in terms of syringe 1 ml per hour or 2 ml per hour. Like
so the single strength norad, if you are going till 10 ml per hour, then you should add the vasopressin.
Okay.
Even during the de-escalation also for the single strength, you should start tapering vasopressin only when you come till the 10 ml.
So what are the contraindications to start as a first line inotropic drug?
Sir, noradrenaline is the first line as per the evidence because the dopamine and epinephrine, they are more arrhythmogenic.
Okay, for any case, this is the first time.
Yes, for any case, you will have to start with the norad only.
What is the broad spectrum antibiotic you prefer?
Sir, it varies from case to case. If the patient is not in shock, we can go for beta-lactam and beta-lactamase inhibitors. The most common that is used here in this place is Zostam and Piptas.
Okay.
Yes, sir. And if the patient is shocked, it is always better to go for meropenem directly.
Right. Thank you.
Yeah.
Sir, what is the mortality rate of septic shock?
So it's more than 40%. I have put it in this slide. Yeah.
Even after the treatment, best treatment?
No, it is not after the best treatment. It is with the definition, sir. It is during the initial assessment. When the patient comes to you in the emergency room, you do the screening tools, you see the patient has got the septic shock, you can explain to the family that the patient has got more than 40% mortality. After the after the best treatment, we always wish to get the patient back to the normal only. No particular study as per your questions. Yeah.
No, there are no questions.
Thank you.
Thank you, Dr. Prashant. It was a very nice presentation. Thank you for enlightening us on sepsis and the recommendations of septic shock. Next, I invite Dr. Sriharsha to present his topic, Body Contouring, Conquer Your Body. Dr. Sriharsha is consultant and director at Dr. Harshavardhan Reddy's Plastic Surgery Clinic at Padmavati Nagar, Nandyal. I invite Dr. Madhusudan Rao sir and Dr. Ramachandra sir to chair the session. And I request Dr. Seshikiran and Dr. Divya to complement the chairpersons with books.
Really thrilled to see Harsha's presentation because I am very eager to see your wonderful contouring. My friend Dr. Venkatramana, MS ENT and plastic surgeon. So becoming an ENT surgeon, after that plastic surgeon, he established his hospital in Jubilee Hills, Hyderabad. His hospital name is Contours.
Contours, yes.
So he just want to make Contours so famous. Now the same Contours Harshavardhan is going to make famous Nandyal.
Sir, to add to that, actually the father of modern plastic surgery is an ENT surgeon himself, Gillis. Harold Gillis is a ENT surgeon himself. So there was a lot of contribution from ENT department to
so we ENT surgeons are
ideal placed to become a plastic surgeons. Anyway, good evening everyone, and I think it's not too late. So for all the audience here, I'm still thankful that you're still patient enough to listen to the talk. So straight away diving into the discussion. So I've chosen body contouring as an extension of the last talk that I've given.
So that was all about trauma. So let's dive something, let's explore something more beautiful or beautifying people. So, the objectives of my talk straight away would be just giving a glimpse of what is to be expected. I mean, in a body contouring, what is the spectrum of body contouring? What are the principles or science behind that, and the terminologies associated, the benefits, and also to debunk the common myths that we have among common public or even among our fellow physicians about like the safety regarding body contouring, and whether it is a cosmetic procedures or is it only restricted to the social media or people associated with fashion industry. And I'll definitely promise, and I made it my prime objective that I will not discuss the technical details and bore you. So that is one. So the body contouring is also known as body sculpting. So it encompasses surgical and non-surgical medical procedures which are used to reshape, tone and refine specific areas of the body, especially for people who are obese and shed their weight either by workouts or after a bariatric procedure, giving a loose saggy skin, and also people who are aging or a aged look, and after pregnancy, and even due to some hormonal imbalances in a younger population, and also with the changing lifestyle, changing eating habits in the younger population, we are seeing more of obese kids nowadays and very insecure about their looks. So these are few areas where the body contouring is primarily focused. The double chin, of course, we are not discussing that here, and the chest in males, gynecomastia, females, so the breast asymmetry, the small breast, large breast, and the love triangles around the flanks, the buttocks, sagging buttocks, the thighs, the arm lift, and the sagging skin around the arms. So all these are things. So you can see with this picture the massive transformation that has been done due to a very good bariatric procedure. But what we notice here, after he is having a very good muscle tone beneath, but what very good muscle tone underneath this sagging skin, which is giving a aged look. So the plastic surgeon's role or the aesthetic surgeon's role comes here. How to adjust this skin envelope to give to justify the tone underneath. So that is where all the calculations, all the measurements and all the sculpting goes. So this is one example. Most of these diagrams I've taken from internet. So that is a disclaimer, because we are not yet that high volume center. So that is a prime objective or aim of presenting this. So we are able to do this, and I expect support from you. So this is, I guess, maybe in the late 40s or early 50s. So the transformation has been phenomenal in the abdomen, the thighs, and maybe making her lesser about 10 or 15 years younger than what she is supposed to look. So the concept or science behind this, so as I said, it is both surgical and non-surgical modalities. So in surgical modalities, again, there is a mechanical removal of this unwanted or stubborn fat, either by liposuction, or there is an advanced thing using an ultrasonic guided. So we call it as VASER, vibration amplification of sound energy at resonance. So in liposuction, plain liposuction, mechanical one, it is laborious. It is very, the surgeon is exhausted. So we normally do it in a team of 2, where we break the cells using a cannulas and suck it out through a very powerful suction machine. And the duration increases with regular manual suction machine. But when we use VASER before sucking out, this will emulsify the fat and make it into a gold, what we call as liquid gold, if we use the same fat to augment the areas in other parts of a body, like in a breast and all. So that is one. Once we have sucked out all the unwanted fat, the thing left out is loose, saggy skin and the aprons of fat, which we are removed by careful planning of incisions and cutting that redundant skin. And then to tighten it, just suturing the skin is not adequate, as more often we see when we suture a skin, it will eventually drape down. So there is underlying structure which pillars this skin or tighten the skin. In face, upper limbs, lower limbs, that is a superficial fascia system. And in the abdomen, the tone of abdominal muscles is improved by suturing them or by plicating them. And in the non-surgical, with the evolving technologies, with the newer innovations, cryolipolysis, or what we are now calling the work term is cool sculpting. So there is a controlled cooling of the body at the area in focus at minus 11 degree to 5 degree Celsius, which triggers apoptosis of fat cells but spares the other normal cells like skin, nerve, vessels, or muscle tissue, because they have a higher water content in them. So that will break down the fat cells, which are eventually scavenged. Same thing with thermolysis, but here the heat is used as energy. The CO2 lasers, radio frequency heat cells, they heat the fat cells to 42 degree to 47 degrees Celsius, which will again cause the damage to the structural integrity, eventually collapsing the cells and again scavenged. And they also stimulate the collagen, the neocollagen formation, which will give structural integrity or that evolved look or the enhanced look to the area in focus. And ultrasonic cavitations, again we use low frequency sound waves to create micro bubbles on the cell membranes, which will eventually break down or emulsify, and that is eventually scavenged. And the same with electromagnetic here. The electromagnetic impulses are given to excite the muscle fibers, and strengthen the muscle fibers, and also they promote the burnout of fat cells due to increased metabolic rate. And once these are done, the recovery depends solely on two important factors: body metabolic, BMI, and smoking. So the closer the BMI to the normal, the better the recovery. And there are strict guidelines that the patient's weight has to be stable for at least a 6 to 1 year period, because when there is a weight loss, its body is still in a catabolic phase. So you don't go and do a surgery immediately again, because you are again causing one more insult to the body. So you give time for a body to regain its normal process, to increase the micronutrient deficiencies, to recover the micronutrient deficiencies and other factors. And smoking is a strict no for any cosmetic procedure. The patients will not get results, and eventually they land up with complications because of poor wound healing. And this is the only theoretical part that we are discussing. Okay. So after that, just to get a hang of things that we are discussing, the terminology. So around the abdomen, when we do a 360-degree liposuction and suture, remove the excess skin in the front and the back to lift the buttocks, to flatten the belly, that is called as belt lipectomy, just like the belt. So the incision is around the waist area, so that is why it is called as belt, and that is in the pattern of a flower. So it is only for anterior abdominal wall corrections, and that is abdominoplasty. And we do in younger individuals, plain liposuction itself would help, because they have a very good skin recoil or skin elasticity, and it will come back again. And the upper body, the arm lift is done in females, in a middle-aged women where they have a hanging skin. Especially we can see most of the women in a middle-aged group in our society also, when they put on a blouse, the skin is still hanging around. And the thigh lift, this is more of functional and also a cosmetic, and the breast remodeling things. So the benefits of body contouring, apart from elevating their own self-image and making and the psychological impact, it also improves the look of a patient. Aesthetic appeal is improved, and they become more social. So we'll be seeing examples of each of these in a just pre and before and after images, and discussing a brief about each one of these. So the liposuction is one of the most commonly performed aesthetic procedure, and it can be done alone or independently, or it can be clubbed with any of these procedures. More often we are clubbing the liposuction with these procedures, a minimally invasive procedure, and just the excess skin is just removed and sutured in a planned wise manner to give a better scar. So the brachioplasty, again, this is an example where we had extended, of course it was taken from internet. So the extended arm brachioplasty is done, where we can see this excessive skin has to be removed for her to wear a sleeveless or anything. Even to wear a blouse also, that is always a concern for a people in a middle-aged group. So the scar is well hidden. Of course, this is image taken to show the scar. Otherwise, it is now, if she puts her arm by the side, it is well hidden inside. And for a minimal, if this is not this much hanging or there is minimal excess skin, we can do something called as mini brachioplasty with a transverse skin which is well hidden in the axilla. From behind, you can hardly see any scar and it looks beautiful. The thigh lift, one is aesthetic concern where the younger, even with PCOD and everything, with improper distribution of fat, the younger girls are very much concerned of wearing a tight garments, or even if they wear a tight, they wear a long salwar over that, and if they want to wear a t-shirt over a jeans and all, they have their own worries because of improper distribution, and they will have the cellulites around this and the thighs. So, and apart from this, in elderly individuals where they have abdominal fat deposition over the medial aspect of thighs, whenever they walk, there will be chafing or gaping of the rubbing of both the thighs. So that will be troublesome, and even if they want to shed down their weight due to some exercises, they can't do that because of this activity. So the liposuction comes to the rescue in this part, liposuction or body contouring procedures. So you can see how beautifully it is transformed in this case. And another case where it is, I guess they have done only liposuction in this case, which gives a very good thing. And with improved cosmetic, improved awareness of clothing, and a younger population coming up, so these procedures will become normal in even tier 3 cities in a coming future. And coming to the breast defects, so breast is still by global standards one of the most important factor to define a woman's beauty. So the patient here, the breast augmentation is where we increase the volume of a breast, increase its shape and symmetry, including the nipple and areolar position. So for a girl, for a young teenager who has a small breast, and she is becoming more conscious about herself, she is being bullied at her educational place or workplace, they will lose their self-dignity, they will not socialize, this has a longer, or this has a more deeper impact than we realize. And only when you perform a surgery and see them after surgery, you will realize how significant it is for these people and how concerning it is for the parents. So I'll be almost done. So then in this lady, there we do autologous and non-autologous breast augmentation. So one is autologous is where we put in fat grafting, and non-autologous is silicone implants. Multiple shapes are there and multiple volumes and multiple planes we choose depending on the requirement, individualized according to each patient's multiple incisions. We go by inframammary incision, well hidden, well concealed. And coming to the breast reduction, what about the people with a large breast? Isn't that a problem? So these are two cases we have performed thanks to the people, thanks to the senior colleagues who have referred these cases. So on your left is a lady, still young lady, but she has completed her family. She was suffering with this deformity since she is of her school age, but somehow she has finished. She has finished her family. She has done now her mother, and she has come to me asking for a breast amputation, and she was fed up with this. She has lost her posture, having a severe pain on the chest, and not able to move along society. And on the left is a young unmarried girl, about just finished her 10th class, with a huge breast, not able to wear a clothes. She wears a burqa just to cover her breast, just to protect, cover her deformity. So that is where the concerns are different in these cases. The left side we can reduce, we can tailor the reduction according to her body stature or body thing. But for in a younger girl, lactation is still there. She has to complete her family, so the concerns are high, the risks are high. So that is it. So we'll just go through the slides of this is the markings. This is the place we are ultimately going to put our breast. So we calculate the distance from here, mid-clavicular line to the breast, it was 34 centimeters. Ideally, in ideal setup, it should be anything between 18 to 22 centimeters. So I've chosen the longer one still because the pedicles, and there are multiple plannings. One for the incision, how you take the pedicle, either superior pedicle, superior medial pedicle, inferior pedicle, central pedicle, and how you dissect the, or how you cut the parenchyma. So all these are technical details. That is for another day. So this is intra pictures where on the left side we have performed excision. This is the amount of tissue, almost approximately 750 grams was taken out, and this is the supromedial pedicle. This is diepithelial skin. The areola is also tailored to 4 centimeter. The areola was stretched out, it was bad. So on the other side we have finished one side, and on the left side we can see the breast parenchyma still removed. So that is a result after it is a 2 months follow-up, and now it is almost 6 months since we have done this procedure, and this has almost faded out. The result is pretty good. She is very happy. She has given a very high rating in her follow-up also, and some things to learn. There is some bottoming out here, but she is happy. She is moving out. She is wearing jeans, t-shirts, everything now. So that is the amount of lift. Ideally, the breast is supposed to be, the nipple areola or the inferior mammary, this part has to be between mid-arm and the elbow crease. But you see how long it has stretched out, and the amount of lift that we could gain with this procedure. There is still finer procedures. I was a bit wary because this is my first case. So I've just gone with a regular conventional thing, and it has given wonderful result. This girl, we could not remove excess tissue. We removed about 550 and 550 on each side. There is an asymmetry. The left breast is high. You can see this because of the gaping of this both breast. There is a skin lesion in between. Now that is slowly coming away. The incision pattern has improved. The scarring has literally really good, and it keeps on improving by the coming age by wearing additional required garments. And she had a axillary pad of fat which was removed, and that is almost invisible scar. And in a male's gynecomastia is due to hormonal imbalance, and once there is a fat component and the parenchymal component, the stromal component. So the fat can get down with the exercise, but what happens to this part? So that part is taken care of by liposuction. Different levels of different grades of liposuction. Unilateral, and different levels. So this guy is a doctor by profession. His father has brought him to me very worried that he's in depression because of this scar, and he was refusing to look for a marriage proposal. So he was brought to me. Considering this alone, it is not a very significant gynecomastia. But when we have done that, you can see the difference. Just one side we have done, hardly there is any scar visible, and he has to maintain grams, and he started smiling after that. Of course, marriage part, I'm not sure whether he will still go ahead or not. Yeah, this is an open procedure we have done just to remove the fibrous component, nothing much. He was a 19-year-old kid. Yeah, that is a part. And the last case that we'll be discussing, I put this thing in our folder. So this is a guy, he's again a doctor, very good very successful practitioner. He has lost his weight from 105 to 95 kilos, and it was stable for a year. He has waited for me to perform this case till I finish my aesthetic training. So, but he has this fat deposition hereditary. So you can see the love triangles here, the belly of fat putting on, and the gynecomastia is there, but he was not willing for gynecomastia. You can see the folds, how it is. So we did a liposuction. You can see my friend is doing on one side and I'm doing on one side. So otherwise it took 6 hours for us. We removed about 9 liters of fluid. Of course, we replaced it with fluid also. This is after liposuction. This is on the front, this is the back. So the only skin envelope is there. And once we are done, this pannus is removed. The thing, it's almost 2.5 kilos. And once that is done, we remove till the umbilicus. Once that is done, we just measure the tension and create a new umbilicus around it. And the suture is inside the waistline, which will be covered by the undergarments. This is the result after 2 months. The umbilicus is well settled. The scar is barely visible. Apart from these will fade away. He's a very fair guy. So this will fade away in a span of time. He is able to wear now. His cloth size has come down by 2 or 3 sizes, and this is his final result. He's got married and he's very happy and he's maintaining his lifestyle. Just to finish off the debunking the myth part. So body contouring is not equal to weight loss. Weight loss is done by bariatric surgeon. What we do is the follow-up of weight loss, and we try to help those patients. Once we do body contouring, will the patient avoid gaining any weight later? No. He has to maintain a proper lifestyle. The results are short lasting? No. They can be as long lasting as the patient maintains his lifestyle. And the recovery period is very minimal. Gynecomastia, where he can go to work the very evening or the very next day. Liposuction alone, the second or third day, and all these other procedures within a 4 day span with improved pain medication, it has come very good. So thank you very much. That is my MBBS college from Hubli. That is my MS training from Calicut, and that's my plastic surgery training. That's place where I'm doing all this work now. And my aesthetic guru, that is Rajat Gupta, is from Delhi. He is one of the leading global practitioners now. So, and these are the teachers who have shaped my career throughout from my schooling days to this part. Thank you very much. Sir.
ఒక ప్లాస్టిక్ సర్జరీ వాళ్ళ హాస్పిటల్ ముందు ఒక పోస్టర్ పెట్టారట. డోంట్ గెట్ అట్రాక్టెడ్ బై ది బ్యూటిఫుల్ లేడీ కమింగ్ అవుట్ ఫ్రమ్ హిస్ హాస్పిటల్. షీ మే బీ యువర్ గ్రాండ్ మదర్.
దట్ ఈస్ ట్రూ సార్. దట్ విల్ బి సమ్ డే.
ఇల్లస్ట్రేటెడ్ వీక్లీలో ఐఎస్ జోహార్ అని చాలా సెటైరికల్గా రాసేవాడు. ఆయనకు ఒకసారి క్వశ్చన్ అండ్ ఆన్సర్స్లో, అంటే ఈ ప్లాస్టిక్ సర్జరీ అంత ఇంప్రూవ్ కాని కాలంలో డిఫైన్ బ్రా, వాట్ గాడ్ హ్యాస్ ఫర్ గాటన్ వీ ఫిల్ ఇట్ విత్ కాటన్ అన్నట్టు. చివరిగా నేను చాలా రోజుల కిందట హర్షాల గురించి రాసిన ఆయన దగ్గర ఉంది ఇది. ఎక్కువైనవి తగ్గిస్తాడు, తక్కువ ఉంటే పెంచుతాడు. వికారాలు ఎన్ని ఉన్నా ఆకారంలో సరిదిద్దుతాడు. విషాదాలను ఆహ్లాదంగా మారుస్తాడు. హర్షవర్ధనుని శస్త్రచికిత్స నైపుణ్యాలు సృష్టికి ప్రతి సృష్టి చేసే అద్భుత విన్యాసాలు.
Any questions from audience? Thank you, sir. Thank you for the elaborate and informative presentation on body contouring. I next warmly welcome Dr. Ravinder, sir, to talk on the topic antenatal hydronephrosis is the termination a must, which is a daily question in OPS OPD. And sir is pediatric surgeon and pediatric urologist at Shantiram Medical College, and achievements sir, district coordinator for the Society of Pediatric Urology. To chair the session, I invite Dr. Chandrasekhar sir and Chandrakala ma'am. And I request Dr. Madhav Reddy sir and Dr. Rohit to give compliments to the chairpersons. Dr. Madhav Reddy sir and Dr. Rohit sir.
Good evening, everyone. So today I would like to have a discussion on antenatal hydronephrosis. So first of all, why I have kept the caption is termination required is the very first moment I came to Nandyal, I see in a prescription hydronephrosis, and the patient has been advised for termination. So I was literally surprised. I asked the patient, what are you talking? No, sir, hydronephrosis, kidney swelling is there. Our child will die. I said, no, nothing will happen. You continue the pregnancy. So then after that, I thought of giving a talk. Then after I got an opportunity after so many years. So I thank IMA and Nandyal Urological Society for giving me this opportunity. So let's move on to discussion. So I will keep this discussion very short and crispy. I know everybody is tired and exhausted. So what is the definition of hydronephrosis? Nothing but it is a dilatation of the collecting system, and in fact hydronephrosis is the most common abnormality detected in the pregnancy. Not only urological, of all the abnormalities seen in the pregnancy, this is the most common abnormality detected, and its incidence is around 1 to 5% of all the pregnancies, and this is more common in males. So why are you actually worried of antenatal hydronephrosis? So the goal of evaluating these children is you want to potentially prevent the complications and preserve the renal function by intervening early. So I will go little bit into the anatomical details. Fetal urinary tract. So actually urine formation starts around 5th to 8 weeks of gestation, and then fetal kidneys are well visualized on ultrasound by 12 to 13 weeks, and fetal bladder is very well visualized around 10 to 14 weeks of gestation. So by 10 weeks, amniotic fluid is mainly dependent on the urine produced by the baby. So why I am stressing this point is, as everyone is aware, amniotic fluid is very much important factor for the survival and growth of the baby. So there are few causes, especially urological causes, which result in decrease in production of urine, thereby resulting in oligohydramnias. So any amniotic fluid less than 500 ml, it is called oligohydramnias, and there are main causes of oligohydramnias is urinary tract obstruction. The most worrisome cause is bladder outlet obstruction, especially in the male child. See, unfortunately, we are in a society where we cannot label sex, but every time I feel bad because I think this is a condition where you should assign the sex, because if we assign the sex as male child in the bladder outlet obstruction, we can straight away advise for termination, but unfortunately our system does not allow. So bladder outlet obstruction is one of the main cause. Why? Because it causes severe hydronephrosis, severe oligohydramnias. There will be pulmonary hyperplasia. Literally, the baby won't survive. See, there are many children of posterior urethral valve. I won't say not all will die, but let us say there are 10 child with posterior urethral valve. 1/3 of them may survive in the newborn period, but ultimately they will require transplant somewhere around 10 to 12 years, and another 1/3 may die, and so only 1/3 may survive their life. So that is I am stressing this point. And there are other causes of oligohydramnias, renal dysplasia and amnionodism. These are obstetric cause, and leakage of the amniotic fluid. And reverse cause, polyhydramnias. There is increase in the amniotic fluid. There are few causes. Mostly this is associated with GI pathology, like tracheoesophageal fistula, esophageal obstruction, and urological causes mesoblastic nephroma and multicystic dysplastic kidney. So how will you grade the hydronephrosis? The traditional grading system is based on the pelvis AP diameter, which is measured in transverse plane, and what are the factors which affect the pelvis AP diameter. So the gestational age of the mother, hydration status of the mother, as well as the degree of bladder distension. So the traditional classification what we follow is Society of Fetal Urological Grading System. The grading system has been 0, 1, 2, 3 and 4. 0 it is minimal and 4 it is severe. As you can see the picture, grade 1 there is hardly pelvis splitting is there. Grade 2 there is minimal splitting of the pelvis. Grade 3 there is splitting of the pelvis as well as minor calyces are dilated. In the grade 4, apart from all these features, you will see parenchymal thinning. So traditional grading, as everyone is aware, it is mild, moderate, severe according to the dimension. As I mentioned, if it is 4 to 7, it is mild, it is 7 to 10, moderate, it is more than 10, it is severe. Whereas in the third trimester, it is 7 to 9, moderate, it is 9 to 15, severe, it is more than 15. So though you say the parameters, so sometimes you feel like it is more than 15, but actually it is not. See, the degree of the parameters does not reflect the degree of the pathology, and because it does not consider calyceal dilatation. So there is one more classification, Japanese modification called hydronephrosis index, which we do not follow here, but it is mostly mentioned in the textbooks and articles. It also correlates well with SFU grade 3 and 4. So apart from this pelvis AP diameter, there are other sonographic parameters which are helpful in assessing the degree of hydronephrosis. If there is poor corticomedullary differentiation, if there is increased echogenicity of the kidneys, and presence of the renal cyst which compromises the renal parenchyma, so kidney function is already reduced there, and presence of perinephric uroma suggests that there is severe bladder outlet obstruction. The pressure is so much that the kidneys, the pelvis calyces, they are not able to bear the pressure, and one of the calyces has gone and ruptured, forming a urinoma. And fetal bladder length, the degree of distended bladder suggests that there is high degree of obstruction and oligohydramnias. So what are the causes? What is the etiology for hydronephrosis? There are obstructive causes, there are non-obstructive causes. Obstructive causes, most commonly encountered causes, pelviureteric junction obstruction followed by vesicoureteric junction obstruction. It can be because of ectopic ureter, it can be because of ureterocele, it can be because of bladder outlet obstruction in the form of posterior urethral wall, anterior urethral wall, congenital urethral stricture or urethral atresia. Non-obstructive cause, most common encountered non-obstructive cause is vesicoureteric reflex, what we call as VUR. Other causes is primary obstructed megaureter. It can be because of megacalcicosis. It can be because of neurogenic bladder. Apart from this, there are few conditions which actually mimic the hydronephrosis. Most commonly encountered is multicystic dysplastic kidney and peripelvic cyst. So what is the postnatal outcome? So how are these children will going to be after delivery? So the timing of the diagnosis, when the hydronephrosis have you seen in the pregnancy? Suppose if you are seeing in the first trimester, so there is high chance that the baby won't survive, means the outcome is very poor, because earlier the onset means the pathology is more severe. And suppose the hydronephrosis is detected in the second trimester, they are likely to have favorable outcome. 80% of the time the lesion means hydronephrosis will spontaneously resolve. Only thing you have to give some time, periodically follow up with regular ultrasound, and only 5% of them will require surgical intervention. And if you are encountering hydronephrosis in the third trimester, there is highly chance that it is associated with pathology and requires surgical intervention. So what are the imaging modalities available? As everyone is aware, ultrasound is easily available. It is simple, portable, inexpensive, non-radiation. So, but there are few limitations with ultrasound, because anatomical information is very limited. Functional information we won't get. There is one more thing, Doppler ultrasound, though it is mentioned, usually we don't follow practically. Our radiologist only should highlight. Doppler ultrasound, they say there is increased intrarenal arterial resistance, which actually causes decreased diastolic flow. So in all hydronephric kidneys you see, but generally in routine practice we don't see. Our radiologist will highlight at the end of the discussion. And few other investigations, micturating cystourethrogram, because there is 10% association of vesicoureteral reflexes in cases of hydronephrosis. So that's why we have to do MCU, micturating cystourethrogram. And diuretic renal scintigraphy, in case of whenever in doubt, if there is any obstruction or not, you have to go for diuretic renal scintigraphy, because this gives functional information. And magnetic resonance urography, gadolinium enhanced MRI will give good anatomical and functional information, but there are few disadvantages, because it requires sedation and it is expensive and you cannot do every time. So timing evaluation, when to evaluate? Suppose if it is unilateral hydronephrosis, best thing is the first week of life. Why not, someone may ask, why not immediately? Because in the very first few days of life, the child is literally in a relative state of dehydration. Your mother might be coming just out of C-section or normal delivery. Mother nutritional status also won't be up to that mark. So breastfeeding also will be compromised. So if there is no urgency, you better delay ultrasound for 1 week, so that everything will settle. Of course, there are few situations where you have to go for early ultrasound. If the hydronephrosis is bilateral, or in the presence of solitary kidney, or in the presence of bladder outlet obstruction, because in this condition bladder outlet obstruction is a case of relative emergency, where everything you have to act quickly. Means as soon as the child is born, you have to go for renal assessment, do RFT, see whether the bladder is distended, immediately catheterize the child, go for ultrasound. So these are few exceptions. So follow up for unilateral hydronephrosis, do postnatal ultrasound at first week of life, and then you classify whether it's SFU grading 1 or 2. If it is grade 1 and 2, you know it is mild hydronephrosis, just follow up the child and with periodic ultrasound. If it is SFU grade 3 and 4, you have to put the child on antibiotic prophylaxis, and again periodic reassessment in the form of ultrasound is required. Then if you have any doubt, suppose if you are seeing any dilated ureter on subsequent ultrasound, you go for micturating cystourethrogram. Suppose if you have done MCUG and if there is reflex, then it is a primarily case of, it could be a primary VR, you put the child on antibiotic prophylaxis and observe. Suppose there is no reflex, still the hydronephrosis is progressively increasing, then you have to think that yes, there is something called pathological cause. Then you have to go for diuretic renal scintigraphy. So ideal age for diuretic renal scintigraphy is anytime more than 6 weeks, because you want the renal tubules to be mature for the study to be done. So once you are done with diuretic renal scintigraphy, you know whether there is an obstructive pattern or not. Once there is obstructive pattern, you have to go for surgical intervention. If there is no obstructive pattern, then you have to put the child on antibiotic prophylaxis and periodically reassess with ultrasound. If necessary, you have to repeat renal scintigraphy. So when will you prescribe antibiotic prophylaxis? Not all hydronephrosis children require antibiotic prophylaxis. Only children with higher grade of hydronephrosis, SFU grade 3 and 4, and hydronephrosis in the
One clinical question. A 24-year pregnant lady comes, 24 weeks, sorry, 24 weeks gestation pregnant lady comes with scan report of 7 mm renal pelvic diameter.
Okay, sir.
What do you advise?
7 it is whether in the
24
first
weeks.
trimester, second trimester.
24 weeks. 24 weeks.
24 weeks.
Scan done at 24 weeks.
Second trimester. Second trimester, it comes around moderate one, sir, 4 to 7.
Okay.
So it still comes under mild hydronephrosis. So as you say, mild hydronephrosis, second trimester has got favorable prognosis. There is 80% chance that the hydronephrosis tend to get resolved. Only thing is you have to reassure the patient. I mean, you have to reassure the mother.
Next question is?
Next, you have to follow for one more scan.
Next question is, Yen kada?
That is what I am saying, sir. See, apart from the pelvis AP diameter, if you carefully see the ultrasound report, they will mention the size of the kidneys, and you have to look for any thinning of the parenchyma, sir. See, if there is any thinning of renal parenchyma, that suggests that the underlying pathological cause. So usually non-pathological renal parenchyma won't be affected.
So if there is small thinning of renal parenchyma.
If there is thinning of parenchyma, there is likely a chance that PUG obstruction might develop. So you have to say that you have to go for repeat ultrasound after 4 weeks, say around 30 weeks of
30
gestation.
weeks there is no chance of MTP.
No, 30 weeks you have to see whether the hydronephrosis.
24 weeks there is there, I think. Is there up to Supreme Court recent? No.
So 24 weeks it is already 7 mm. So it falls into the mild hydronephrosis. So very unlikely that this child requires surgical intervention.
So it's very difficult nowadays to counsel all these patients.
Very tricky only, sir.
Even bilateral, I asked bilateral only.
We cannot say that there is no problem. Most of the times, 80 to 90% they will resolve spontaneously, but 10 to 20% they may have problem. But this is not a condition where we can do termination. So we have to follow.
Sir, maximum.
In these cases, we
as
simply
you say, suppose the hydronephrosis is not getting resolved. If it is progressive, maximum what will happen? The child will require surgical intervention, which is not at all life-threatening. So that is how you can counsel, sir. So most of the time they are worried that kidney surgery, you will lose the child. It is not like that, no, sir.
Most of the times we are postponing with come after 2 weeks with review scale like that.
Is there any chance of making a intrauterine surgical procedure?
Yes, sir. There are
and save the child.
Yes, sir. Definitely. There are few centers. There are few centers, sir. But there are definite indications. Say, especially one condition I said, bladder outlet obstruction. The degree of distension is more. Oligohydramnios, you are compromising the baby's life. So there is something called vesicoamniotic shunting. Intrauterine procedure is there, but you have to take that procedure with little risk, because there is a chance that there is a chance of preterm labor. There is a chance that you might lose the baby. But yes, there are few procedures. Intrauterine interventions are there, sir. In Kerala, Amrita Institute they are doing. In Bombay also one center they are doing fetal interventions. But it is not very popular because there are few risks involved. Not everyone will be coming forward to accept that risk. Nobody want to lose their child unless it is very precious. So there is 5 to 10% chance that you might lose the baby, and there is chance that the baby can go for preterm labor.
Because it is very difficult to convince the parents that the child will have a normal life, with all the
that is what I am saying, sir. So if it is a
conditions.
male child, the child will definitely cannot have a normal life, sir. Normal life in sense, their bladder function will be compromised because everything is antenatal event, bladder outflexion, posterior urethral. It is not about the valve, sir. Valve is associated with renal dysplasia as well as the dysplasia of the ureter. The bladder dynamics has been altered. See, not only your what you said, detrusal muscle has typically lost its function of distending and contracting. Bladder has gone to a kind of tonic state where the child sometimes holds most of the time urine. They will have increased post-void residuals. So that is why I am saying, sir, if it is male child, if they straightforwardly they can label as, if it is a male child going for severe bladder outer obstruction, better go for termination.
Yes.
Closing session.
Thank you, sir. Thank you, Ravinder. Thank you, Chandrasekhar sir. Madam, thank you. Very good informative presentation. Thank you.